first virtual full mega event of Bombay Spine Society and of course of the nation. We had a super success pre-conference workshop on the 13th, the Sunday of December, where 4,600 plus viewers enjoyed the academic feast served on a platter by Bombay Spine Society, the Young Turks, wherein basic spine, cervical spine, minimal invasive spine, and the soft bones of osteoporosis received a hard talk, and all the panelists took you through a wonderful elucidation of the academic feast that was served and enjoyed by one and all of people across the globe. This, the day 2 of the meeting, which is the main conference today, is the session where we are going to be coming up with further Young Turks coming up with their research papers all throughout the day, followed by the foreign presidential faculty guest lecture session all throughout the day. And Bombay Spine Society is going to all not only learn but share the experiences that we have all learned over these years. We all will be running you through and mentoring things that all the faculty are going to take us through in today's presidential throughout the day. And Bombay Spine Society is with my co-secretary, Dr. Uday Pawar. I take this opportunity to welcome you all to the first BSSCON 2020, and I hope you enjoy the academic feast being served to you from here on. These 2 days are going to be an academic platter served to you. It has got something for everyone, and pick what you like, and you are welcome to join us all throughout the day from now onwards till tomorrow 20th, the evening of the December. Over to you, Uday Pawar, to address the welcome address for all the delegates around.
So thank you, Dr. Vishal. So greetings to one and all from all parts of the world. It gives me immense pleasure to welcome you all on behalf of the Bombay Spine Society to its first ever annual conference. Now, at the risk of repeating myself, I must say again that we are a very closely knit family of stalwarts and young Turks who really take immense pride in our academic programs. I'm sure many of you might have experienced this with us at different national and international conferences organized by our spine team members in the past. We are very happy to have you all, and we are ably supported by the industry and our technical team at VAMA events. As Vishal said, last Sunday, we had a successful full-day pre-conference workshop. And today and tomorrow, we literally have an academic feast from the who's who in spine surgery. Again, we have a heartfelt gratitude to all of you present here and for taking a keen interest in the program. Do visit the trade stalls whenever you get time. And with this, we, myself, Dr. Uday Pawar, and my super energetic friend, Dr. Vishal Kununani, on behalf of the whole Bombay Spine Society family, extend a warm welcome to you all. Over to you, Vishal.
Thank you, Uday. Thank you so much for a warm welcome extended on behalf of Bombay Spine Society. But the meeting will only be open when we have our president, Dr. Sudhir Srivastava, the president of Bombay Spine Society, to deliver the welcome address, please. Dr. Srivastava.
A very good afternoon to all of you. On behalf of Bombay Spine Society, I welcome all the delegates, BSS members, other participants, and our respected patrons. We were eagerly waiting for 19th December 2020 for this history and making day when we are conducting the Bombay Spine Society first virtual annual conference, that is BSSCON 2020. Our very dynamic secretaries, BSS members have worked very hard, and our patrons have guided it very well to provide you the best academic event of the year 2020. My sincere and best wishes for BSSCON 2020. I hand over the proceeding to Dr. Uday.
Thank you, sir. Thank you.
Thank you, Dr. Srivastava, for a warm welcome from Bombay Spine Society. Since the lockdown has begun, I think we have learned how to use technology to our benefit. And we all today here are organizing a fully loaded virtual conference that is not only national, but touching the global heights all across the globe. And this is all possible only because of the backend team of the technology. Backend team and the tech team are the ones who have brought this to this level where we can share all the things from the comfort of home all across the globe. And may I welcome the technical team who have not only made a wonderful virtual auditorium platform for us, but have also created a situation where we all can, from the comfort of home, disperse the knowledge that we have and share and learn more and more. So Vama team, may I welcome you all to please run us through the platform and also show us how to navigate on this platform for all the delegates, please. Vama team.
Thank you, sir. Thank you so much. So I would like to show everyone the video first, and then we will take you through to the virtual platform and we will show you how to navigate. Tech team, can we have the video, please?
I welcome you for the Bombay Spine Society.
Okay, allow me a moment to share my screen and take you through the platform. Okay, so you all must have actually joined the platform by now. So I'll take you to the platform and I'll show you the navigation and how to use the buttons to go to the exhibition hall, e-poster area and session hall. So here we are. So this is the lobby, and as soon as you will be entering the lobby, you will see the information desk. These are the navigation buttons. So there are two ways to go to the sessions hall, exhibition hall, and scientific hall. Either you can click these round buttons, or you can use these icons and go straight to these particular halls. Let's go to the information counter first. So as soon as you're in the lobby, you can actually go to the information counter, and here you can actually find the information of the information related to the conference, some basic guidelines, how to use the platform, how to go to the exhibition hall, how to use the booths button to interact with the exhibitors. And here you will find the agenda for the 19th and 20th. If you have any technical glitch and if you need to reach out to somebody, you can actually come to the information counter. You can do a live chat with our technical team who would be helping you real time. And you have their numbers also, which has been shared on an email ID. Let's go to the lobby and let's check out the scientific hall. So as soon as you reach the scientific hall, you will actually get the agenda of the day. So as we are starting, everything is upcoming. So you will find the agenda button over here, and you can actually play this button to access the session. If you have any question while the session is on, you can ask your question by putting your question over here and submitting it. You can either watch this session like this, or you can go for full screen as well. You play this button to access the session. So let's go to the lobby. So here you can go to e-poster area as well. So we have actually put up all the e-posters, and it will be there for today and tomorrow for you viewing. You can actually go and view any of the e-poster.
Diabetes mellitus, a risk factor for
Now let's go to the exhibition hall and see how the booths are lined up. So this is the expo area. You can actually check the booths by clicking these scroll buttons. So let's go to one of the booth and see how does it looks. So once you are at the exhibition booth, you can actually find these buttons wherein the exhibitor has put up his videos, his documents. You can chat with the booth staff. You can book an appointment if you're busy in a session, or if the exhibitor is busy at that moment, and you can chat with their sales info as well. So let's check out these buttons. So here the staff might have put their company profile. If you want to watch, you can watch by clicking here. Or if you want to watch later, you can put it in the briefcase and you can watch it after the conference. Here you will find the document info of the booth staff, their company profile, their product profile, brochure and catalog. If you want to chat with the booth staff, you can actually click this button and you can chat with these booth staff. So you can either do chat, you can do audio call, and you can do video call as well. If you want to book an appointment with them, like if you are in a session right now, if you want to book an appointment during the breaks and maybe tomorrow, you can actually select the date and select the time, and you can send that information to, and if you want to put a message also, you can put the message and you can send it to the booth staff. They will revert with the confirmation. And if you want to directly go to the information of the sales staff, the regional manager or VP or whosoever it is, you can actually chat with them. You can do a video call and you can download their business cards. So this is the functionality of the booth. So we would request you all to go to the booths and in network with the booth staff and encourage them. So this is all about the platform. Thank you, and I hope you have got a clarity of the platform, and wish you a very successful and knowledgeable day ahead. Thank you.
Thank you, Neetu. Thank you, Wama team. So I hope that it is a clear understanding of the platform, and we are all set to handle all the technical glitches. Just to take you and run you through the academic program that is to be served in coming 2 days from now onwards. Today, we have the youngsters as the opening batsmen, and I'm sure they are not going to behave like the second innings of the Indian test that we just saw this morning. And I'm sure this is their first inning, and they're going to rock like what India did in the One Day 2020 series also. So the youngsters are going to come up with the free research paper session starting 3:30 p.m. onwards. And there are 15 papers that are going to come across, following which we have presidential foreign faculty guest lecture sessions. We are going to have some rocking sessions on spine trauma, where who's who in spine trauma are going to be on the podium to share their experiences about the past, present, and future of thoracolumbar spine trauma and cervical trauma, which only enters into the future of spine surgery, which is minimal invasive spine surgery. And the fathers of MIS from across the world, Dr. Larry Koo and Dr. Kim, both tubular and endoscopic versions of MIS, past, present, and future, are going to be discussed later, only to end the day with a long session on spine deformity, where A to Z, we are going to question the fathers of spine deformity classification, whether they have come up with the most validated classification systems or not. and we are going to listen to the idiopathic and other versions of scoliosis, followed by high-grade listhesis by Shuffleberger, who's going to end the session today. Today we end at 9 p.m. only to begin as early as 9 a.m. tomorrow morning, where we start our day again with very nicely integrated sessions on high-grade spondylolisthesis, followed by multi-level cervical myelopathy, and the nuances will be discussed in a more interactive fashion with a case presentation and only very, very few lectures, followed by didactic discussion coming up forward from the speakers tomorrow. We enter into the session on COVID-19 and the change that it has brought, opportunities and crises that have come across in the last 8 months, being discussed by none other than Dr. Abhay Nene, Dr. Amit Sharma, and a wonderful faculty from across the country, including Dr. Rajashekharan, Dr. Srivastav, Dr. Ram Chadda. What is the future in COVID times for all the spine surgeons, orthopedic surgeons will all be discussed. And then we enter into the presidential oration session, which will be headed by Dr. Srivastav, sir. And also we have two wonderful orations on spinal tuberculosis tomorrow afternoon, starting 11:30 a.m. onwards. The early part of the afternoon will see the best paper award session. We have had tough time to choose the best out of the best, and 10 best papers will be at display on an award session for a fellowship at Bombay Spine Society. Best poster session follows. Again, we had really tough time to choose the best out of them. We have a best video session, and the best publications in spine from across the India will be displayed in the later part of afternoon. We enter into the session with spine deformity, where idiopathic rigid curves will be discussed in detail by the faculty here. And then we'll have another intriguing session on minimal invasive spine surgery and safety in spine surgery, a detailed didactic discussion on how to enhance the safety in spine surgery to end our day later in the evening tomorrow. With this program, we have not only got wonderful audience, but also we have wonderful faculty from across the globe. And also to thank all these faculty members who have come one and all from across the globe, from US, from Japan, from Korea, and various other parts, joining us to share their experiences. All this has been possible not only with the help of tech team, but also all our academic partners to whom we express our heartfelt gratitude. And I request all the delegates to at least take out some chance to go ahead and visit the stalls technically created by the tech team, where all the sponsors and all the academic partners there are there to showcase their products. You would like to interact with them there. We also have these academic partners in an expedition tomorrow from 2 o'clock to 3 o'clock live, coming to show us what's new in industry to keep us engaged with them. I would now welcome Dr. Uday Pawar to please declare the Congress open and start the first opening session. The opening batsmen are already waiting and ready to go. Uday, over to you.
Thank you, Dr. Vishal. I actually request our chairman, Dr. Sudhir Srivastav, sir, to open this Congress, and then we start with the first exciting session of the fourth, that is the free papers. Dr. Srivastav, sir.
Yes, I'm here only. Yeah, tell me.
So with your permission, we'll start the free paper session, sir.
Yeah, please, go ahead.
Thank you, sir. So I request the Bombay Spine Society members, Dr. Raghu Prasad Verma, Dr. Tushar Rathod, Dr. Kshitish Chaudhary, and Dr. Devesh Dholakia to please chair the session and start off with the 15 excellent papers that we have lined up. Over to you, Dr. Verma.
Am I audible? Uday, Vishal,
yes.
am I audible?
Yes.
Yes, you're audible.
Yeah, sure. So thank you, Vishal, and thank you, Uday, and thank you, Dr. Srivastav. We all know that Bombay Spine Society sets high standards in academics, and what better way to start off this conference, much awaited, than starting off with what we call as pre-paper sessions. We all know that it's this session through which that we learn innovative ideas, innovative thought process. And it's my sincere request to all these speakers from here on to be ready and finish on time, so that we have enough time to start off the discussions and have a proper endpoint to all the talks that have been discussed here. I also want to invite Kshitij, Tushar, and Devesh as my co-chair. And without wasting any more time, let's have the first person, Amit Surushe. He's going to tell us about what his long-term outcomes of anterior reconstruction in thoracic tuberculosis, whether through a direct anterior approach or a posterior approach. Do we have Amit here? Can his talk start off?
Yes, sir. I am here, sir.
Sure, go ahead.
Tech team, share the video, please.
Good afternoon, everyone. Myself, Dr. Amit Surushe, presenting on comparative analysis of long-term outcome of anterior reconstruction in thoracic tuberculosis by direct anterior approach versus posterior approach. It was first described by Sir Percival Pott. Thoracic spine is the most commonly affected areas, affects more commonly the anterior part of vertebra and causes collapse, leading to kyphotic deformity and neural compression. The goals of surgery in Pott spine are adequate debridement and decompression, maintenance and reinforcement of stability, and prevention and correction of deformity. The selection of whether anterior or posterior approach for surgical treatment of thoracolumbar tuberculosis is still a matter of debate. Anterior and posterior approach used for reconstruction have their own pros and cons. The study was retrospective study, which was conducted over 245 patients of confirmed cases of thoracic spine tuberculosis. Patients with Frankel grade A and B are considered for immediate surgery, whereas Frankel grade C, D, and E are put on bed rest and anti-TB chemotherapy. Comparison was done between the two approaches using various factors like surgical time, blood loss, length of hospital stay, neurological recovery, correction of kyphosis, maintenance of correction, time for fusion, grading of fusion using Bridwell's grade and complications if any. Patients were assessed clinically and their neurology was recorded using Frankel's grading system preoperatively and were seriously assessed at immediate post-op 1, 3, 6 months and 1 year. Patients were assessed radiologically using X-ray, MRI and CT scan taken preoperatively, and X-rays were repeated immediate post-op at 1, 3, 6 months and at the end of 1 year. Radiological parameters taken into account were number of vertebrae involved, level of instrumentation, correction and maintenance of kyphosis as measured by Kopp's method, fusion grading as per Bridwell criteria. Surgical techniques. This is an X-ray in AP and lateral view in a case of D8 and D9 Koch spine via versatile approach. Anterior reconstruction was done with the help of bone graft and posterior reconstruction and stabilization was done with the help of heart shield and sublaminar wires. This is an X-ray in AP and lateral view in a case of D10, D11 Koch spine operated via posterior approach, and anterior reconstruction was done with the help of bone graft and posterior reconstruction and stabilization was done with the help of pedicular screws and rods. Results. Total number of patients operated were 245, out of which mean operative time in anterior approach was 6.8 hours and in posterior approach was 5 hours. Mean blood loss in case of anterior approach was 1.6 liters as compared to 1.1 liters in posterior approach. Mean pre-op kyphosis angle was 41.154 degrees in anterior approach as compared to 34.863 degrees in posterior approach. Mean post-op kyphosis angle was 9.498 degrees in anterior approach as compared to 11.286 degrees in posterior approach. Correction achieved via anterior approach was 77.467% as compared to 67.216% in posterior approach. Mean time for fusion was 4.69 months in anterior approach and 6.34 months in posterior approach. Conclusion: decompression and deformity correction are the only answer to prevent progression of neurological deficit, kyphosis, and late onset paraplegia. Single stage anterior reconstruction and posterior stabilization via anterior approach allows for thorough debridement, neural decompression, and much better anterior column reconstruction and deformity correction under direct vision than posterior approach. Though posterior approach is easy to master, but the results shown by anterior approach cannot be overseen, we would like to conclude that better functional outcome and significantly better kyphosis correction by the anterior approach are strong pointers favoring the anterior approach. Thank you.
Thank you, Amit, for that talk. Before anyone starts off with some questions, can I ask you a question, Amit?
Yes, sir. Yes, sir. You can. Yes, sir.
Yeah. So one question I wanted to ask was the series, because you have a good number at 245 cases. What was this? Was it statistically significant when you actually did you have a statistician?
Yes, sir. It is study was statistically significant
as according to
deformity correction.
It was significant.
Yes, sir.
The second important thing I wanted to ask you was if you pick two things which you felt was better in the anterior, two things that you want to say as compared to doing everything from behind, which is what a lot of us want to do nowadays.
Yes, sir.
can you think about two things that made you feel that it has a versatility? What is the two things that are good in that approach?
Sir, one is deformity correction, sir.
Okay.
And second one is, sir, easily accessible for decompression and debridement, sir.
Okay. So do you think the fusion rates are also better in any way? Do you have a difference? Did you study the fusion rates between the two?
Yes, sir. Fusion rates are better in anterior approach, sir.
Okay. Last, one of the worries for us is anterior approach, guys. I mean, is that you have chest complication, use of ICD. Did you have any of those pleural tears? Anything that you had a problem with? Because it's a pure thoracic
yes, sir.
tuberculosis that you're talking.
Sir, out of 118 patients operated via anterior approach, so we have, sir, 17 complications, sir. Only three of them are pneumothorax, sir. Have pneumothorax. Only 3 cases have their pneumothorax.
So that's a very significantly low amount according to you.
Yes, sir. Yes.
But they are doing
Any other questions?
versatile approach. Is not a classic anterior approach, is it not?
Yes, sir. Study was done using versatile approach, sir.
Okay. So it's not a classic anterior approach.
No, sir. Not a classic anterior approach.
Do you use cages or graft or use a combination, or how is it? Or reconstruction?
Sir, reconstruction was done using, sir, iliac crest bone graft, sir.
Both for anterior and posterior, both.
Yes, sir. Yes, sir.
Okay. Thanks, Amit. We'll go on to the next topic. Sutej is going to tell us about some minimally invasive stabilization with cement augmentation for osteoporotic fractures. Sutej, are you ready?
Yes, sir.
Yeah, go ahead.
Good afternoon, everyone. My name is Sudhir Peshawar, and my topic is short segment minimally invasive stabilization with cement augmented French-thread pedicle screws and vertebroplasty in osteoporotic compression fractures in thoracolumbar spine. We aim to evaluate the clinical and radiological outcomes of short segment minimally invasive percutaneous stabilization with cement augmented screws and vertebroplasty for treatment of osteoporotic compression fractures. We included severe osteoporotic patients with worsening back pain and neurological impairment. Age of these patients was more than 75 years and having DEXA scan of T-score less than -2.5. We also included patients who had failed the average conservative trial. Exclusion criteria involve no neurological impairment, age less than 75 years, patients having pathological fracture or osteomyelitis, and patients with near normal T-scores for VMT. Out of the 30 patients we treated because of vertebroplasty and MIS between Jan 2016 and Jan 2019, 11 patients were more than 75 years of age and met the inclusion criteria. We clinically evaluated using the VAS scores, the ODI scores, and the severity of the neurological deficit was assessed using the Isha impairment scale. Radiological evaluation was done with the help of calculating the local kyphosis angle, the retropulsion, and this spinal canal encroachment. Greater than 25% of retropulsion and the encroachment was regarded as significant compression. Anterior vertebral height loss as was compared to the normal height, and the restoration angle was also measured after the surgery. In the surgical technique we used, the fracture was reduced by proper distraction applied between 2 screws as necessary before vertebroplasty. Anterior column support was provided by the vertebroplasty cement, and decompression was done using mini-midline incision in cases with more than 25% of canal encroachment. Correction of kyphosis and good restoration of vertebral height resulted in indirect decompression. This is an image showing the surgical technique we used, and the screws we used, the cementing technique we used towards the right side, and the intra-op images and the CM images towards the left side. This is a case 1 of 78 years old wheelchair-bound female with HSC neurology. In this, we have restored the vertebral height and the local kyphosis angle. The vertebral height is restored from 10 mm to 25 mm, and the kyphosis angle corrected from 22 degrees to 3 degrees. This is a similar case treated with vertebroplasty and cemented augmented pedicle screws in an osteoporotic compression fracture. We found that the most common level involved was D12 followed by L1. There were 4 males and 7 females in the study with mean age of 71 years. Average duration was 130 minutes and the mean blood loss was 80 ml. Mean follow-up period was 28 months and average hospital stay was 4 days. We found out that VAS significantly dropped from preoperative 9 to postoperative 2 and 1 at 1 year of follow-up. The ODI scores improved from 71 to 29 at 1 year of follow-up, and average local angle of kyphosis was 18 degrees pre-op decreased to 6 degrees at postoperative period. The vertebral height was 10 mm, increased to average post-op vertebral height of 22 mm. Patients recovered neurologically and improvement in Asia scores was also seen. We like to conclude that short segment stabilization can successfully be achieved with cement augmented screws and vertebroplasty by MIS technique for patients with osteoporotic vertebral fractures. MIS stabilization with or without local decompression and vertebroplasty is well tolerated with excellent results. Thank you.
Thank you, Sudesh. Anybody has some questions?
Sudesh, I have a question for you. Did you encounter any complications during your series with this particular, like cement leakage or any other issue?
No, sir. There was no such complications encountered in my series.
And how long do you have follow-up these patients?
1 year of follow-up, sir.
Okay. Okay.
Also, Sudesh, if I can ask you, if I read it correct, you do how many levels of fusion above and below with the cement augmented screws?
So 1 above and 1 below, sir.
So have you had a problem anywhere where that fell short? You've had adjacent level fractures, because we all know osteoporotic.
No.
Before vertebroplasty or after vertebroplasty?
Before vertebroplasty, sir.
Okay, so there are no more questions. We can have the next person on. Tankeshwar Borwa, is he around?
Thank you, sir.
Are you around, Tankeshwar? Tankeshwar Borwa?
I think we can skip to the next one.
No, can the Vama team play the program?
Everyone.
Of Tankeshwar Barua.
Yeah, Tankeshwar. Okay, go ahead.
It is indicated primarily for biopsy when there is doubtful diagnosis. Otherwise, if there is neurological deficit like no improvement of neurology or the new onset of neurology on ATT and severe instability, patients with spinal deformity, yes, there are some relative indications. It is primarily can be addressed by anterior approaches like thoracic thoracotomy, thoracoscopy approaches. One can go for combined approaches, posterior approaches, namely transfacetal, transreticular, costotenthysectomy, lateral extracavitary approaches. Sometimes we can go for laminectomy. In lumbar spine, it can be addressed by transforaminal or anterior retroperitoneal approach. But the current trend is posterior along surgery for thoracic and thoracolumbar tuberculosis. Yes, according to the pathology and destruction, we can address according transfacetally, transreticularly, costotenthysectomy or lateral extracavitary approach. These are the surgical steps. We can nicely decompress the spinal cord by costotenthysectomy or transpedicular approach, and in it we can go for anterior reconstruction. Sometimes it can be combined with laminectomy if there is some spinal cord tumor syndrome or posterior LMS involvement with compressing the cord. We usually advise all the patients for dose center, and chemotherapy is given at least for 12 months and it is extended up to 18 months depending on case-to-case basis. We followed all patients at every 3 months and after completion on treatment for at least for 2 years. Supportive treatments are very, very essential for this medical tubercular disease. We took all the patients retrospectively. We primarily aim to see the decompression and neurological improvement. We included 34 patients retrospectively in this particular study. All the patients improved to a functional grading except in 3 patients, one there is no improvement. 1 patient died after revision surgery because of some medical conditions. This is 1 patient grade 4 paraplegia. We addressed by transreticular approach along with posterior fixation. Another 1 patient with mild deformity. We did laminectomy here. This is one patient on middle part regime, no improvement. So we went for posterior lateral decompression, debridement, reconstruction, and posterior fixation. Patient improved and could walk. So most of the literature, they had shifted to posterior decompressions, and studies are showing that they are getting equally good results in comparison to anterior surgeries. Anterior decompression was once very popular surgery when there is no intent of implant, or people were scared putting implants, but nowadays it is done in a very limited indications. Anterior surgeries definitely, though it is better for debridement of prevertebral interspinal focus of infection, but it is definitely with some complications. To summarize, primarily a medical disease, so anterior tubercular treatment is the mainstay approach, but when indicated, we can go for posterior decompression as it is a single stage procedure. The window can be tailored according to degree of destruction. It is adequate for canal decompression and debridement, adequate for abscess drainage, can be combined with posterior transreticular fixation and fusion, anterior reconstruction with bone graft with or without case. Thank you.
Questions from the audience?
So my question to him is, what were the complications? You skipped past that part quite quickly. So what were the complications that you encountered in your series?
Dr. Tankeshwar, are you there?
Yes, to unmute the speaker. Dr. Tankeshwar, unmute your speaker.
Actually unmute. Dr. Tankeshwar?
I think we can move ahead.
I think
I guess so. Okay. Is Dr. Satyendra, can we have Dr. Satyendra's talk, which talks about pedicle screw fixation in thoracolumbar fractures. He's compared between navigation screws assisted with navigation and free hand. Please go ahead. Yeah.
Good morning, all. Hello, I am audible to you?
Yes, Dr. Fulgale, you are audible.
Yes, sir. Good morning, all. Thanks for giving me the opportunity in conference. This is the study, myself, Dr. Fulgale from Medical College, Raipur, with our co-presentation, retired Professor Mukherjee Sahab and Dr. Dao sir.
Next.
Dr. Fulgale, do you want to share your screen? Because we have the presentation.
Yes, madam.
So, so should we take off the presentation? You will share your screen?
No. You play the recorded presentation, please.
Okay.
The screenshot will go live.
Okay. So, next slide, please.
So the overall the spine injury is 6% of all the trauma, 65% occur due to the fall from the high road accident, and 90% of the all thoracolumbar injuries are more lumbar region is more common in 90% of the all vertebral fractures.
Next slide.
Next slide. So we have done CT-based navigation. This method involves the preoperative CT scan registration step to relate the 3D virtual model and actual model in operation theater. Next slide. So we are all aware of the basics of the navigation. This is an important tool, that is the infrared camera, which gives the idea about the picture of the navigation. Next slide. There are silent features are the virtual fluoroscopy display predict the position of the surgical instrumentation and the implant related to the stored images. Next slide. Again, the silent image can be readily updated after fitting the optical tracking array, both C-arm and the patient. It allows tracking of the bone and the fracture. This slide shows the direction, giving the direction of the for the pedicle screw fixation. Next slide. This is the study, very popular study in Indian Journal of Orthopaedic by Dr. Rajshekharan and Dr. Ashish Jaiswal from the Coimbatore, India. They advocate the navigationally useful advent during stabilizing challenging spinal trauma, rendering feasibility, accuracy, and safety of pedicle screw placement in difficult situations. Next slide, please. Another study from the China gives the again advocated the pedicle screw placement increases the accuracy, reduce the surgical time, and perform safely. Next slide. This is the important classification given by the Lurch and Wisner in 2011 European Journal of Spinal upon the encroachment. Pedicle screw could not be visualized and minor screw trajectory was less than 3 mm outside the pedicular boundaries. And the moderate penetration screw trajectory was 3 to 6 mm outside the pedicular boundary. And severe penetration screw trajectory was more than the 6 mm outside the pedicular boundaries. Next slide, please. These are the observations, as far as the accuracy is concerned in conventional method, that is without navigation 81% and with navigation is the 92%. Next slide. These are the various study by the Carbon et al., Sijaz et al., and the Yasser Alam study is very important. Without navigation is 89%, and with again in the Yasser Alam study, the 99% accuracy of the pedicular screw fixation. And in our study, we have a 92% and confirmed 84% by the non-navigation, and with navigation 92%. Next slide. So these are the classification given by the Henry class again for the penetration: grade 1 no bridge and grade 2 lateral bridge, grade 3 is lateral with anterior bridge, grade 4 is the medial inferior bridge, grade 5 is the bridge for revision. Next slide, please. These are the certain cases of fracture of the L1. Next slide. This showing in the navigation that is give the direction of the pedicular screw fixation, and this particular is the gives the idea when it comes in the middle of the bull-like preparation. Next slide.
You have 30 seconds, sir. Please. 30
this
seconds.
is the intraoperative photograph. Next slide. This is CT scan picture. Next slide. This is a clinical photograph. Patient is walking with physiotherapy assisted walking. Next slide. This is second case of the fracture spine. Next slide. This again gives the this particular should be the in the center, but giving the idea of the particular fixation. Next slide. This is the CT scan picture with the pedicular screw fixation. Next slide. This is a clinical photograph of the patient. Next slide. Next slide. This is our study and conclusion with high accuracy and less radiation to the doctors and OT staff. Next slide. Take home message is required a learning curve for the computer technique to study and to learn it with the free, as compared to the freehand technique. Need further training to get more better results. Next slide. Thanks.
Thank you very much, Dr. Fuljale, for a very nice presentation. And we now move on to the next presentation in the sequence, please. To the team, I would like to say
for management of neglected
live presentation. Please spray the recorded presentation of every presenter.
Sure, sir.
It's the cervical dislocation. These are rare injuries which most of the times are diagnosed and treated in the initial treatment and acute setting itself. But some of the time they are missed because of misinterpretation of the clinical signs and radiograph in the initial assessment. These missed injuries after a period of 3 weeks are termed as neglected. The fibrosis that develop further prevents close reduction. These are unstable injuries with further risk of neurodeficit. Multiple approaches are required, which further makes it difficult and challenging, and there are no clear-cut guidelines yet presented. The author has successfully managed such cases in single stage by 2 approaches. The aim of the study was to discuss the operative sequence for its reduction and stabilization and to assess the clinical outcome. It was a prospective case series of 5 patients. Only the bifacetal and neglected cases were included. Patients with associated fractures and associated injuries were excluded. Mean delay was 9.8 weeks. Average age was 47.4 years. And minimum follow-up was up to 1 year. In clinical presentation, 3 patients had myelopathy, 1 patient had radiculopathy, and all the 5 patients had cervical axial pain. So in order to achieve reduction, an attempt for close reduction under anesthesia was given, which failed in all the 5 patients. So primarily a posterior approach was selected, soft tissue release was done, bilateral fascectomy and bilateral foramenectomy was done. A polyaxial reduction screw in the cranial vertebra and a standard lateral mass screw in the caudal vertebra were inserted. A pre-lordotic rod was then fixed in the caudal vertebra, which acted as a fulcrum for the further reduction. Because of the anterior listhesis, there was an offset between the screw head and the rod. As the set screw of the cranial vertebra was tightened, a reduction was achieved in a controlled and safe manner. This was then checked under the guidance of fluoroscopy. Secondary and anterior approach for discectomy fusion was used, which led to a circumferential fusion. This was the post-operative protocol. The neck pain was assessed by VAS and NDI. Sagittal alignment was assessed by sleep angle and spinal laminar line. Neurology was assessed by modified Joe score. Perioperative blood parameters were also assessed and recorded. So in results, good anatomical reduction was achieved post-operatively, which was confirmed on lateral X-ray and which was well maintained till the final follow-up of 1 year. Because of which neck pain, which was assessed by VAS and NDI, was also significantly improved at 6 weeks and 1 year follow-up. There was complete recovery of neurology at 1 year follow-up, which was assessed by modified Joe score. So the perioperative parameters like blood loss, total operative time, and hospital stay, which were recorded, were lesser as compared to the 5-stage surgery described by Hassan, 3-stage surgery described by Ronald, and the 2-stage surgery described by Liu et al. So the all cases were managed in single stage and 2 approaches. Primary the posterior approach for complete reduction, secondary and anterior approach for circumferential fusion. Neuromodulating signals were intact throughout the procedure. No complications were noted. Complete fusion was achieved in all the cases, which were confirmed on serial radiographs. So in conclusion, neglected bifacetal cervical dislocation are difficult to reduce. The role of closed reduction is limited in such cases. The ultimate goal should be always anatomical reduction and stable fusion. Fascectomy and reduction screw helps in safe, strong and controlled reduction. So a single stage posterior anterior approach is sufficient for its management. Thank you.
Thank you, Dr. Jayesh. We'll invite questions. If there is one question from Dr. Zaveri, which company has cervical reduction screws?
So the company which
did
was
you
used was
specially get these made?
the Technoshine company, sir.
Okay. So I have one more question. If you are seeing neglected dislocations, how often have you found that only a posterior release would be sufficient? Because sometimes these anterior structures also get stiff when they get they are not reduced in time. So just posteriorly reducing it without an anterior release, is it did it work without any hassle, or you had to do something for the anterior stiffness?
So thank you, sir. The posterior reduction was done and was achieved most of the time by a reduction screw, sir. But our aim was to get a circumferential fusion. So for that reason, we went anterior to get the achievement of the circumferential fusion. The main reason for going anterior was the circumferential fusions.
So you did that second stage, right? You didn't do that as the first stage.
Okay. Yes, sir. First stage was posterior, second stage was anterior in the same settings.
Dr.
What about the disc getting displaced?
Had a neurologic deficit.
Sorry, sir.
How many of your patients had a neurologic deficit post the injury?
Post injury, there was no deficit, sir. But one of the patient was having a paraparesis, not paraparesis, so neurology of C5 deltoid palsy, sir.
So what was
It was recovered after a period of six weeks.
10 weeks post injury. Patient has only neck pain, no neurologic deficit, no radicular arm pain. Then why can't you think of doing an in situ fusion? You would still get a result without exposing the patient to a double surgery and the risk of neurologic deficit while reducing the spine.
Definitely, sir, we can do that. But the patient, as I have mentioned it, all patients are having a cervical axial pain. So maintaining the reduction was the prior motive for that.
Reduction with compression of the nerves. So reduction will not help. Even if you had fused in situ, the axial pain would have been relieved.
So, but none of the patients were having fusion in our cases. So if there was a fusion, then we might have thought of leaving it and just fusing it in situ. If there was a fusion, but there were all unstable injuries, sir.
All right. Thank you.
Thank you, sir.
So we'll invite the next speaker, Sayajot Raut, and he's going
My topic for today's presentation is learning curve of minimal invasive 7C2 transarticular screw fixation vistas, a learning curve of over a period of 5 years. So transarticular screw is a recognized method for stabilization. It gives us robust and strong fixation, higher fusion rate, and avoid post-op immobilization. Minimal invasive surgery in transarticular screw minimizes surgical trauma. It gives a smaller incision. Interspinous ligament capsule of C1, C2, C3 joint is not touched. Use of allograft and avoids use of wires. But what are the challenges in MISTAs? They have steep learning curves. They require familiarity with the microscope. Surgical anatomy planning should be done. Radiologically, pre-op anatomical planning should be done, and there should be proper screw placements. So now understanding the learning curve helps in reducing the steep curve for beginners, delineate problems faced in early cases, understand predisposing risk and salvage complications, reduce complication rate, and improve overall healthcare. So now conventional and MISTAs are different. Conventional has muscle dissection, they have greater visualization of anatomy, direct visualization of structure, and they do posterior wiring. MISTAs has minimizes tissue injury, deeper tissues are less exposed to organisms, less post-operative pain, early ambulation, shorter hospital stay, and early return to work with small incision. So now what are the aims and objectives to learning curve of MISTAs in atlantoaxial instability based on evaluation of surgical and clinical parameters? Also to challenges encountered in long series of patients and to overcome them. 84 patients were taken from the year 2009 to 2014, single surgeon, single institute for the follow-up of 2 years. Mobile and reducible C1, C2 instability were taken without any basilar invagination. They were divided into 4 equal quartiles, 21 each, and each group control for the prior. These were the parameters which was used. Now, what was the procedure? Procedure was done by GA was given, prone position was given, the head was fixed with the Gardner well tongs, incision was taken over C1 and C2, exposure was done from the inferior arches of C1 and C2, subparietal dissection was done, C1 and C2 joint was opened by McDonald's and Penfield and curated. Entry point was made from the 1 centimeter lateral to T1 and T2 midline region, and entry point on C2 bone was made 2 mm just medial to the line drawn from the medial border of the pars, just lateral to the spinous process. Retrograde entry direction was taken from lamina pars, passage joint of C1, C2, lateral mass of C1, anterior arch of C1. Drilling was done to the anterior cortex of C1. Hole was typed, screw was passed, and allograph was placed. These are the parameters which we saw from first quartile to fourth quartile. All the 4 parameters, including surgical time, incision size, guide wire migration, and broken guide wires, have decreasing trend. But surgical time in second and third quartile have significantly statistically different. The surgical time is less in second, third quartile. Dorsal burst of screw in C2 pars, blood loss, dural leaks, and vertebral artery injury all also on decreasing trend. Statistically significant data was found in blood loss in second to third quartile. Pre-op was post-op was ODI and MJO show significantly better from pre-operative studies. So to reduce learning curve, we have to have what are the problems which we face is improper positioning, inadequate reduction, guide wire migration, improper trajectory, C2 pars burst, and vascular neurological injury. So what we conclude from this study is novice surgeons should practice on cadavers and bone models. 40 to 60 cases should be must to mastery. People should be familiar with the instrumentation like the microscope. There should be detailed radiological investigation preoperatively. Communication should be good with the surgical team, and there should be defined expectation from the radiological technician. Thank you.
Any questions from the house?
There was a mention of a complication of a broken guide wire. So how did you do with those cases? Did you were you able to remove them all the time, or did you salvage? How did you salvage it?
Yes, sir. The broken guide wire which was there, fortunately we were able to, we were able to remove it, sir.
Do you think it is more frequent with the MIS one?
No, sir. So the guide wires is necessary in the screw fixation because the screw won't go without the guide wire. So the incidents are same in open and MIS.
Okay. If there are no more questions, can we go on to the next talk, please?
Hello everyone, this is Dr. Amir Ranikar. I'm a fellow in spine surgery. The topic for my today's presentation is learning curve of microendoscopic decompression for PIVD patients. Now, disc herniation with radicular pain usually comes with a protocol of conserving disc for 4 weeks. If conservative treatment fails, we usually go for surgery, which can be the open or MIS. Success rate of discectomy is quite variable in sciatic pain, which varies from 50 to 98%. Microendoscopic discectomy is such a refinement of microlumbar discectomy. Now, microendoscopic discectomy comes with some challenges, like steep learning curve. It requires familiarity with microscopic techniques. Surgical anatomy and radiographic anatomy should be well known, and over-the-top decompression technique. Understanding the learning curve helps in reducing the steep curve for beginners. It delineates the problems faced in early cases, understands predisposing risk and salvage complications, reduces complication rate, and improves overall healthcare. If we compare microlumbar discectomy to that of MLD, we'll see that in traditional MLD, there was greater visualization of tuberous sac, direct visualization of structures, and optimal angle for disc removal. Whereas in MLD, there was minimized tissue injury, less post-op pain, early ambulation, and a shorter hospital stay, with the early return to work with smaller incision. Aims and objectives. In this, a learning curve of tubular MLD in PIVD is based on evolving surgical and clinical parameters, as well as we saw the challenges encountered in the long series of patients. In our study, there were 120 patients who were operated by a single surgeon in a single institute, most common level being L4-5 and L5S1, which were equally distributed in 4 quartiles of 30 each. Each consecutive group served as a control for prior. Parameters which were seen were demographic, surgical parameters including time, blood loss, knee injury, clinical outcome based on VAST and ODI score, technical problems, clinical complications like infection, neurological injury, and dural tear. The procedure was like the patient was under GA and prone position. 18 size needle was inserted with infiltration by 10 cc normal saline. A 1 centimeter incision was given lateral to midline at spinal lamella junction. Then guide wire was inserted over it. Serial dilators were placed over the guide wire, and final tubular retractor of 18 to 20 mm was stopped. Laminotomy was done into the ligamentum flavum under microscope. Thecal sac and nerve root shoulder were retracted and disc was removed. Now coming to the results, there was significant difference in the pre-op and post-op VAS score as well as ODI score in each quartiles. Similar to that, the complications which were seen in first quartile were not much there in second, third, and fourth quartile, including the guide wire migration, post-op leg pain, dural tear, and tube docking related problems. The surgery time was also significantly reduced in second quartile as compared to first quartile, and same goes for the blood loss. Now, to reduce the learning curve, infiltration with normal saline must be done, which gives the easy dilatation of muscles. There must be no guide wires which may cause dural injury. Tube should be in line with the center of disc. The tube docking should be done at spinal lamina junction. 2 AP lateral radiograph should be obtained. Contralateral lateral decompression should be done first, and overhanging of tissues must be avoided. Now, coming to the conclusion, for the novice surgeon should practice on cadavers and bone saw models first. 50 to 100 cases must be done to obtain the mastery of technique. There must be familiarity with instrumentation and good communication between the surgical team, and there must be defined expectations for radiology technician. Thank you.
So we can invite questions. I can ask the first question. What was your tube size? Did you find that over a period of time your tube size you could get it with a smaller and smaller tube? Or if somebody's starting out, what would you recommend their starting tube size should be?
Sir, 20 mm should be.
Sorry?
Should start with 20 mm tubes. Over the time, hello?
Yes.
Sir, starting tube size should be 20-22 mm. And over the time, as experience gains, we can switch over, but it wasn't, there was no parameter evaluated for regarding tube size, honestly.
Okay.
It should be started with 22.
You always use expandable or?
But 18 mm can be used later, once experience is gained. So it is never expandable.
How did you account for like the discectomies? Like, were they all throughout your, were they similar kind of disc herniations? Like if they are extruded or migrated, would your thing change in any way?
So
the way you approach them, or
this study was done on the paracentral
so all
disc
were
only.
paracentral. None of them were migrated or like huge,
Yes,
large
of these
central
conditions.
discs. So none
No,
of
no,
them
sir.
were huge, large central discs. Okay.
So there were large central discs, but not bilateral discs.
Okay.
It was mostly on paracentral ones.
Okay. Are there any questions more?
Oh, I think we can move on the next paper.
So we can move to the next paper, please.
Good afternoon, everyone. In the next 4 minutes, I'll be talking about novel head positioning method for spine surgeries, a simple and cost-effective way. Most of the spine surgeries require prone positioning of the patient. Positioning head and neck of the patient has pivotal role for optimal operating outcome and minimizing position-related complications. Improper positioning may cause intraoperative surgical difficulties and position-related complications like pressure sores, conjunctival and corneal abrasions, post-operative vision loss, ophthalmoplegia, glaucoma, and difficult access to anesthetist for endotracheal tube management. So we present our novel method in head positioning and its application. It requires garden well tongs, cardboard boxes of drains or syringes, cloth sheet, and if cervical traction is also needed, then Balcom beam and weights, along with the routinely prone positioning devices like bolsters. So we first take two cardboard boxes of either Romovic drain or syringes and completely pack it with a tightly rolled cloth sheet as shown in the video. We then seal both ends of the boxes with Dynaplast. They are then placed in front of the bolsters on two boxes and as shown in the picture. Head of the patient lies in the space between the two boxes and ends of the garden well tongs applied to the head of the patient is supported over the two boxes on either side. Skeletal cervical traction over Balcom beam can also be given as and when required. So this is the final positioning showing two cardboard boxes placed in front of the bolsters and ends of the garden well tongs supported over the two boxes. And Balcom beam and weights can also be seen and can be applied as and when required. So these are the intra-op pictures showing patient's head and neck positioning using our technique. On the right image, you can clearly appreciate the free access to eyes and endotracheal tubes. This is the intro picture and final positioning of the patient. The advantage of our technique is that it does not require any special attachments, no need of any additional equipments or devices, can be used with vertical or horizontal bolsters, and can apply or release skull traction. There is completely free eyes, easy access to endotracheal tube. It avoids localized pressure over the contact areas of the face, eyes, and periocular areas due to malpositioning, especially in prolonged surgeries. There is complete control of the head and neck position with stability. Change in traction as per the requirements. It is cost effective and easy to learn and use positioning for a variety of spine surgeries. We have been routinely using this position for spine surgeries of long duration, atlantoaxial instability, deformity correction surgeries, cervical spine posterior decompression and fixation, traumatic injury to cervicodorsal region, and in cases with difficult positioning and in obese patients. Thank you.
Harshit, two quick questions. What do you do when you don't have the prongs and you want to give a prone position? And second thing,
good afternoon, sir. I was not able to hear you, sir. Can you repeat the question?
If you are fixing a dorsal lumbar fracture and you're giving a prone positioning, or in a cervical spine when you are not put at tongs, how do you do that? Or you have to always put a tongs for a cervical spine? And second question is, why can't you adjust the pulley height and get the same result?
Sir, initially we did it with the pulleys also, but when we want just a fixed traction, then it's always better to give the supports so that it doesn't dongle. On table, the head doesn't dongle. And for this technique, yes, sir, cervical tongs are always needed, because otherwise we have to use a Mayfield headrest or this surgical pillow. If you want to rest the head over these two boxes, then we always need that cardinal tongs. So for the long surgeries, we always do this so that pressure areas are avoided. We have not encountered any pressure areas or any eye or endotracheal tube related complications in last 62 cases while we have done this. The only thing we have to take care is about the pin tracks of the cardinal tongs. That's it, sir.
One quick one, Harshit, if I can ask. In these surgeries, normally the problem with cardboard is that as you have more water, you give washes or something like that, it seeps down. The cardboard starts to get a little spoiled. Have you had any problem where it's kind of buckled eventually?
That is why, sir, the sheets are tightly packed. They are first rolled tightly. There were multiple sheets, one or the other, stacked in a multiple sheet pattern, and we then roll it. So
you've not had a scenario where it is buckled, as I understand. Right?
No, sir. The sheet, if you pack the sheet very tightly, then it is very unlikely to box to get buckled, sir.
Okay. So why don't you use a solid blocks then? Solid wooden blocks.
Just about the availability, sir. We can go on. Anyway, we have to support the tongs from both the sides. So Romoic then boxes and sheets are readily available everywhere, sir. So that's why we.
I think I'm on the next paper. Thank you.
Can we have the next talk, please, the UB team?
The judges, the chairpersons, and my co-presenters, the topic of my study is 4.5 mm pedicle screw in subaxial cervical spine, game changer in desperate situations. The general preferred modality of fixation in subaxial cervical spine involves the usual lateral mass screws. This is because of the advantage of lesser neurovascular complications. However, biomechanical studies have proven the superiority of pedicle screws as compared to the lateral mass screws. Pedicle screws give us better, that is double pull-out strength and lower loosening rates over the time. Also, the concept of 3-column fixation can be realized in cervical spine with pedicle screws and not with lateral mass screws. Now, we had a patient, 56-year-old male, radiologically diagnosed case of junctional cervicothoracic cox. He was managed conservatively with halo vest and antitubercle chemotherapy elsewhere. The patient had incomplete progressive neurological deficit, Frankel grade B, when he presented to us with bladder and bowel incontinence. The investigations revealed C6 to D4 spondylodiscitis, possibly cox, with a kyphotic deformity of 75 degrees. This was the X-ray. The CT scan showing wide destruction of C7 to D4 vertebral bodies anteriorly. This was the MRI showing the muck and the granulation tissue. When we did the CT scan, we found out that the diameters of the pedicles and cervical spine in this patient ranged from around 4.7 to 5.1 millimeters. These were the C4 pedicles, the C5 pedicles, and the C6. The left-sided C6 pedicle was less than 0.44 centimeters. What we did was we inserted 4.5 mm diameter reduction screws in cervical spine, that is in C4, C5, and the right-sided C6 pedicle. We used standard 5.5 mm reduction screws with freehand technique in T1, T5, T6, and T7 pedicles. We inserted a temporary rod on the right side and did laminectomy C6 to T2, decompressing adequately posterior by debulking. We used the cantilever forces and we achieved the reduction of kyphosis. This was done under neuromonitoring. This was the immediate post-op X-ray wherein we got substantial reduction of kyphosis, and towards the end, the reduction, the kyphosis angle was around 35 degrees. Post-operative CT shows no breach of the pedicles and cervical spine. We got approximately 40 degrees of correction with a final kyphosis angle of 35 degrees. The reports were suggestive of rifampicin-sensitive Mycobacterium tuberculosis. He was given drug-sensitive chemotherapy adequately. The patient showed on follow-up significant improvement on neurology. On 12 months follow-up, he was Frankel D neurology with complete bladder and bowel recovery. There was no loss of reduction and loosening of implant on follow-up as seen on this X-ray on follow-up. The challenges in this case were the transitional area of cervical lordosis and thoracic kyphosis and the transitional lateral muscle C7. The stabilization of the instrumentation in these areas is generally challenging. The problems with anterior surgery were the location of mediastinum and viscera restricts the safe access of junctional area anteriorly. In our case, anterior surgery was fraught with challenges because of extensive bony involvement from C6 to D4. The anterior approach would have involved multiple corpectomies from C7, D2 to D4, and also in this process, we would have to compromise the D1 body because it would have been practical. For this, extensive anterior approach would have been required, and sternotomy approach which would have been pretty morbid. The reconstruction would have required a customized anterior cervical plate. Multiple studies have shown that in case we approach more than 2 levels anteriorly, it should be supplemented with posterior surgery. The pathological bone of tuberculosis is known to consolidate eventually with proper chemotherapy. Posterior-only surgery using lateral mass screws wouldn't have given us good correction of kyphotic deformity. Hence, we planned on using the pedicle screws. Combination of 3.5 mm screws in cervical spine with 5.5 in pedicle screws would have warranted the use of tapered rods. Now, the diameter of tapered rods is 3.5 approximately in cervical spine and 5 in thoracic. The area of taper is a high-stress zone. The pressures are inversely proportional to force power radius. With this degree of kyphosis, the chances of failure with tapered rods seem to us pretty much on the higher side. To conclude, in selected cases like ours, we can possibly manage the cases of 4.5 mm pedicle screws in subaxial cervical spine using standard rods. This will give us the advantage of 3-column fixation, obviating the need of anterior surgery. Thank you.
Any questions? Dr. Devesh, anybody has questions?
No, I think we can move on.
We can move ahead.
Thank you.
Next presentation, please.
Good evening, respected chair and faculty and my dear colleagues. I am presenting a paper on pre-surgical psychological screening in spine surgery, Indian surgeon's perspective. Several psychosocial variables are found to be predictors of clinical and functional outcome to spine surgery, especially for chronic pain conditions. Comprehensive pre-surgical psychological screening prior to spine surgery is an extensive process, usually completed by a psychologist with expertise in this area. United States Preventive Task Force recommends use of pre-surgical psychological screening in clinical practices and patients undergoing elective surgery. PPS serves two purposes. It can be used to determine patient's prognosis and to develop a customized treatment plan. For patients undergoing back surgery, PPS can be used to assure correct diagnosis, to identify those at risk for poor outcome, and to provide effective treatment and follow-up services. Thus, the aim of our study was to estimate the prevalence of use of PPS among spine surgeons and neurosurgeons in India, to identify those subsets of patients associated with the use of PPS, and to evaluate surgeons' opinion of PPS and their belief regarding the effect it will add to their practice. An online survey invitation was sent to 310 surgeons doing spine surgery. Questions addressed surgeons' characteristics that were number of years in practice, practice characteristics that include practice type, inclusion of integrated rehabilitation and psychological services, and use of PPS. The impact of psychological factors on rehabilitation and recovery was assessed on 11-point Likert scale, 0 being the lowest and 10 being the highest impact. The distribution of surgeons, out of which 56 were orthopedic surgeons with spine practice, 32 were primary spine surgeons, and 10% were neurosurgeons. 67 surgeons responded to the survey, and only 16% used pre-surgical psychological screening before surgery. 90% among these were from institutional practice or with experience more than 15 years. Which subset of patients were likely to be referred or routine for psychological evaluations? 94% were with previous psychological illness, and next 60% were with revision surgeries. Surgeons reported a strong belief that if they use PPS in their practice, it will affect on the pain relief, the mean impact rating more than 7. And surgeons also reported a strong belief that if they use PPS in their practice, it will have effect on the mean of return to work, also mean impact rating more than 7. The analysis of 67 responses were done using a chi-square test with a significant p-value. The success of many surgical procedures depends on not only the skill of the surgeon and the use of state-of-art technology, but also the actions and characteristics of the patients. Patients' emotional, psychosocial concerns, health related behaviors, outcome expectations, and compliance with treatment regimen can all strongly influence the ultimate effectiveness of surgery. Thus, mental health professionals are increasingly called upon to perform pre-surgical psychological screening and to ensure that patients are given the treatment most likely to be effective while reducing the chance of worsening their conditions. As part of the surgery decision-making process, the PPS can help avoid the creation of failed back syndrome, surgery syndrome also. In the end, we conclude only minority of surgeons is using PPS in their practice. Surgeons who weren't using or less likely to use PPS were those who have just completed their residency or fellowship or begin practice within 5 years. With strong belief among the surgeons of advantage for the advantage of using PPS in their practice, we advocate the use of PPS in spine surgery. Thank you.
So we'll invite questions.
Are there any questions? It's Tushar. Can you hear me? Yeah, it's a very good paper assessed. The only question that you have mentioned that use of PPS needs to be increased. So how do you propose that? Are you suggesting any scale or any other issue? And what is your thinking about the cognitive psychotherapy that we routinely recommend in this kind of operations?
This paper I started at the lockdown time only, and as you can see the numbers, it's very low. 67 only responded, but to increase the use of PPS among the spine surgeons or any surgery, we have good results. So ideally we should refer to a psychologist with all kind of surgeries and see positive effects. So if we may
across any characteristic on which you would suggest that we should be referred to the psychologist, or you recommend every another patient should be referred and PPS should be done?
Sir, patients with more back pain and multiple non-specific complaints with more of yellow flags.
So my question is, did your questionnaire include specifically whether asking the surgeons whether they are doing surgery for predominant back pain, doing fusion surgeries for discogenic back pain, because traditionally psychological evaluations have been used for those kind of surgery. Now, if somebody has a neurological symptom and a neurological pain, I'm not very sure how much that PPS is going to help if you can establish the pain is neurological. But if you have purely mechanical symptoms which are discogenic, did your questionnaire capture that your target surgeons are doing fusion surgeries for discogenic back pain? There, this would make a big impact because you would be screening out patients who are cuckoo,
Yes, sir. Basically not for fusion surgery, but for chronic back pain and discogenic back pain, sir.
So you mean to say surgery or conservative treatment?
No, surgery, sir.
So chronic back pain surgeries is what you're talking about. So you could identify that these people are doing these kind of surgeries.
Yes.
The 67 surgeons that you have questioned. Is that correct?
Yes, sir. And revision surgery, sir.
And revision surgeries. Okay, thank you very much. We can move on to the next question, next paper. Tech team, please play the next paper.
Good afternoon, everyone. My name is Dr. Sudhir Kuchawat. My topic is comparison of gram-negative, gram-positive pyogenic and tuberculous spondylodiscitis. We will compare the clinical and radiological characteristics and the outcomes of the treatment. To our best knowledge, there has been no similar study in the past which has compared the clinical, radiological, and the outcomes of surgical treatment in all these three categories of infection. We included 34 patients between the period of May 2016 to May 2020 who underwent combined antibiotic and surgical therapy in the treatment of spondylodiscitis. All these patients had disabling back pain with varying degrees of neurological deficit. Electronic clinical records and MRI of these patients were reviewed and compared. This is a case showing the gram-negative organisms. The MRI showed degenerated intervertebral disc cartilage on histopathological examination. This is a case showing the gram-positive organism which showed acute inflammatory markers on histopathological examinations. This is a case of tuberculous spondylodiscitis which had acid-fast bacilli was seen on microbacterial culture, and MTB was detected on gene export. Fasciating granulomas and was seen on histopathological examination. Out of the 34 patients, 18 were Asia grade C and 10 were Asia B grade B and 6 were Asia grade A at presentation. 12 elderly patients were found to have gram-negative spondylodiscitis. 6 had gram-positive spondylodiscitis and 16 patients had tuberculous spondylodiscitis. There was no statistical difference found in laboratory parameters between these three group of patients. Even with higher average levels of CRP and ESR in gram-positive spondylodiscitis patients. Constitutional symptoms with varying neurodeficit were the primary reasons for visits in the gram-negative spondylodiscitis patients, whereas pain in the affected spinal region with neurodeficit was the most common manifestations in the gram-positive spondylodiscitis patients at the initial visits. Back pain in the affected region with neurodeficit were the primary reason for presentation for tuberculous spondylodiscitis patients, while the clinical outcomes of gram-negative patients under combined surgical and antibiotic treatment were not different from those of gram-positive patients and tuberculous spondylodiscitis patients. On MRI, the gram-negative spondylodiscitis patients had less incidence of epidural abscess compared to the gram-positive spondylodiscitis patients. Gram-positive spondylodiscitis patients had epidural abscess but less spinal deformity and destruction, while the tuberculous spondylodiscitis had paraspinal and epidural abscess and spinal deformity was seen due to the bony destructions. This is a case showing the tuberculous spondylodiscitis on an MRI. The disc base is relatively was preserved and the posterior elements were most commonly involved. The anterolateral extension with the extension to the paraspinal soft tissues was present and collapse of the vertebral bodies was with the gibbous formation was seen. Spread under the anterior longitudinal ligament was also seen. This is an MRI showing the tuberculous spondylodiscitis. The pyogenic spondylodiscitis had MRI signs which was not distinguishable between which did not distinguish the gram-positive or the gram-negative spondylodiscitis. Low T1 and high T2 signals were present along the end plates, and loss of definition of the end plates was seen. Destruction of the end plates and sclerosis in chronic infection was seen, and distant paraspinal soft tissue involvement, such as the psoas abscess, was most commonly found. This is an example of showing the MRI of the pyogenic spondylodiscitis. We like to conclude that the clinical manifestations, MRI presentation, and the histopathological appearance of gram-negative and gram-positive and tuberculous spondylodiscitis were distinguishable, while surgical outcomes were similar. Gram-negative spondylodiscitis patients were more often found to be elderly individuals or had a history of cancer or symptomatic urinary tract infections in the past. Thank you.
Thank you very much. We can invite questions for the presenter. To begin with, I have a question. It's a little bit surprising that you are saying that the clinical outcomes of surgical patients with pyogenic and tuberculosis was same, considering that so many of your patients were deficit patients.
Yes,
It's
sir.
like a little bit common knowledge that pyogenic infections with deficits are, they don't have a very good prognosis. So how do you explain the discrepancy between, I mean, I understand that the numbers in your study are quite small, so it's very difficult to make a conclusion like that.
Yes, sir.
But do you have any thought process about that?
No, sir. Basically, in the tuberculosis spondylolischitis patients, the only problem we saw was the deformity which was found compared to the gram-negative and the positive spondylolischitis. Otherwise, in my study,
You had 6 Asia A patients who were operated. 6 Asia
Yes,
A patients who were operated. How many of those 6 Asia A patients were pyogenic infections?
That number
The severe deficits, how many were pyogenic infections? Gram positive or gram negative?
Yes, sir. That is not. I didn't. That's lacking in my study. I couldn't differentiate between both.
Because there is a big difference in prognosis in literature about pyogenic infections causing paraplegia and tuberculous paraplegia.
Yes, sir.
Clinical symptoms and MRI picture apart, but the clinical outcome of neurological deficit, there is a big difference between pyogenic and tuberculous. So maybe you'll have to look into that, whether it made a difference or not.
Did we do a
If there are no
CT-guided
questions,
biopsy?
sorry, Dr. Devish.
CT-guided biopsy or something done pre-operatively or all intra-op?
No, CT-guided biopsy was done pre-operatively, and then after an antibiotic therapy, we went for a further plan.
Okay.
All
Can we
right.
go ahead? Can we have the next?
Thank you very much. Thank you. We can go to the next one. We can't hear any sound, please. Tech team. Tech team, please. There's no sound.
My name is Harshil Patel. My topic for presentation is scoliosis associated with intraspinal anomalies. They are often associated with early onset scoliosis, which can result in neurological deficit and propagation of spinal deformity further. Most common of which are roll-carry malformation, T-third cord, and split cord. Their incidence is 20 to 30% in congenital scoliosis. Most common being ACM with syrinx, and secondly T-third cord. More commonly found in females and in failure of segmentation variety. We all know ACM defect in brain characterized by its downward displacement through foramen magnum, 4 types. T-third cord, low-lying conus below L3, includes fibrinoid, terminale, meningocele, sinus plate. Split cord, 2 types. 2 hemichords which are separated by bony septum, it is type 1, and if separated by fibrous septum, it is type 2. So we carried out this retrospective study wherein we included 10 patients with age greater than 10, Cobb's angle greater than 40, and having intraspinal anomalies, whereas syndromic and muscular dystrophy patients were excluded in civil hospital. They were examined thoroughly neurologically, and investigation in the form of whole spine bending X-rays, 3D CT, MRI, USG, abdomen, pelvis, and 2D echo were done. Other systemic examinations, that is of skin, wherein we saw for tuft of hair, dermal sinus, capillary spots, limb length, scoliosis, and foot deformity in orthopedic side, neurogenic bladder, yes or no, for urological, and abnormal reflex or sensitivity symptoms for neurological side. First surgery was performed for intraspinal anomalies in all the cases by neurosurgery department. And secondly, scoliosis under neuromonitoring. Now some of the cases, 12 female patient having Cobb's angle 75 and ACM, operated for annual carry first. You can see the resolution of syrinx. But her Cobb's angle increased to 110, which COVID got corrected on suspension. So finally we did posterior correction only from D3 to L2. Similar case, here you can see 16 female, noticed just before 2 years. So the guy, you can see the ACM, first operated for the same thing, duroplasty, decompression only, no fixation, and we did from T3 to L4. Here also only posterior with the help of vertebral column manipulation. Third case, operated for meningomyelocele, and 2 days after birth, you can see the Cobb's angle 90 degree. Unfortunately, we lost this patient immediately post-op. So this was just a portable on-table X-ray. So here the mean follow-up was 6 months, mean age 13, average gap between two procedures 8 months. Pre-op Cobb's angle improved from 86 to 29. And most commonly, ACM was found, followed by T3 cord 3 and split cord. We encountered one death. So indications for MRI, those are neurological deficit, early onset scoliosis, double curves. High-risk patients are delayed presentation after 10 years, Cobb's more than 40, vertebral rotation, double major curves. Now, yes, of course, decompression of Chiari morphology is often recommended first, as it may subsequently resolve spinal deformity. Now, in some cases, both these procedures, that is spinal anomaly and scoliosis, are done at the same time. But the operation time and the blood loss were out of range. I mean, 9.3 hours and 1980 ml, quite more. So we conclude that management of interspinal anomalies should be done first, as it avoids development of neurological deficit and stabilizes deformity. Though there are some cases of spinal tension and simultaneous correction, stage approach spaced by 6 months is preferred. In spinal deformity surgery is quite challenging. So multispecialty team approach with appropriate instrumentation, that reduction towers, vertebral column manipulations, are essential for optimum outcomes. Thank you very much.
Thank you. Thank you for this paper, Dr. Harshil. We can take questions. I can start with the first question. Can you please tell us more about the death you had in this?
I think Harshit is not able to join, so maybe we can.
Oh, he's not there. Okay. So we can move ahead. So I think we are at the last paper. Is that correct?
Yes, sir.
Because Tushar and Sandeep are not there, so I think it's Bharat.
Tech team, please play Dr. Bharat Patel presentation.
Good afternoon, everyone. 12-year male patient present with severe dorsal kyphoscoliotic deformity with spastic paraparesis since 4 months. Non-ambulatory status at the time of presentation, bowel bladder urgency frequency. Patient was operated for hydrocephalus at the 4 months of age. Left VP shunt was put and development of milestone was normal. The clinical examination saw a kyphoscoliotic deformity at the upper dorsal spine with convexity on the left side, both shoulder on the same level, left trapezius, fullness, no congenital stigma. Patient had a grade 3 spasticity, sensory was reduced below D9, motor power in both lower limb was grade 2, lower limb had a UMN sign, upper limb normal, higher function normal. On plain X-ray show there is a 37 degree of scoliotic deformity with significant kyphosic deformity at D4-8 level, and we can appreciate here the left old VP shunt. The CT and MRI show right side D6-7 hemivertebra, there was no spinal cord anomaly. Preoperative SCCP showed delayed posterior column conduction. We couldn't get any MEP except the left quadriceps signal. VCR surgery was performed. Neuromonitoring signals are remained same throughout the surgery. Kyphosis corrected up to the 37 degree. There is no perioperative hypertension. On day 0, patient was absolutely fine. High function normal, neurology normal. But on day 1, patient become irritable, confused. There is a repeated episode of vomiting, headache. GCS was 7/15. Elective intubation was done. And CT brain showed dilated dilated both the ventricle and diagnosis of efficient blockage. So what are the causes of efficient blockage? The truncal height lengthening after the kyphosis correction may cause mechanical stretching of the patient, or may cause fracture of the shunt, or it may dislodge the shunt end from the proximal and distal end. But in our case, fracture and dislodgement is not there, so the possible cause is mechanical stretching. So urgent VP shunt reinsertion was done from the right side. The GCS was improved next day. Patient was extubated, but the power in both lower limb was grade 0. So immediate CT and MRI was performed. No implant malposition, no any syrinx formation, no spinal cord compression, no any loss of correction. So patient was observed, and for the first initial recovery sign was seen at the 4-week, and in the last follow-up, patient become independent ambulatory with lower limb power was grade 4 with residual spasticity. So the causes, so one of the theories that the hydrocephalus may cause communicate distally and form the communicating de novo syrinx, or it may expand the pre-straight syrinx. But in our post-operative MRI, there is no syrinx formation, so this cause was ruled out. So possible hypothesis is increased intracranial CSF pressure leads to the increased intraspinal CSF pressure, and that's why there is a decrease the spinal cord perfusion patient that led to the transient ischemic event. So conclusion, VP shunt malfunction is a rare complication. Increased spinal CSF pressure leads to the decreased spinal cord perfusion and hence for spinal cord ischemia, and prompt restoration of the shunt pattern should reduce the CSF pressure and restore the spinal cord perfusion pressure. Augmentation of the mean arterial pressure appears too prudent to maintain the spinal cord perfusion pressure. Thank you.
Thank you very much, Bharat. That was a terrifying case. Are there any questions?
I have one question for Dr. Bharat. In future, how do you, what measures would you recommend to prevent this kind of a VP shunt stretching and causing a issue in a case of kyphosis? Hello,
Bharat.
Bharat around?
Can you hear me, sir?
Yeah.
We can
please
hear
go ahead,
you. Go
Bharat.
ahead.
So, have you heard my question, Bharat?
Maybe Dr. Bapat can answer the question.
Hi, can you hear me, guys?
Yes.
Yeah, so this case was
A shunt in the body, and they are during the childhood. So we should be careful to examine before scheduling a surgery. We have to careful that this shunt and shunt function are functioning well or not. So pre-operatively, we have to also evaluate a shunt function along with the our routine surgery planning.
Here, would you like to elaborate?
Yeah, so first is how do you determine the shunt patency? Now, there's something called as a shunt occlusion test, and then there is something called as a patency of the shunt as it enters into the ventricles. Now, you can do an MRI of the brain to see that the ventricles are not dilated and the shunt is working properly pre-operatively. Now, during the surgery, the only precaution that you can take is that don't use too much of, you have to actually shorten the vertebral column and don't try to stretch it out too long, because the common error is to put a cage in front and use the cantilever force. So if you stretch these shunts along the length, then it can stretch into the fibroosseous tunnel or as it enters into the ventricle. These are the 2 points where the shunt can get stretched. So do not use a lengthening procedure at all. Always shorten the column. It is wise to maintain your intraoperative systolic pressures, blood pressures, above 100 millimeters of mercury, though it may add to a little bit of blood loss. But these are absolutely vital to maintain your spinal cord perfusion pressures. And it is always wise to check on the shunt immediately post-operatively. So a neurosurgeon input into this sort of assessment post-operatively is vital, because if the shunt is blocked the only way to do it is to restore the shunt patency. You cannot wait on it, because otherwise not only is the brain at risk, but the spinal cord is also at risk if the shunt remains blocked.
Very well. Thank you.
Any more questions?
So sometimes these shunt patients have an Ommaya reservoir in the neck. Did this patient have a reservoir in the neck where you could directly puncture and take out the CSF?
No.
Sometimes they have a reservoir here.
No, the shunt was a very old shunt. It was working for the patient, so he did not have any reservoir there.
Otherwise, sometimes they have an Ommaya reservoir in the neck where if you have an emergency, you can just put in a needle and just take out the CSF. It immediately decompresses. So,
valid point.
I think from all of us here, from the BSS, we would like to thank all the presenters for the effort they have made. Most of them stood by time. They didn't overshoot, and I think it was a wonderful session. For the presenters, please remember that the certificates will be sent thereafter online. Can I hand the proceedings from here on to Dr. Uday Pawar and Dr. Vishal Kundnani? And as I say this, thank all the co-chair to give me a hand to conduct this session. Vishal and Uday.
Thank you so much, Dr. Raghu Prasad. Thank you all the chairpersons of the session, Dr. Tushar Rathore. We had Dr. Kshitij Chaudhary and Dr. Devesh Dholakia. Thank you so much for being around. So the much awaited time of the day is here. We are now blessed to have all our foreign faculty members joining us. The session that has been looked after for so long is here now, which is the Presidential Guest Lecture Series session. We have the who's who of the world with us today, addressing the delegates and also the Bombay Spine Society. These coming 4 hours are not only prestigious in they are sharing their knowledge, but also what they've seen so far in last 3 decades of their practice. Also the vision statement of what is in future in spine trauma, minimal invasive spine surgery, and spinal deformity. What changes are waiting for us to see the day? And we are going to soon listen to all these masters from across the globe in the session, past, present, and future by Presidential Guest Lecture Series session. May I, to address the whole session, call upon all the panelists of this President's session, to start with the current President of Bombay Spine Society, Dr. Srivastav sir. Please chair the session. May I also call upon Dr. Arvind Goregaonkar, the immediate past President of Bombay Spine Society, to please join us. May I also call upon Dr. Ram Chadda, the past President of Bombay Spine Society, and also Dr. Ketan Badani, who is going to be along with us to join this session. The patron of the session, Dr. V.T. Ingalalikar, will be joining us very soon. Over to you, Dr. Sudhir Srivastav, sir. Sir, unmute, please.
Thank you very much, Dr. Vishal. A very good evening to all of you. On behalf of Bombay Spine Society, I welcome one and all to this prestigious presidential guest lecture sessions, where a galaxy of spine surgeons across the globe will share their knowledge. We are going to have 3 sessions. The first session is about the spinal trauma. The second session about the minimal invasive spine surgery, and third would be about the spinal deformity. In spinal trauma session, our guest speakers are Dr. H.S. Chabra and Dr. Alex Vaccaro. Dr. H.S. Chabra is President of Association of Spine Surgeons of India and a Medical Director of Indian Spinal Injury Center, New Delhi. Dr. Alex Vaccaro is Professor and Chairman of Orthopaedic Surgery in Rothman Institute and Professor of Neurosurgery in Thomas Jefferson Hospital, Philadelphia. I warmly welcome both of them. For subsequent session, we have galaxy of spine surgeons who are master in their field. I welcome Dr. Larry Combe, Dr. Larry Lenke, Dr. Peter Newton, Dr. Harry Schafferwerker, and our own Dr. Neil Anand from USA. Professor Abume is most welcome from our society, where he has been visiting our country multiple times He is from Japan. I thank you very much, Dr. Abumi, to visit us. I welcome Dr. J.S. Kim from Korea, Dr. Kwan from Malaysia. A very warm welcome to all of you. Now I hand over the proceeding to our coordinator, Dr. Gautam Javeri. Dr. Gautam, please.
Thank you, Dr. Srivastav, for welcoming our faculty. And before we actually start this very prestigious session, can I call upon our patron, Dr. Ingal Halikar, to say a few words of welcome and introduce this session before we actually go ahead with the session. Dr. Ingal Halikar, please unmute, sir.
Yeah. Thank you, Gautam, for asking me to say a few words. This is the first annual major conference of Bombay Spine Society, and the organizing team has collected a huge number of top experts in the field to talk, to do their presentations, and in general update all of us in the field of spinal surgery. Most of the first meetings of any body anywhere in the world generally have very small attendance of say 50, 60, 80, 100 people. Now here we have crossed over 1,000 people who are at this moment live watching everything, including the people on other platforms like OrthoTV and YouTube, etc. So all in all put together, this is an excellent beginning for the Bombay Spine Society, and I'm very happy and also proud that I'm part of Bombay Spine Society, and I wish this conference a great success. And let's get on with the proceeding. Thank you very much.
Thank you very much, sir, for welcoming our audience and our delegates and our participants as well as our faculty. A couple of words of welcome from our past president, Dr. Ram Chadda.
Good evening, everybody. On behalf of the Bombay Spine Society, it's a matter of extreme privilege that we have a plethora of stars from all over the world. We are most grateful to the 1,000+ delegates who are active spine surgeons who are here adding value to this meeting, which has been conceived and conceptualized by the Bombay Spine Society. Let me thank each one of you delegates for taking your time out on this weekend. Many of you were with us last weekend when we had the workshop, and today we are here having something which is probably in search of excellence. We have the best of the best speaking about what is closest to their hearts. We have people who are regarded as legends and who have created history by presenting what they are sharing with us today. We are extremely proud that each one of you have come as our guest faculty today to be a part of this maiden venture, first venture of the Bombay Spine Society. Thank you, friends from all over the world, our own, some like Neil who've gone overseas, and close friends like Kwan from Malaysia and Professor Abumi, and of course, those from the United States of America and other parts of the world who have always been there to add value to our events. Thank you, namaste, and welcome to India.
Thank you very much, Dr. Ram. I take this opportunity also to welcome my co-convener for this session, that is Dr. Mir Bapat. And now, without much ado, I take you to the first and inaugural session of the Bombay Spine Society Conference 2020. The inaugural session, of course, has to be something to do with what all of us see in day-to-day practice, and that is spinal trauma. Although trauma is something which all of us manage on a day-to-day basis, there is still a lot of controversy regarding how to actually describe the morphology of an injury, what is stability and what is instability, and what is the classification one uses to actually decide the type of injury, decide on the management protocol as well as the surgical approaches. For discussing that, we have two legends in the field of spinal trauma who are with us today to talk about various aspects of this. The first of these is Dr. Alexander Vaccaro. Dr. Vaccaro needs no introduction. He is recognized as the foremost expert of spinal trauma in the world. He is probably the most published spinal surgeon in the world. Enormous amount of peer-reviewed publications, chapters in textbooks. He himself has written multiple textbooks and is invited world over for sharing his knowledge and information. He has always been crisp in his ability to communicate with people, and the classification system, starting with the TLIX classification, the SLIC classification in the cervical spine, and even the modified AO cervical spine classification, he has been an integral member of task forces that have decided that. Along with him, we have got one of our very own, Dr. H.S. Chabra, the medical director of the Indian Spinal Injury Center and the current president of the Association of Spinal Surgeons of India. A dynamic leader who has actually developed the Indian Spinal Injury Center from nothing about 20 years ago to the leading spine center in the country, doing more than 2,500 surgeries every year. And from simple to the most complex of reconstructive spine surgery is performed in the hospital. Dr. Chabra himself has been involved in enormous amount of research on not only on spinal trauma, but on a lot of other objects or subjects related to spine. So without wasting much more time, I would request the BSS Tech team to start playing the video recording of Dr. Vaccaro's talk.
It is an honor to be able to speak at this meeting. I was asked to talk about the spine trauma classification systems, what was, what is, and what is next. And I'm going to take you through a journey of what that means. And it's been a long journey. I have a direct conflict with this talk as I was the team member of many different teams that looked at how to make classification systems more usable, more reproducible, and more reliable. We grew up in a system where everyone described fractures by describing what they saw on a plain X-ray. And then some people ventured out to describe these fractures as to the mechanism. And as you and I know, it's difficult to know the mechanism by looking at a two-dimensional X-ray. All these classification systems initially had no measure of instability. We see a fracture, is that stable or unstable? The classification didn't tell us the stability of the osseous elements, the ligamentous elements. Personally, if there was a neurologic deficit, I would consider that an unstable situation. We didn't account for metabolic bone disease such as ankylosing spondylitis. Is it more important to have a fracture in a small canal or larger canal? None of the systems really gave us an understanding. In the late 1980s, early 1990s, Dr. Panjabi from Yale said, listen, let's put a lot of different elements together. Is the patient predisposed to injury in the future? What do the x-rays look like? How much translation, rotation? What is the neurologic status? And he came up with a point system. And that was a brilliant introduction to understand neurologic instability. Now, if you look at the upper cervical spine, we had fractures named after people's names, like the Monsanto classification or the Orlando Anderson. It doesn't mean anything to me. It doesn't tell me anything about the type of instability. So we had that problem. So we had to put it all together. And then the AO came out with a great type of method of classifying and registering fractures, A, B, and C. Letters mean nothing, but they developed silos. Compressions are A, distractions are B, rotations, translations are C. And that's a brilliant way of placing fractures in silos so you can think about it as long as you memorize the alphabetical nomenclature. But the system originally had 53 different subtypes, the original Magro classification for the AO. And when you started to look at inter and intra-observer reliability, it was poor. For the A, B, and C, it was high. But as you got down to the classifications, it was very low. So we have so many classification systems. Do you do morphology? Do you do mechanism? How do you know mechanism? How do you determine instability? Most ignored the neurologic status. Most didn't tell us how to treat it. We thought the more severe an injury, the more aggressive we would get in terms of surgical intervention, but we really had nothing to determine prognosis. In North America, when I was growing up in the 80s and early 90s, we had the Allen Ferguson because it was sort of a mechanism of classification: flexion, distraction, extension, vertical compression. See, to me, that made sense. But remember, there was 24 different classifiers, and you really didn't know what the mechanism was. So the first attempt was a spine trauma study group coming up with a subaxial injury classification system, or SLIC. It looked specifically at morphology, discoligamentous complex, and neurologic status. And it looked at the level of injury, the morphology, type of injury, what did the soft tissues, what were injured in the soft tissues, and what was the neurologic status. And then it looked at confounders. Do you have a metabolic bone disease? Do you have osteoporosis? And it put it all together using research from previous systems: compression, distraction, translation, rotation. And again, you have to thank the AO for that. And what was the first time a classification took this together, put numbers to different types of injury patterns, and came up with a algorithm. If you had less than 3 points, that could be treated non-operatively, 4 equivocal and greater than 5. So it's the first time you had morphology, understanding ligamentic complex, neurology, and a point system. So the SLIC system, 2007 was the first to introduce that, and you could come up with an algorithm. And these algorithms are difficult to go through, but it sort of took you through a thought process on when you should operate and when you should not operate. The AO did the same thing. The AO came in and said, listen, we love that, but it's difficult to classify verbal descriptors. So let's get back to the A, B, and C so we can keep the red straight. And let's also look specifically at the facet injuries, because the previous SLIC system didn't look specifically at facets. So that made sense. So again, the A, B's, and C's: compression, distraction, translation. And then in A's, you have five different classification systems: minor to complete burst, B's, tension injuries, and C, translational. Made sense. A0, minor injury; A1, wedge compression; A2, pincer fracture; A3, incomplete burst with 1 end plate; A4, complete burst. And then you have an algorithm. So that made sense. You can now record that in a registry. So if you have to do research on it, retrospectively or prospectively, you had an understanding. Tension injuries: B, bony only; B2, bony ligamentous only; B3, distraction extension injury. Made sense. Now make an algorithm. And then C, translation, where there's significant disruption, and then an algorithm. So these are the things we looked at. But here, for the first time, we start describing the facet. F1, stable, non-displaced; F2, potential for instability or greater than a centimeter in height and 40% of lateral mass; F3, floating lateral mass; and F4, any type of pathologic subluxation, perch facet, or dislocation. So these are visual understandings of this system. So now, finally, we are looking at the facet, which is important in the cervical spine, less important in the thoracolumbar spine. And we have something unique in the neurology, the scriptures. Now we have NX cannot be examined. How many times does someone come in with an obvious cervical spine fracture, but they're in a coma? NX cannot be examined. That's great. I need to know that. Or someone says, I was paralyzed in the field, but not better. That's an N1. We never had that before. And again, it borrowed from the old spine trauma study group in terms of it had modifiers: critical disc herniation, stiffening bone disease, vertebral artery. And then there's an algorithm. What happened? How do you describe the right side, the left side? What about the sub-injury? So every system has a technique on how to do that and an algorithm. C6-7C, that means that you have a translational injury, and then you could have a subclassifier such as a B, an A1, which means you have a fracture also to the C7 vertebral body. Or you can have an F4, that means it's a bilateral facet subluxation. So you can have that. So that's how it works. Now the thoracolumbar injury assessment, same type of thing. 2005, we say, listen, let's get rid of the mechanistic, let's get rid of the morphology. Let's look at the posterior ligamentous complex, the morphology, and then come up with a scoring system. So this was a TLIC system. Made sense. It wasn't as good for lower lumbar burst fractures, L4 and L5. It was okay, but wasn't very good. And it, of course, didn't look at the sacrum. So then the AO came in and said, listen, we like it. Let's get the classifiers. Let's get the point system for the severity, and let's come up with algorithms. And the AO looked at it and, again, came up with 5 different types of A, 3 different types of B, and C, and it made sense. And you don't have the complicated aspect of facet fracture. So, again, Same neurology because it's consistent, and the modifiers in the thoracolumbar are unique. Is there a possibility of disruption of ligamentous complex? Is there a comorbidity that may make me more aggressive or less aggressive? And then again, it has an injury severity score. So you add those up and it tells you, if let's go non-operatively, equivocal can go either way, or let's get more aggressive. One thing these systems don't do is it doesn't really look at the sagittal balance. It doesn't look at it. And we know that lumbar fractures with kyphosis are worse than thoracic fractures with kyphosis. And even after fixation, spinal alignment does affect outcomes. So we need to look at that. So that's the future. We need to look at that. We need to understand the anterior column better. And this system, unlike the TLIC system, differentiated between a burst with a single end plate and a burst with two end plates. So that's good. And if you compare them both, one system is a little bit more reliable in identifying the morphology type. They're about the same. AO is a little bit better in terms of identifying the fracture type. Now, what do we do about the low lumbar fractures, and what do we do about sacral fractures? Well, people have looked in the lower lumbar fractures. This is sort of a system that sort of mimics the TLIC system. It gives a point classification system. There's been no study that shows it's better than the TLIC system, but this was an opportunity in spine in 2012 to sort of take the same system, come up with a different point system to do it. And then the AO came out with a separate pelvic classification that looked at lower sacral coccygeal injuries type A, posterior pelvic injuries type B, and spinal pelvic dissociation injuries type C. A's are either simple, like avulsion injuries, A2, transverse injuries, and A3, transverse displaced. B's are sort of vertical fractures, are like the previous DNE, but a little bit different than DNE. B1 is in the canal, B2 is in the ala, and B3 is in the foramen, which is different than the DNE type 2, which is in the foramen, and it's a great way of classifying it. And then the classic U-type fractures would be C injuries. And again, same neurology, and then the modifiers are different. Is the SI joint involved? Is there an anterior pelvic ring injury? Is there metabolic bone disease, and so forth? So you just have to be careful because each system has a little caveats, like an A0 minor injury to an L5 transverse process and something and a small motion on the sacrum may be unstable. So you have to keep an eye on what's going on. But what I've noticed is all systems, again, don't tell me the type of fixation strategies and don't tell me anything about sagittal balance. Now, the most complicated system, I think, is the upper cervical spine. Before I told you, you had Montesano classification, Delonzo-Anderson classification for odontoids, the Levine system for hangman. We got rid of that. We go with the A, B's, and C's, and we divided the upper cervical spine into occipital condyle, craniocervical junction, second silo, C1 ring, C1-2 facet, and third silo, C2 and C2-3 facet. And again, type A injuries, bony only. And we type A, occipital condyle, C1 ring. And you could go through this and you could see the logic for type B injuries, bony only, ring injuries, type B, where you have a little bit more instability. And it goes on to type C injuries. And now you see translation in both the occipital condyle, craniocervical, C1 ring, C1-2 joint, and C2 and C2-3 joint. So you have that ability, and you got to sort of memorize this because remember, using letters is all memory. It doesn't make sense. The old systems that made sense, we described the mechanism, makes sense, but it's impossible to categorize what's going on. So this is just an example of an occipital condyle. Type A, non-displaced. Type B, potential ligamentous injury. Type C, obvious translation. C1 ring, C1-2 joint. A, bony arch fracture. B, transverse ligamentous injury, no obvious instability. Type C, you have a rotational instability. And C2 and C2-3, if you look at type C, you have significant translation. Type B, tension band injury. So it all makes sense. And again, same neurology and modification modifiers specific for the upper cervical spine. So I know I went through a lot from the past, the present, and what we need for the future. We need to understand how to prognosticate. We need to keep it simple. We need to do something we haven't done before. Sex. Is a burst fracture a burst fracture? Will that burst fracture heal appropriately, but the patient may have a sagittal plane deformity? How can we figure that out initially? And we may come to the conclusion you can't. Only at follow-up can you reclassify that. So I think those are the challenges we have today. So thank you for going through this journey with me. Have a nice day.
Thank you, Dr. Vaccaro. Welcome also. We have taken the liberty of introducing you whilst you are not here. And we've actually heard this wonderful lecture from you. So welcome again. And I would like to open this lecture to the house for any questions whilst I get any questions from the audience, let me start off and put a question through to Dr. Vaccaro. Dr. Vaccaro, would you extend the application of this classification to osteoporotic or fragility fractures?
I'm glad you asked that question because we did extend it to osteoporosis, fragility fractures, and we came out with an entirely different classification. And it's the AO, osteoporotic fragility fractures. It has 5 subtypes, and we haven't published it yet. And it's interesting. If you send me an email after this meeting, I'll give you an understanding of the meeting. So it looks at mild compression. It looks at Z-scores, T-scores. It looks at retropulsion of bone. It looks at all sorts of factors. It's a little bit different. So it's a corollary to this system, but we couldn't just make it part of the system. We had to make a separate system. So it exists today, and I'll email it to you so you can give it to your society.
Well, thank you. Any questions from any of the panelists?
May I? Yeah.
Yes, Vishal, please.
Welcome, Dr. Alex. It's so nice to have you around. My question is, Rob, there have been questions lately about the validity and applicability of TLIX classification to various different kind of fractures. In specifics to the low lumbar fractures, which you just had a mention about. So what do you have to say about the exact validation and applicability of TLIX in some different and complicated fracture systems?
Gotcha. So most of those studies show that at the thoracolumbar junction, mid-thoracic, upper lumbar, it had high intra. When you get down to L4 and L5, it was less so. And therefore, we had to come up with a different system. Ron Lehman came up with his system that looked at it, but it's complicated. It's sort of like a copy of the TLIX system. So I think when you get at the lumbosacral junction, we have problems with the system. And that's why we sort of modified it with the AO system. But you're right. I think for the vast majority of the fractures, it works well. Lower lumbar tends to be stable in general. I mean, rarely do I operate, and if I do operate, I do a short segment fixation, and you tend not to see failure of the instrumentation, but it struggles in the lower lumbar segment of the spine. That's a good point.
Thank you. Dr. Kulkarni, you have a question?
Yeah, Dr. Vaccaro, good evening. I just wanted to ask you, is there any way we can just get away without doing a CT scan in a fracture spine, avoid radiation? Can you get all information from MRI itself?
So that's it. So you mean, are you saying with just an MRI scan and a plain X-rays, or just plain X-rays, period?
Yeah. What is it that you can, what is it that you look for in CT, which you can avoid, and prevent?
Yeah. So it's interesting. The argument traditionally is, can you just get away with a CAT scan and not an MRI? Because MRIs are expensive, and a lot of facilities throughout the world may not have it. So the consensus among all spine surgeons is if you have a CAT scan, you don't need to have plain X-rays. The downside of a CAT scan is what you said; it's radiation exposure, and we tend to take that sacrifice, and that's the risk. The nice thing about a CAT scan is that you can see if there's bony retropulsion. You can contrast the images to see if there's an epidural hematoma component. You can pick up a disc herniation with contrast. You could see separation of the facet joint. So a CAT scan is great. Plain X-rays, as you know, I've looked at various studies that looked at CAT scans. You have a 55% sensitivity. Hold on one second. Guys, you got to be quiet. There's a 55% sensitivity using plain X-rays alone. So CAT scan has a 99.4% sensitivity. If MRIs were widely available, can you use an MRI scan to give you everything you want? And I feel in the future, with a 3 Tesla in the future, that's beautiful. Okay, that's beautiful. A 3 Tesla in the future, you may be able to obviate a CAT scan, but we're not there yet. We're looking at it right now because that'll be great. Because then you don't have to have any radiation. The problem with MRIs are if you have a pacemaker, if you have ferromagnetic implants, if you had metal fragments in your eye, you can't get it. So that's a headache. So CAT scan right now is what we have, but I agree, radiation is a major problem.
Dr. Vaccaro, you have been instrumental or integral in both the SLIC and TLIX classification and the AO classifications. So as a rule, which one would you encourage youngsters to follow?
Another great question. So I tend to be a man who doesn't like to memorize things. I tend to be a simple man. So that's why I like the TLIX system, because it's simple, it makes sense, it's intuitive. I don't like numbers and I don't like letters. Now, I have gone with the AO system because it allows me to characterize. So if you want to be a researcher, and if you want to be able to say that's an A2 whatever, you got to go with a nomenclature system like the AO system. So if you want to do studies, if you want to compare apples to apples, the AO system's perfect. If you're a guy in the field taking care of people, the TLIX system is simple, easy, ready to use, but difficult to communicate if you want to study groups of cohorts in the future. So simplicity, TLIX, academics, AO.
There's a question from the audience. Dr. Barua has asked you whether the classification systems guide you towards anterior or posterior surgery.
Well, that's a great question. So, you know, I'm a student of the load classification system of Gaines. Gaines came up with a great system that looked at, you know, the anterior column. Is it slightly comminuted? Is it significantly comminuted? Is there separation of fragments? How much kyphosis? And it sort of taught me in the early 90s when I needed to go anteriorly. We moved away from that because the spinal implants got to be stronger and stronger and stronger. And we just assumed if you have significant loss of anterior column, you're going to go anteriorly. So the newest systems do not look at that at all, because the spinal implants got better. And we kind of learned, listen, the anterior column is destroyed. You got to go anteriorly. So we've sort of gotten away from that. So they do not. The contemporary systems do not, because we've learned already that you really should go anteriorly on something that's significantly destroyed, except in lower lumbar where it seems to be stable. But if you've lost all anterior column support at T12, L1, and you go posteriorly, unless you go multi-segment, that single level is going to fail. It's going to fall into kyphosis. So we've sort of learned it. The new systems don't tell us to do that. Now, we may, with the AO system, as more time goes on, differentiate between an A3 and an A4, single end plate, two end plates, and that may tell us if you're an A4, you may have to go anteriorly, but we don't have enough information. But that's a great question.
Right. The next question is the applicability of the Gaines classification today. I mean, it has always been difficult to actually use the Gaines classification in practice, because how much is the spread of fragments, how much is the kyphosis you are expecting correction of. So those were difficult things to apply to in practice. How does one decide the need for an anterior column reconstruction in today's world?
So that's a great question. So I don't sit there in the Gaines classification, 6 points or more, you go anteriorly. I never put the points together. So I just use the principles. Wow, that's a really comminuted fracture. Wow, that patient's kyphotic. I'm going to have to really correct. And the early AO studies showed that the degree of kyphosis correction, it sort of settles back down again. So what I do is I just look at the personality of the fracture. And if I see significant kyphosis, and if I want to cheat, and if I want to go short segment, I'm going anterior posteriorly. If I want to go short segment. If it's an older person, I'm not going to do that. I'm going to do multi-level above and below. If it's lower lumbar, L4, L5, I'm not going to go posteriorly. I'm not going to go anteriorly, because anteriorly is a real pain at L4, and it's a real, guys, be quiet, please. It's a real problem to go anteriorly at L4 and L5. Very difficult to do. So I'm a man of common sense. I don't use the system anymore. I just know how badly I did in the 1990s. I mean, I remember 1988, 89, 90, 91, 92, everything would fail. All the screws would fail. And then all of a sudden Gaines wrote the paper and it made so much sense. But now we know that. So now I know if I want to go short segment, I'm going anterior posteriorly. I use common sense now.
Right. Thank you. Any other questions from any of the delegates? Or yes, Dr. Srivastav?
Yeah. Nice presentation, Dr. Vaccaro. I have a question for you. In MRI, we say that there is the exaggerated picture of soft tissue edema, bony edema, and it exaggerates the pathology. Do you think the CT exaggerates the bony fragmentation? Because many a time, if you see the plain X-ray, you don't feel so many things, and there is not a just crushing which is visible in CT. What is your opinion?
That's a good question. You know, the MRI, I did some studies in the past where I looked at MRIs before I operated. I classified every injury that was destroyed in the MRI. Then I operated and I wrote down every single thing I found. And I found that the MRI was so much sensitive, and it allowed me to be more aggressive. So MRIs
for someone on a CAT scan, I know I have a problem. Occipital cervical. If I see the occipital condyle and C1 superlateral mass separated or translated, I've got a problem. So I favor the CAT scan. It sounds like people aren't too much of a fan of a CAT scan, but I favor it. It's simple and it's cheap. It costs $300 for me to get a CAT scan now. It costs $900 to $1,000 for me to get an MRI scan. So MRI scan is great. It shows everything, but it overreads pathology.
Thank you very much, Dr. Vaccaro. I think we've got to move on, and we are very, very grateful for you to make time and join us today. If you could stay for the next.
No, I'll be on. I'm going to turn it off because my kids are making too much noise. I apologize.
So I invite our ASSI president, Dr. Chabra, for his talk. And his talk is going to be on the relevance of whether patients with severe spinal cord injuries, should they be treated in cervical trauma? Should they be treated, or is treatment really worth it in today's day and time, or should they be left alone? As I said earlier, Dr. Chabra needs no introduction, and I would request the BSS tech team to start Dr. Chabra's presentation, please.
I want to start by thanking the organizers for giving me this opportunity to talk on cervical trauma and spinal cord injury. Is surgery really worth it? We know that subaxial cervical trauma is one of the commonest causes of spinal cord injury, accounting for around 14% in one study. But more importantly, it has devastating effects associated with these injuries, which include tetraplegia, permanent disability, respiratory dependency, and sometimes death with a mortality of 15 to 20%. The vertebral lesion can be managed either conservatively or surgically. The topic, as has been given to me, may mean to say, can't all cervical spine injuries be managed conservatively? Or does surgical management add value? The goals of treatment, as we know, are attainment of spinal stability to prevent or limit neurological deficit, promote neurological recovery, and provision of an appropriate healing environment that will result in a stable and pain-free spinal column for the long term. Historically, most spinal injuries have been managed successfully non-operatively. Hippocrates first advocated postural reduction and traction. This was later supported by Malgaian, Sir Charles Bell, and other stalwarts like Sir Ludwig Guttmann, Frankel, Bedbrook, and others. Worcester was the earliest advocate of surgical management. Dixon et al. First introduced Harrington rod technique, as we are all aware of. In 1807, Sir Charles Bell wrote a treatise advocating conservative treatment, mainly as an attack on Sir Ashley Cooper, who advocated a more belligerent and operative attack on a condition where death would be the reaper anyway. Controversy has thus raged for over 150 years. The proponents of surgical management talk about the hazards of non-operative treatment, like complications related to prolonged recumbency, increased hospital stay, potential for development of increasing kyphosis, progressive neurological deficit secondary to increasing deformity or late degenerative changes, and severe incapacitating back pain. They also say that surgical management provides optimum environment for neurological recovery, facilitates early mobilization, thus avoiding adverse systemic and psychological effects related to prolonged bed rest. It provides an opportunity of commencing rehabilitation process earlier. It reduces difficulties of nursing care and decreases the overall expenses. However, on the other hand, the proponents of conservative management talk about the risks involved with operative treatment, and they label quite a few, as is also available in the literature. And they also say that since there are comparable or better results achieved with conservative management, why go in for a surgical management? So do we have the answer on whether we should go in for conservative or surgical management? And if we were to consider this, what are the points in consideration? I have been able to recall these points and will be discussing this briefly over the next few minutes. And we also need to see if there are special considerations for emerging countries where 80% of the population across the globe lives. When it comes to neurological recovery, Biological rationale for surgical treatment has been to attenuate the secondary spinal cord injury mechanisms in the clinical setting. And there is experimental evidence that persistent compression of spinal cord is a potentially reversible form of secondary injury. Experimental model studies in favor of surgical management have consistently demonstrated a beneficial effect of early decompressive surgery. However, the relevant interventional timing in humans remains unclear. So there has been a literature in favor of surgical management, and especially the proponents talk about the incidence of neurological deterioration in the non-operative group, which in various series has ranged from 17% to 10%. The recovery of neurological function after delayed decompressive surgery, months or even years post-injury, is also important. And although these studies were retrospective, the improvement in neurological function after the recovery had plateaued is worth noting. And we should also note that most earlier studies on surgical management had used laminectomy procedures. It is now well recognized that laminectomy as a sole surgical procedure in spinal cord injury is contraindicated. Moreover, with advancements in surgical techniques, the outcome may be in favor of surgical management. On the other hand, the proponents in favor of conservative management say that the beneficial effect of surgical treatment needs to be considered in the context of spontaneous recovery, which can occur in conservatively. So in the emerging countries, generally we have trained surgeons adequately available. However, there is a doubt about availability of skilled nursing and paramedical personnel required for active physiological conservative management. Now, coming to canal clearance, the degree of bony spinal canal compromise correlates with the incidence of motor deficit. However, those in favor of conservative management point out that immediate post-traumatic neurological status does not correlate with the percentage of neural canal encroachment. A non-anatomic result does not equate with a poor overall outcome. And they also talk about up to 50% canal compromise being reabsorbed through remodeling of the healing spine. And when it comes to emerging country context, there may be no possible considerations with regard to canal clearance. When it comes to early mobilization, there is literature in favor of surgical management, but proponents of conservative management say that early mobilization can be done. For example, they talk about even unstable burst fractures being mobilized early after a cast or a brace. However, burst fractures may behave differently, and most of these studies we know have been done on neurologically intact patients. When it comes to the emerging country context, surgical management may allow early mobilization, and this assumes importance due to the exodus of nursing and paramedical staff from emerging countries, looking for greener pastures in developed countries. And environmental and climatic conditions may have an effect in reducing patient compliance in using an appropriate cast or orthosis. When it comes to associated complications, there's literature in favor of conservative management where they point out to the more incidence of urinary tract infections, pancreatitis, and DVT in the surgical group. Whereas on the other hand, the proponents of surgical management point out to up to a 32% complication rate in conservatively managed patients, even by proponents of conservative management, and studies showing a lower overall mortality in the surgical group. There are other studies which show equal incidence of complications. With modern methods of respiratory and hemodynamic resuscitation, it has allowed such patients to undergo surgery, and minimal difference or complication rate between operative and non-operative cases has been demonstrated. When it comes to the emerging country context, modern methods of respiratory and hemodynamic resuscitation may be available for the acute management. However, we talked about the paucity of experienced nursing and paramedical personnel, and also humidity and heat may increase chances of complications in immobilized patients, and inadequate and suboptimal conditions in the hospital may increase the chances of complications. When it comes to hospital stay and cost of treatment, the proponents in favor of surgical management talk about length of hospitalization being 50% less in operative cases, whereas the cost may be 60% more. Then there is also evidence in favor of conservative management and other studies which show equal results in both groups. When it comes to the emerging country context, hospitals already overburdened with patients may find it difficult to accommodate patients with spinal cord injury for a long time, as required by conservative treatment. And thus, in these emerging countries, surgical management may have a role to play. When it comes to incidence of associated late complications of pain and late neurological deterioration, there are studies which show that late progressive collapse and kyphosis can impede rehabilitation by causing progressive neurological loss, inhibiting neurological recovery, and causing a painful deformity. And this is in favor of surgical management. Where they also talk about better results when it comes to pain, and they also point out to the requirement of late operation in conservatively managed patients. When it comes to proponents of conservative management, they mention that kyphotic deformity does not correlate with eventual outcome, and the progression is equal in both the groups. Similarly, with regard to pain, they say there can be better outcomes with conservatively managed patients. With regard to the emerging country context, there may be a less compliance for cast or brace due to climatic conditions, as we talked about, hence there may be more progression of kyphosis. And paucity of trained personnel may also contribute in this regard. Now, talking about return to work, there is literature in favor of surgical management. In the study by Day and Cochrane, they pointed out that 67% of patients treated conservatively had to make permanent employment changes to lighter work. And other studies which show that those operated surgically return to work faster. However, there are other studies showing good results with conservative management also in this regard. And there are no special considerations with regard to the emerging country concept for this factor. Now, the dilemma whether surgical management or conservative management is better, how do we move forward in this regard? The controversy regarding management of vertebral fracture causing spinal cord injury may be due to a lack of adequate knowledge of data and outcome. With advances in perioperative and anesthetic management and surgical techniques, early surgical management has been proven to be safe. Most earlier studies on surgical management had used techniques which are now known to be counterproductive. There has been substantial advancements in surgical techniques, and hence the outcomes may be in favor of surgical management. There is also evidence that early surgical intervention can improve neurological outcome. We are all aware of the outcomes of the Staskis study. There's evidence that even delayed surgical intervention after any spontaneous recovery has plateaued can improve neurological outcome. How many times have we seen immediate recovery in patients where recovery has plateaued and after we have put them to surgery? There's evidence that surgical management reduces the risk of progressive kyphotic deformity and syringomyelia, and that it also allows early mobilization. And now there are studies also that indicate that surgical management is more cost effective, especially in emerging countries. We're also aware that there are other considerations in emerging countries which may favor surgical management, as we discussed about. Unfortunately, even some professionals are still of the opinion that outcomes of management of tetraplegics are poor, and hence there is no point in wasting resources on surgical management. And that, in various conferences when they point it out, it pains us, because the awareness is low even amongst professionals that life after tetraplegia can be happy, meaningful, and worth living. And in our study, we saw that this lack of awareness may be very high and may contribute to neglect in up to 58.76% of the patients treated. And many of these patients back home for an unsupervised period at home, mainly due to lack of awareness amongst the professionals. So this makes us question, when we have to answer this question, is surgery really worth it? Rather than progress, has there been a regress? Are we again confirming the age-old adage of spinal cord injury being an ailment not to be treated? Whereas we know that many of these patients can lead a very active lifestyle per se and have been able to demonstrate this in the normal lifestyle. And we have algorithmic-based approaches towards management of most of the cervical spine fractures, where conservative management has a role, but surgical management also has one, and most of the unstable situations in all forms of cervical spine injuries. So the carry-home message would be, there is biological evidence from experimental studies that early decompressive surgery may improve neurological recovery after SCI, although the relevant interventional timing in human remains unclear. Role of surgical decompression or conservative treatment in spinal injuries is only supported by class 3 and limited class 2 evidence. Most of the better planned and recent studies in favor of conservative management have been on neurologically intact patients. Surgery for spinal injury can thus only be considered as an option. This may be for want of a well-designed, prospective, randomized, controlled clinical study which needs to be done. We know that there are inherent problems in doing such a study. Patients with spinal cord injury managed conservatively need to be in bed for a specified duration during which they require meticulous care. With inadequate and unsuitable management infrastructure, paucity of trained personnel, and unsuitable climatic conditions in emerging countries, surgical stabilization and mobilization may provide better results. However, there is a need for a proper study in this regard. Approach to management of a spinal cord injury should not be a knee-jerk decision. Each case should be worked up properly, and surgical or conservative management should be decided based on the merits. Also, surgical or conservative management is just one component of comprehensive management of spinal cord injuries, and they need to be given comprehensive management so that we can provide social justice to them and empower them to be able to lead a happy, meaningful, and worth-meaning life. Thank you for your patience.
Thank you very much, Dr. Chabra, for a very comprehensive and nice talk on this subject. I open this talk to the House for any questions. We would be glad, I'm sure Dr. Chabra is with us and he would be glad to answer. Whilst we wait for the panelists to ask questions, Dr. Chabra, let me go back to Dr. Vakaro's talk. At the Indian Spinal Injury Center, what classification system do you use for the cervical spine and for the thoracolumbar spine?
As you know, Gautam, we have a large number of consultants here. We have different philosophies here, but as per me, I am still of the age-old group which still follow the traditional techniques of traditional classification systems. So we have tried to modify the previous classification system of Alan Ferguson in order to incorporate stability in that and incorporate modifiers and also neurological status of the patient. And we tend to use that in our day-to-day practice. However, we are in the process of publishing that classification, but would want to say that the AO classification has stood the test of time. We are only trying to find out a system which can be more easily used by the fellows and the residents, and where many of the times if an MRI is not available, say like in 70 to 75% of the Indian patients, we could still on the base of an X-ray try to classify them. So this classification system has that benefit. Hopefully you will see this classification system published in the next 3 months or so.
Right. Now, there has always been a controversy regarding the timing of surgery in patients with spinal cord injuries. Suppose a patient has come with a subaxial cervical spine injury and a complete quadriplegia. What should be the timing of surgery? Should we operate if there is definite compression of the spinal cord? If the patient comes in the middle of the night, do you operate in the middle of night? Do you wait? There are some people who say wait for 48 hours. What exactly, where does this controversy stem from? And what is your answer to that?
Yeah, Gautam, we have also gone into the literature review at depth, and we are coming out with a Spinal Cord Society position statement in this regard. And we discussed this in depth in one of our previous BSSCONs. We believe that all patients of cervical spine injury with a neurological deficit have a physiological instability, and they may have hypotension or other elements of instability, and it is very vital to stabilize these patients before you put them up for surgery. If they are stable, the earlier you put them to surgery, the better. So the answer to your question is, have them in for surgery as soon as they are stable. But that does not go to say that all patients with a cervical spine injury need a surgery. You need to evaluate if they can be managed conservatively or need a surgical intervention. And if they need a surgical intervention, we need to go in for surgery earlier. Also, when it is a fracture dislocation, our effort is to try to achieve a close reduction as early as possible, so that we not only achieve an indirect decompression early if possible, but then the surgery becomes simpler when we need to go in for a surgery. So that is generally the protocol that we follow. If need be, we would even go in for a surgery at midnight if the need be, if the patient is stable. However, many of them would need stabilization. Also would want to point out that when the patient comes to you early, it is very difficult to say whether the patient is complete or incomplete. Because many of the times the patient is in the phase of a spinal shock, and your neurological evaluation cannot determine. Many of these patients who look like an AIS-A at 48 hours evaluation will turn out to be AIS-B. And generally, it is well accepted that a neurological evaluation at 48 hours is generally the one which prognosticates the outcome of these patients.
Dr. Chabra, your take and some words to end this controversy of steroids in acute spinal cord injury.
Hopefully, you will see a meta-analysis from our center in the next 3 months per se also. So we have to go by evidence, and the evidence will come by a meta-analysis. So there have been, if I were to try to summarize what is the take-home from most of the studies which have been done so far, the main controversy is about the complications that are there with a high-dose methylprednisolone therapy. And all the studies have pointed out that the complications are there mainly if you use the NASCIS-3 protocol, where you extend the methylprednisolone usage beyond 24 hours. Of course, the evidence in favor of methylprednisolone is also weak, in that you should not expect a fabulous improvement in these patients. There will be only a few motor point improvement in these patients. But those who deal with spinal cord injury rehabilitation know the difference that can make to a patient if even one level improves. For example, a C5 level tetraplegic gains 4 motor scores and becomes a C6. It makes a world of a difference in the patient becoming almost completely independent with the help of a caregiver versus being a substantially dependent person. So there may not be a very good level of evidence, but there is no evidence also that if we give methylprednisolone as per the NASCIS-2 protocol, it is detrimental to the patient. So we hope to come out with a manuscript in the next 3 months and have it published. We are in the final stages of a meta-analysis in this regard.
Dr. Chabra, one question.
Yeah.
So my question is, in a country like India, where even today, I think 70% of cervical spine injuries with complete cord injury happens in villages, where forget spine surgeons, forget rehab specialists, we don't even have trained specialists to reduce the fracture there. How do you foresee establishing a consensus statement percolating and penetrating the far corners of our country where, as you just mentioned in your slides, that the treatment management starts on day 1 minute. Like if it is 1 minute, what is that baseline treatment that one should aim at getting the moment patient with spinal cord injury comes to any center? So like for all our peripheral delegates who are listening to us.
The first and foremost principle of any treatment is do no harm to the patient. So the patient should not deteriorate with your treatment. And that is the first and foremost thing. So you have to start with a treatment that you are well versed with, and we have to realize that the management of the patient starts at the site of the accident. The single most important factor which has the most impact on the outcome of spinal cord injury is pre-hospital care. And unfortunately, that is a component which is sadly missing in our society, and we haven't done much in this regard. But even when the patient reaches the hospital, in a tetraplegic for example, acute management has a very important role. So to maintain the mean arterial pressure of this tetraplegic patient may be more important than an early surgery. And the hypotension that may come in an early surgery, if you do not have good anesthetists, may do much more harm than the benefits of a good surgery. So we have to see this person as a whole. Surgical management forms one small component of the entire management of the patient, and we have to comprehensively manage the patient. And for God's sake, don't send the patient back home after you surgically manage the patient, because the real other component of management which helps the patient get back to a normal lifestyle is comprehensive rehabilitation. So refer the patient to a comprehensive rehabilitation center if you do not have the facilities in your place. Now, we have come out with an ISCOS, Spine Trauma Study Group grading, like you have the grading for trauma centers. So we have come out with a grading for spinal centers. And there we see how comprehensively within a country, within all the existing setup, you can implement a setup where all patients can be managed properly, not putting a stress on the tertiary level centers and dividing it amongst the whole center. So hopefully you will see this publication also soon coming up. It was the topic of a workshop in the recent ISCOS meeting. And we hope to share that with you also soon.
Thank you very much, Dr. Kabra, for a very, very comprehensive talk and some lovely words of advice regarding the management of this difficult problem. I would like to invite my co-convener, co-coordinator, Dr. Mihir Bapat, to actually summarize the lecture of classifications of the spinal fractures in a few words, please. Mihir?
Thank you, Gautam. It was really a very interesting session, and Professor Vaccaro went through various classification systems. Actually, it's very interesting that he said that to be an academician, you need to memorize in details the AO classification versus if you are a clinician, you need to remember the SLIC and the TELE classification in details, because it's a very sort of practical classification system that you can use. Amidst all this, Dr. Chhabra has brought out a very, very valid point that you need to take all trauma patients as a whole. You need to really balance their physiology with their radiology, with their clinical picture, and select the best possible management that is available in a particular scene at your hospital. Do not jump into surgeries at the earliest, because it can do more harm than good to the patient. And finally, the aim of any trauma management is to see that the patient is rehabilitated in the best possible way as possible. Thank you, Gautam.
Thank you, Mihir. And with that, I would like to thank both the speakers of this session for the excellent lectures and the amount of information they have imparted to us. And I take you to an even more exciting topic, and that is minimally invasive surgery, where I hand over the mic to Dr. Arvind Kulkarni, our own minimally invasive expert from the Bombay Spine Society, who's going to take you through this session. Dr. Kulkarni.
Okay. Thank you so much, Dr. Gautam and Dr. Mihir, for conducting a wonderful session. Before we move on to the next session, may I call upon Dr. V.T. Ingalhalikar sir, the patron of this session, to please extend a small vote of thanks to our speakers of this session, Dr. Vaccaro and Dr. Chhabra. Dr. Ingalhalikar sir.
The most important thing I've thought about both these lectures was they were thinkers' lectures, and they were not only summarizing lectures. And they gave us viewpoints, they made us think about it, and whatever path we follow, we should be able to make a good, give a good care to the patient. Well, I thank both of them for such wonderful, elaborate talks. Both of them spoke from a very long experience of managing spinal trauma, and I think their words are valuable to all of us. And I'm sure the younger ones, younger surgeons, will definitely benefited by this. Thank you both again.
Thank you, Dr. Ingalarika, sir. Over to you, Uday, to start the session next. Uday.
So thank you, Vishal. So we swing on to the next important topic for the evening, which is minimally invasive spine surgery. And as alluded by Dr. Zaveri, I welcome Dr. Arvind Kulkarni to chair this session. And please introduce the panel. Dr. Kulkarni, please.
Also, we have with us Dr. Nikhil Arbati and Dr. Pramod Lokhande, who are also joining us as the panelists for this session and joining Dr. Arvind. Over to you, Arvind.
Hi, thank you, Vishal, Uday, and Gautam for this kind introduction. COVID has taught us to be minimalistic, and we have Dr. Larry, who is a champion and pioneer of minimal invavism, and if you can blame someone for disrupting the fusion technology, it is him, because he is he participated in the first MIS TILIF done ever, and later on he has been the star surgeon to most of the Hollywood actors, and he's always been a friend of Minimal Invasive Spine Society. In fact, he gave 7 lectures when he was invited to Mumbai last time, and he also demonstrated a case which was relayed live from Bombay Hospital. Later on, he has conducted many workshops in Bombay and taught a lot of young spine surgeons in minimal access. And once the COVID scare disappears, I would advise the young budding surgeons to visit his center in Los Angeles to learn tips and tricks of minimal access from him. Over to you, Larry.
Thank you so much for this kind honor to participate. I think I sent my recorded lecture earlier, and perhaps because of bandwidth issues, that we could play it that way, and then I'll be available, of course, for questions. Would that be okay?
Sure.
Tech team, please play the video.
Thank you. Is the volume working?
Check the volume.
I can hear it very lightly.
So while Larry sets up the talk there,
Vishal, I would suggest that since Larry is live, maybe he could play it from his computer rather than going through the BSS.
Yes, Larry, do you have a slide with you?
Yes, I have it. I could pull it up right away if you'll give me one moment.
Yes, please. Let's do that. You have the share screen option. Please go ahead and do that.
Yes, sir. I will do that right now.
So Neetu, please ask the tech team to off the video, please. We'll have Larry going live.
Sure. Tech team, take off the video.
Meanwhile, we are joined by Dr. Larry Lenki also from Bombay Spine Society. We welcome Professor Lenki to joining us. And while this session is coming up, while Larry Koo is setting up his point and he's going to prove that tubular MIS is the way to go, we have another big, strong contentant there, Kim from Korea, who's going to prove us the endoscopic fusion and the future of MIS surgery is going to come up, and he's going to tell us that we are not stretching the limits of endoscopy here. Over to you, Larry. Please share your screens.
Let's see. One moment here. Having a small problem. Sorry. Perhaps I'm having some problems sharing my screens. The security issues won't let me go. Could we have them?
Can we come back to you and we can have Kim to get his talk first?
Yes, please go ahead. Thank you.
Pramod.
Actually, do you think that you can have your tech just run the video and I can just talk over it? That might be the best way.
We can do that.
Let's do that. I'll talk right over it. No problem, since we have good connection.
Yeah, we are sharing the screen.
Could start it again. Thank you so much.
Yeah. Tech team, Dr. Ku's presentation, please.
Okay. Thank you so much for this wonderful opportunity to kind of participate and share with our experiences with minimally invasive spine surgery over the last few years. If someone could advance the slide, that would be wonderful.
Change the slide.
Change the slide, tech
Yeah,
team.
next slide.
I think it's a video.
ऑटोमेटिक हो रहा है मैम ये.
Video playing, please.
It's on, sir. So just give us a moment. The video will be there. The volume will be there.
Yes, it's started.
There it goes. Thank you so much. So, thank you. As we share our experience with the last 20 years of minimally invasive microtubular MIS, the question has always been, where do we start? Where are we heading? And what can we expect to see over the years to come? And if someone could hit the button, I'm not sure why we're not advancing. Okay, well, let's see.
Next slide, please.
It is said in Ecclesiastes that what has been will be again, what has been done will be done again, and that there is nothing new under the sun. Rather, I would put to you that our experience over the last 20 years has shown very clearly that we can grow and that we can transform what we do into something better for our patients. In the early and mid 90s, tubular lumbar discectomy techniques were introduced with the use of endoscopic minimally invasive discectomy. These allowed for discectomies to be performed under small incisions with tubular access, thereby reducing trauma to the musculature and the ligaments posteriorly. However, the lumbar microdiscectomy is an excellent operation that is very difficult to improve on. Even despite prospective, well-controlled trials, the superiority of a simple tubular discectomy could never be shown over a well-done small microsurgical lumbar discectomy, with no differences in length of stay, postoperative recovery, return to work, and overall complication rate, despite the much smaller cosmetic operation. However, the lessons learned from microscopic tubular discectomy were then extended into a larger operation for bilateral laminotomies for true spinal bony stenosis decompression. Early work began in the 1990s and then was subsequently compiled and published in 1999 and 2000 in our work from Chicago, and also subsequently from previously from Dr. Foley's work in Memphis, Tennessee. Through these techniques, we found that minimally invasive lumbar decompression of 1 and 2 and even 3 level spinal stenosis bilaterally could be achieved, and decreased complication rates could also be achieved as well. When we looked at open decompressions for 1 and 2 level laminectomy, despite the fact that it is a very good operation in terms of achieving spinal stenosis decompression, there were significant complications, both regards to wound hematoma, soft tissue complications, and infections, and also subsequently the need for blood loss, transfusion, and blood replacement. Thus, it became a question: could we take the minimally invasive tubular lessons we learned in discectomy and achieve wider bilateral laminotomy decompressions, preserve all the muscular ligamentous attachments, decrease perioperative surgical morbidity, and improve long-term outcomes. In 2005, as our experience grew over 5-6 years, we compared minimally invasive tubular lumbar decompression techniques with classic open techniques and published our results in orthopedic clinics. In a single institution prospective trial comparing minimally invasive tubular 1 and 2 level lumbar stenosis decompression versus classic open muscle stripping laminectomy, what we found was significant benefits both in the short, midterm, and long-term windows. After surgery, we found that because of less tissue destruction, less pain, minimally invasive tubular decompression techniques would allow patients to leave in 24 hours in the vast majority of 2/3 of our patients, whereas only 7 to 10% of open laminectomies could leave within 24 hours due to complications and postoperative pain. However, in the mid to long term, did we achieve equivalent neurogenic claudication benefit? And the answer was yes. Minimally invasive techniques did not shortchange the neurological outcomes of the operation. However, when we looked at the perioperative complication rates due to pain, stasis, and inability to walk, we found that open laminectomy patients were clearly associated with a higher incidence of pneumonia, urinary tract infections, DVTs, and wound infections, whereas minimally invasive techniques were associated with 3 to 4 times a lower incidence and rate of these complications. Now, long term, as we preserve the musculoligamentous attachments of this muscles, ligaments, and tendons by minimizing the amount of bony removal required to decompress the nerves, we found that long-term instability, new imaging slip, recurrent stenosis, and need for subsequent fusion also decreased with minimally invasive 1 and 2 level tubular decompression versus open midline laminectomy. And thus, when we calculate the quality of life year benefit, open laminectomy is an effective operation, but costs about $13,129 to achieve one quality of life year benefit. With minimally invasive tubular laminotomy and spinal stenosis decompression, we found that cost decreased to $10,980 per quality of life year, and thus gaining our patients benefit with regards to short, midterm, and long-term complications and sequelae versus laminotomy. At the same time we learned these lessons for minimally invasive tubular decompression, so too did we begin to learn lessons with new technologies such as minimally invasive screws, which were being developed with long extension sleeves to allow for mini open or percutaneous placement of these screws and for fixation and reduction and rod placement as well. This, of course, combined with tubular techniques, opened the way for minimally invasive lumbar inner body fusion techniques. Our first publication of minimally invasive PLIF, or percutaneous posterior lumbar interbody fusion, was completed in 2002 based on 2 years of work in cadavers and our subsequent initial series. This was work done in Chicago with Richard Fessler and also in work done with Memphis, Tennessee with Dr. Kevin Foley and Mo Smith. Using minimally invasive new alpha prototype screws as well as minimally invasive tubular interbody techniques, we were able to perform bilateral posterior lumbar interbody fusion in relatively high-grade cases such as this grade 2 mobile spondylosis with significant spinal stenosis and slippage and collapse. Furthermore, tools were being developed for the minimally invasive screws to allow for reduction and distraction all above the skin, again obviating the need to strip the muscles off the spine, as you can see here. So with tubular decompression, reduction, distraction,
a series of interbody distractors, the interbody space is then distracted on the ipsilateral side under fluoroscopic guidance.
Here you can see the pre and post with the full restoration of lumbar interbody height, lordosis, and correction of the spondylolisthesis, all achieved through small 2 percutaneous incisions with minimal blood loss, short length of stay, and relatively decreased narcotic requirement after surgery, all done through 2 small muscle-sparing incisions. There is the AP correction as well. Looking at our 4-year outcomes and experience, we published these in 2010 with myself and several of my co-authors and fellows. We looked at over 144 consecutive cases of minimally invasive TLIF compared to same institution control series of 54 open. And we found very similar results to our lumbar stenosis studies. By preserving the musculoligamentous complexes, decreasing soft tissue stripping and damage and exposure, we were able to achieve significant benefit for patients. With regards to length of stay, we had almost half the length of stay, 1/5 to 1/6 the blood loss, and a decrease in operative time as well. Outpatient fusions were achieved in almost 1/4 of cases, and 39% of one-level cases, or 40%, were able to leave within 24 hours of a one-level minimally invasive fusion. With regards to their ODIs and their long-term pain scores, we not only saw equivalency at 1 year and 2 years, but at 3 and 4 years, we saw statistical benefit in terms of less residual back pain, less adjacent level ODI back pain in the minimally. Reoperation rates, like in lumbar stenosis, were also decreased in the minimally invasive group, with less reoperations for infections and hematoma drainage and less reoperations for adjacent level degeneration, as you can see here at 4 years. Thus, when we looked at the quality of life years and the cost directly to the hospital and indirect costs over a 1-year period, we found that because of decreased infection rates, decreased transfusion rates, decreased length of stays, that we on average saved $1 million per 100 cases in the United States. So in other words, for every single case, we saved on average $9,295, or call it $10,000 per case, by decreasing those parameters, with again 22% of one-level fusions done minimally invasive able to leave within a 24-hour period. Thus, with the 4-year data, we clearly show that minimally invasive TLIF techniques were superior with regards to 1 and 2 level degenerative disc disease and spondylolisthesis case with regards to operative time, blood loss, perioperative complications, 6 weeks and 3-month pain scores, not to mention 3 and 4-year long-term ODI scores, decreased global direct and indirect costs, and a decreased infection rate as well. Thus, like the quality of life year calculation for lumbar stenosis, we found that for spondylolisthesis fusions, we could also achieve almost a $5,000 quality of life savings per year to achieve 1 good year of quality of life for our patients in spondylolisthesis, thus representing a significant cost savings to the system. Then, using the lessons learned from 1 and 2 level minimally invasive TLIF and posterior lumbar interbody fusion techniques, we begin to apply these to larger operations of flat back deformity and scoliosis as well. Here you can see a classic flat back kyphoscoliotic deformity with multi-level degenerative disc disease. And this is where we took our lessons of tubular approaches to modify what we would call classically a flank approach, or lateral or anterolateral approaches to the spine for deformity and trauma correction. Extremely morbid procedures that now, using the same minimally invasive techniques that we had just learned over the last 10 years, we begin to also apply this to anterolateral type or ventrolateral interbody techniques through tubular approaches, as you can see here, or what we call the direct lateral or the OLIF techniques. And this is where we began in 2006 with our direct lateral approaches through the retroperitoneal fat pad, minimal muscle splitting, and anterior to psoas or transpsoas techniques to achieve very large interbody grafts placed in the anterior column, thereby allowing us to correct significant kyphoscoliotic segmental deformities. Then also we learned additional lessons by releasing the anterior longitudinal ligament, or what we call anterior column release, through these lateral and anterior to psoas techniques. And of course, at the same time, interbody implants improved to create hyperlordotic implants, unified single standalone type implants, and implants with plates that again would allow us to not only correct the deformity, but hold it and hold correction in place. This, combined with minimally invasive multi-level raw derotation techniques, now truly open the door to allow us to do minimally invasive scoliosis corrections in a stage and often single stage setting to allow for rapid correction of what would otherwise have been classically a very big operation. Here, after we've achieved a 3-level lateral direct approach to correct the coronal plane, we use raw derotation techniques to then bring back the spine and do sagittal plane correction as well, all through percutaneous muscle-sparing, minimally invasive techniques. Here you can see the restoration of what was essentially a flat back deformity with a significant pelvic tilt of 38 and an SVA of 15 brought down to a pelvic tilt of 24 and SVA of 6, all through 3 percutaneous levels of screws, as well as 3 anterior to psoas or O-lift type approaches for a final lordosis of 43 degrees as opposed to 8 degrees. As we developed our facility with anterior to the psoas or trans-psoas techniques, so too became our confidence of doing more levels. Thus, naturally, from the direct lateral approach came our ability to do lateral corpectomies, what would classically be called the T11 or T10 rib approach. Instead of doing large thoracotomy approaches, we could now do fracture deformity corrections as well and achieve, again, large anterior column cages through a minimally invasive direct lateral approach. Here we can see expandable cages applied through a extended D-lift type technique through a D-lift type retractor and using the expandable cage to achieve corpectomy, trauma, and infectious osteomyelitis treatments through far less invasive techniques than the classical rib approaches and flank approaches that we've been classically trained to do. Here we see a T4, T5 pathological fracture dislocation and 3-column injury due to tuberculosis with kyphotic angulation, and you can see the abscess there. Applying our lessons similarly to the T-lift and posterior techniques, by extending the T-lift technique, we could now do minimally invasive, less invasive, minimally invasive extracavitary approaches with corpectomy as well with percutaneous screws. We published these initial experiences in 2011 showing percutaneous screws and expanding corpectomy approaches all through relative muscle sparing and far less morbid approaches than we've classically used for extracavitary corpectomy. Here you can see the typical corridor and the way we place the cage, and with the advent of expandable cages and percutaneous screws, we can now take a very classically large operation and reduce its soft tissue mortality, but without shortchanging our deformity correction, resection of tumor, treatment of fracture, or debridement of abscess. Here you can see corpectomies of T4 and T5 through a less invasive retractor, the spinal cord fully decompressed above the cage, and the cage is being expanded in place with local bone graft to achieve post-osteomyelitis infection correction, deformity correction, all through far less invasive techniques than classically used in open surgery. Then combined with percutaneous contralateral screws, we're able to achieve additional correction at the same time and fixation as well. And here you can see the pre and post-operative correction and the surgery length of 4 hours and 30 minutes with a relatively low blood loss, no chest tube, and a rather improved post-operative recovery and approximately a 50% correction of the kyphotic deformity as well through these 2 minimally invasive paramedian muscle-sparing approach incisions. So, over this period of time, over a decade from tubular discectomies, we were able to move rapidly forward to not only achieve corrections of compression, distraction, sagittal reduction, coronal reduction, better sacral fixation, combining vertebroplasty techniques percutaneously, anterior spinal column resection, as I've showed you through lateral and posterior extracavitary approaches, and achieve limited derotation and posterior lateral fusion. In other words, minimally invasive tubular techniques were no longer just used for discectomy where we could not prove benefit, but now we were able to achieve even large traumatic, scoliotic, and post-infection decompressions and deformity corrections as well. With the ISSG group, they looked at a prospective non-randomized multi-center evaluation of extreme lateral approaches for the treatment of adult scoliosis, and they found that the MIS techniques had a far lower complication rate by almost threefold when compared to open front-back type approaches. After surgical treatment for the adult deformity, if we look at the cost effectiveness, the quality of life year cost to achieve scoliosis correction in 540 patients was nearly $120,000. As such, this is an extremely expensive morbid operation, and thus opens the question, can we do better? We were able to decrease the quality of life year cost for lumbar stenosis, for spondylolisthesis with TLIF and PLIF through minimally invasive techniques. So could we apply these same techniques to open scoliosis correction, which is an extremely morbid, expensive operation? And with minimally invasive techniques, initial studies show that we could achieve almost $22,000 to $25,000 cost reductions. And keep in mind, in the United States, we consider anything under $100,000 quality of life year threshold a possibly useful operation. In its present form, at $120,000, these are operations that simply cannot be sustained over time in a healthcare system. But by dropping it by $24,000 with the use of these minimally invasive tubular decompression and fixation techniques, we're able to achieve at least a somewhat more reasonable outcome with, again, a great deal of room for improvement. So, over the last 14 years, what have we done? Over the last 24 years, what have we done? We are now able to treat the vast majority of spinal pathologies through less invasive tubular techniques, from discectomies to laminectomies to facetectomies, foraminotomies to corpectomies to deformity correction and fracture and trauma stabilization, all through minimally invasive percutaneous and tubular corrective techniques, with lessons learned the hard way over 24 years. So, what has minimally invasive evolution done? It has reduced morbidity, improved functional recovery for our patients, improved both short, mid, and long-term overall outcomes, decreased complication rates, and we can now achieve the vast majority of these decompressions and a significant portion of fusions, all as outpatients, again decreasing costs and lengths of stays for our patients. However, we see for larger operations like deformity operations, there's still a great deal of room for improvement and advancements to bring the cost of these procedures down and make them more accessible to the vast majority of healthcare systems. So, rather than there not new under the sun, I would answer what Heraclitus said in Greece. In truth, there is nothing new under the sun. In fact, the only truth is that the only constant in life and spinal surgery is change. Thank you for listening. And again, my deepest thanks to the Bombay Spine Society for this wonderful opportunity to share our experiences and a walk down memory lane for us and all the lessons we've learned, and also to suggest that there are still many lessons to come. I hope that you all have a wonderful meeting, and hopefully I'm available for questions at this time. Again, thank you all.
Thank you very much, Larry. Fantastic talk. Reminds us of your talk when you came and attended our MISI conference in Bombay 5 years back. Now there is a question from Dr. Satyan Mehta, who happens to be a minimal access spine surgeon from Bombay. He asks you as to how do you connect lower incidence of ASD with minimal access surgery?
Fundamentally, I think we all understand that minimally invasive surgery's great benefit is sparing of all the soft tissue structures. I used to work with Dr. Manohar Punjabi in a biomechanics lab at Yale. And one of the things he always taught that was we could never truly measure the importance of, for example, something as simple as the interspinous ligament, which is an aponeurosis of all the muscles attached to the spine, because that cannot be measured in cadaveric biomechanical studies. But in open surgery, we have forever been doing procedures to optimize that transition between the solid fused segment and the level above. And we do things like topping off, wiring, fiber wires, dynamic stabilization, all these kind of things. Minimally invasive surgery thus by doing it appropriately, using natural muscle plates, not detaching the muscular ligamentous attachments, both anteriorly and posteriorly, preserves that and essentially is a functional topping off type of surgery. And as such, it decreases in many cases, not all, of course, but in many cases helps to reduce the forces and parameters that are at play that cause adjacent level degeneration, that cause PJK. Of course, if you don't get appropriate lordotic corrections, you don't correct the sagittal parameters and the pelvic parameters, you're still going to be at risk of it. It's not totally preventative, but it's another thing we can do to help reduce the incidence of ASD by preserving the natural muscular extensile structures, which will keep the spine from falling forward.
There's another question from Dr. Uday Pawar, who happens to be a organizing secretary of the conference. He asks you how you do you deal with only one level stenosis with decompression with MED, or you also do multi-level MEDs for multi-level stenosis?
Yes.
So what is the maximum number of levels you've done using the tube?
I know this sounds terrible to say, but we get tired, and that's the God's honest truth. So for us, typically, we will often instrument multiple levels, 3-4 levels, 2-3 levels, but we try to focus our decompression on where it's needed. As a neurosurgeon, one of the things that I've had to learn, and now I completely believe in, is the concept of indirect decompression from foraminal and foraminal and lateral, and to some degree proximal lateral recess stenosis. But sometimes there's large central stenosis, large facets, and no indirect ligamentataxis and elevation of vertebral height will treat the stenosis. So the answer to the question is, when we're doing straight stenosis, for us 3 levels is the number. After 3 levels, simply put, bilateral decompressions through a tube. Each level takes us about 30 minutes, and that's how we mentally break it out. And so that's sort of the typical pathway. So if we have to do more than 3 levels and instrument at the same time, oftentimes we'll think about some type of staging, like do the anterior reconstruction through a direct lateral approach or a straight anterior approach, then come back and instrument and decompress in a separate setting. So all at once versus single stage versus staged over a few days. And so that's a very important consideration, because these are older patients typically, and anesthetic time must be considered.
And just an extension of this question, if you have stenosis at L2-3 or L1-2 and there's no instability and you just want to decompress, how do you use the tube?
Yes. In those cases, as I think you're hinting at, Arvind, the difficulties, the pedicles are very close together, and the facets are very vertical and they're very small. So what we typically do in L1-2, L2-3 junctional kind of decompressions, which are fairly rare, interestingly, but oftentimes seen in ASD after a prior fusion or prior spontaneous, stiffening of the lower spine. What we do is we make sure to really, as much as humanly possible, obey an interlaminar technique, less of a T-lift trajectory and more of an interlaminar technique, and sometimes even going bilaterally to get kind of a biportal approach, all in a deep, deep effort to spare the facets, because we all know it's very difficult to do an angular approach to the very often vertical facet orientations of L1-2 and L2-3. And in those cases, oftentimes, like Ed Benzel would always teach at the Cleveland Clinic, that we would often either do kind of a pseudo arthrosis, lay down a little bit of bone around the transverse process and facets, just to kind of get to stiffen up or to achieve a kind of a stable pseudo arthrosis, if you will, because of the fear of the destabilization, even from a minimally invasive tubular discectomy. Again, we're talking about hard bony stenosis, not just a herniated disc. But in those cases, you have to think about all these kind of things. And that's where, to your point, Arvind, we will often go through a biportal approach in a massive effort to spare the interspinous ligaments, spare the facets, and even just go lay down a little bit of bone around there just to get the facets to thicken up a little bit more posteriorly and decrease the chance of post-decompression iatrogenic instability.
Okay, there are a stream of questions for you. The next one is from Dr. Vishal.
So, Dr. Koo, 2 questions from me. I think both of them are straightforward, and I'm sure you will give a full toss and a sixer for this on me. How do you propose reducing radiation in MIS surgery? That's my question number 1. Like, for all of us, we would want to know, how do you ensure that for all youngsters like us don't end up having cancer at the young tender age or don't end up being infertile for all the young guys. And my second question is, do you think that the evolution of tubular surgery has led to an increase in number of fusion surgeries, which probably shouldn't have been done and they could have been managed more conservatively or more in a decompression manner? But because MIS is available, it is probably trying to push in the corners and people are doing more fusions. Your word on that?
Without a doubt. Unfortunately, one of the byproducts of having all these wonderful tools, I mean, when a fusion is very hard to tune, it's very bloody, I think we all as thoughtful physicians will pause for a second and say, do we really need to do that? Just like spinal cord injury, do we need to treat it? These kind of questions, the indications. Unfortunately, if you buy a minimally invasive access system, you have it readily available, and you also, for example, touching on your first question, have a robot or image guidance system, then it becomes easier and easier. But like the saying goes, a fool with a tool is still a fool. And if we stretch our indications, we will still cause great morbidity, unnecessary morbidity, and complications, both soon and down the line to our patients. So clearly, I think what was said in the earlier lecture about spinal cord injury must always be kept in mind, in the sense that the indications don't change. And that's a really, really important lesson we teach our residents and fellows, because it becomes so easy. You don't have to think about putting pedicle screws in. We now have a robot that will kind of do it for you. And so those are the reasons that I think, I know this sounds strange coming from my mouth, but I believe that residents and medical students should still be trained the classical way. And we should do open surgeries for a while, see the indications, see the complications, think about the indications for adult deformity correction, for example, and not change that. Don't kind of loosen your parameters, because minimally invasive surgery is wonderful. Yes, there's less morbidity, but again, long-term problems will still occur. And finally, to answer your question, Vishal, which is always the big white elephant in the room, in the sense that radiation is extreme. I didn't show the slides, but one or two of the slides showed some of the radiation exposures. But our radiation exposures are 5 to 8 times higher with minimally invasive surgery. And so one of the biggest things that I would advocate for anybody who wants to really start going down the road of minimally invasive surgery, not having more children, but having more children with 10 fingers and 10 toes, is to make sure that you have a good image guidance system, if at all possible. Of course, eventually, previously we had stealth and 3D navigation type technologies, which we implemented in the last 10 years, that cut radiation quite a bit. The accuracies of those systems have gone up quite a bit. Intraoperative CTs to register the patient are very, very good. And now we have a lot of virtual reality systems coming on board online that even decrease the radiation expenses further. And those weirdly are cheaper, because they're like heads-up displays and things like that we've been working with in the last few years, that make it less like a giant system that you have to use, and more of like your iPhone, looking right down on the technology. So with those, we can cut radiation and then make minimally invasive surgery, because that literally is the final wall. It's to this day the reason that only 1 out of every 4 American surgeons uses minimally invasive techniques, because of the fear of radiation, Vishal, which is a very good found fear. I am 100% sure I'm going to die early from cancer from all the radiation that I've been exposed to in the last 20 years. So, but that having been said, and then there's just a little basic trick. Make sure all your students and fellows are bigger than you, so that way when you're doing surgery with them, you can hide behind them. So, and that's a very important thing as well too. But no, in all seriousness, I think virtual navigation, intraoperative imaging, these are very, very important technologies to use, and to always, to your point, be cognizant of the radiation exposure that you're giving yourself, the patient, and then most importantly, your staff and your residents and your fellows.
So Larry, thank you very much. There are tons and tons of questions, but we are caught by time. And
Arvind,
counterpart from
Arvind.
Yeah, Dr. Ingela.
Yeah, I think Larry made a very, very valid and important point here, that before you to get on with the minimally invasive, you must have enough experience of an open surgery. I think 3-dimensional, if you don't understand the spine, probably you're not going to do as good with a minimally invasive technique. So these are the tools, but the 3-dimensional understanding of the spine will come basically from open surgeries only. I think you've got to prove to yourself that you're a good open surgeon. That's a very, very important point, and I think that is one of the important take-home messages for youngsters.
Sometimes it so happens that we convince the patient for open surgery so that our fellows can do something.
That's right. And also, sometimes all these fancy machines, they shut down. Just the other day, we had the stuff, everything shut down. So I had a call from one of our younger colleagues who had never put in cervical screws, for example, without image guidance. So I had to come in and teach him classical anatomic position and technique to put transarticular and cervical pedicle screws in. So I think it's critical because these are tools. They are not intended as shortcuts, and that's very important. Plus, that way you know when the machines are lying to you, you know.
So that was Larry King of minimal access. Now we invite Dr. Kim, who is the champion of endoscopy. Dr. Nikhil will be introducing him. Over to you, Nikhil.
Yeah. Thank you, Arvind, and thank you to BSS. So today the topic for the MISS, we have got Dr. Kim with us, who is from South Korea. He is a great proponent of endoscopic spine surgery. I know him personally also, having worked with him in Buridul. And he performs majority of all his surgeries through minimal invasive endoscopic. And without further wasting time, I would invite Professor Kim to give his talk about endoscopic spine surgery and its limitations and if there are any fallouts of it. Over to you, Professor Kim.
Thank you for your kind introduction, me. So it is not good for me to have a talk behind Larry, the great presenter MIS, right? I'm beyond excited to join the annual meeting of the Bombay Spine Hospital. It's truly an honor to grab a chance with the world-renowned spine surgeon from the world. The title of my topic today looks a little bit difficult to figure out the general frame. Please forgive me, my talk does not reach out to the highest level of evidence, more experience-based or eminence-based. Please enjoy. Hello, everybody. Please allow me to introduce myself. I'm Professor Sung Kim, working in Seoul St. Mary Hospital at the Catholic University of Korea. So today I'm going to talk about the MIS endoscope, the indication and limitation. Are we stretching the limit? Just to bring you guys up to speed about today's lessons, let's move on to the topic content today. So it's about the indication and limitation. Actually, this has been constantly changed over time. So I personally recommend my recent paper about the evolution of interlaminar endoscope, the evolution of transforming endoscope, and recent technical advancement of endoscope. And this paper is Asia Truly Hospital, a contemporary MIS and endoscopic spine surgery, which are published JSS and World Neurosurgery. Before we going further, it is truly important to figure out the history of the endoscopic spine surgery. So I also reviewed this three paper, the history of endoscopic spine surgery and technical advancement in the spinal surgery for stage management of painful spine condition by Michael Meyer and Revendrowski. This is the funny metaphor of the timeline of the age. So I'm gonna use this metaphor for describing the endoscopic spine surgery from the prehistoric age, Paleolithic age, and the Mesolithic and Neolithic age. In the Neolithic age, finally we see the name of Cambion, his kata. And also Martin Knight, he firstly introduced the concept of the foraminotomy using a razor. And the Michael Meyer officially used the name acronym PELD first in 1992. And finally, we are facing the very familiar name. It's renowned two surgeon of Tony Young and the Tom Hugeland, 1998. This is the chronological development of transforaminal endoscopic spine surgery. I'm going to highlight the history and main event, achievement, and the main surgeons described in cornerstone. So actually, the industries, they have developed and launched the each generation of spinal endoscope, from the BSSCON to vertebrae, lumbar, and stenosis. So in the past, we just treat the contained disconnection by simple targeting through the Campbell triangle. And presently, so we are able to treat the most of the herniated disc and the central stenosis and foraminal stenosis, but we still have some questions. Effectiveness of spinal endoscope for the treatment of severe spinal stenosis and the inner-body fusion. That's why some of the trailblazer endoscopic guides in Korea, they developed and expanded the bipolar endoscopic spine surgery. So finally, we are facing the era of turning the big ship in the spine surgery, especially in the United States. There is a changing market, code number 62380. That is a new CPT code for endoscopic spine surgery. So I believe most of the MIS decompression could be replaced by the endoscope, and limited cases, number of the fusion can be available also by endoscope fusion, etc. So Michael Meyer already noted most of the microscope surgery could be replaced by the endoscope with step by step. Let's think about the recent current changes. 2015, 5 years ago, first endoscope for spinal stenosis vertebral lumbar has been launched in Korea. And luckily, I have the first guy to use this endoscope vertebral stenosis in Korea. And later, so other company, they launched the decompression scope, large scope for spinal stenosis. I used to have a lecture titled with the Can Full Endoscopic Spine Surgery Replace Open Surgery for Lumbar Decompression, 2016 and 17. Most of the participants, they usually answered partially yes, maybe no, and also indication for the question, how long does it take? Most of the participants, they answered 5 to 10 and more than 10 years. So see the key opinion leaders in the spine. Jeff Wang, he published his paper titled "The Scientific View of Endoscopic Spine Surgery: Can Spinal Endoscope Become a Mainstream Surgical Tool?" He noted it appears that the entrance of spinal endoscope into the mainstream arena of spinal surgery is inevitable. Recently, we have the most impactful paper that is a systematic review about the complication rate of different discectomy technique. By this paper, they concluded, compared with the open or microscopic discectomy, result of this meta-analysis suggests that transforaminal endoscopic discectomy has a low risk of overall complication. I also published the cost-effectiveness this paper of microdiscectomy versus endoscopectomy for lumbar discoloration. We compare the full surgical common surgical procedure for discectomy right there. So conclusion follows: transfemoral discectomy is more cost effective compared to the microdiscectomy. Also, I published a map of worldwide research productivity about endoscopic spine surgery from 1997 to 2018. So there are a lot of the papers are coming out every day, and more evidence is coming. Recently, I got a big research grant of Korean government, so we will start soon for kind of the randomized control trial, common surgical procedures. 7 university hospitals and 3 private spine specific hospitals will be going on conduct this randomized control trial. What about the recent change in the United States? There's an interesting report from the Becker's Spine Review about the endoscopic fusion and future of the spinal fusion. Many guys, they have highlighted the role of the endoscope combined with robot and artificial intelligence right there. And I'm gonna move on the cases. Probably you have more interest than this kind of review of article and the recent trend. This female, 79 years old female patient, have the high grade, the cuffs angle more than nearly 60 degree, and patient just have monoradiculopathy left side.
What sort of profession?
An MRI and CT scan. I'd like to find a real pain generator in this patient. Obviously, there is a foraminal stenosis and lateral stenosis at the 3-4 left side. For endoscopic surgery, we need to highlight find the real pain generator that is a target-oriented spinal surgery. If you consider the fusion surgery in this patient,
to getting here,
what kind of complication may happen? Like this, treat this patient using the endoscopic
soft tissue procedures
with the navigation guided because of a complexity in this patient. Under the prone position, attach reference frame on the patient back. Find the trajectory using the navigation and introduce walking cannula right there and put the obturator and introduce the navigation guided endoscope. So once we find the ideal trajectory and the targeting, we can go with the endoscopic foraminotomy and endoscopic discectomy. Because of time limited, I'm gonna show you guys the end of the compression status, radialysis, and the foramen as well. This is patient outcome. Sorry for converted the video clip. There's a well decompression of the foramen in this patient, and I followed this patient more than 6 months. Fortunately, the patient didn't have any aggravation of the cuffs angle. So let's move on. The another indication of the endoscope is role in malignant tumor. I mean, it's only the limited in the specific cases like this. Patient have acute onset progressive leg weakness, post-leg foot drop. You can find the canal occupying the mass not only spinal canal on the retroperitoneum. Patient have underlying have the CML and follicular lymphoma. So this is how I made the decompression. You can see the pre-op status having the both leg weakness. Patient have the pre-op weakness ankle, dorsiflexion, and plantar flexion weakness. And also weakness on the knee extension as well. And let's see the post-op improvement of the leg.
For addressing those.
So endoscope has also could be adopted in cervical myelopathy. This is junctional problem following the ACDF at the C3-4 level.
How I carry them out.
Patient
So
have
those-
acute onset quadriparesis.
That's sort of how the
By
chapter
the
is set up.
endoscopic decompression, you can see the well pulsating the cervical cord, right? So what about the other endoscopic spinal surgery?
Kevin, so, as
Special
Kevin,
case with the huge hemorrhagic vasculitis at cervical thoracic junction level.
condition,
Because the cervical
they look
thoracic
at
junction it is hard to identify the
radiographs
exact
or
level.
advanced imaging techniques.
So in most cases, if you want to do the decompression, you need to wide open to see the location.
How they
The endoscope, that is why the endoscope may need the health navigation. It is truly important tool to find the
tips
exact
and
targeting
tricks.
and location. This is another interesting
for
case.
each specific joint. in terms-
Once the corpectomy achieved, there's a remnant bony fragment there. So this kind of remnant bony should could
Not
be
just general
removed by the
run-of-the-mill-
endoscope assisted decompression.
Inflammatory or degenerative changes.
Their evolving
and also
technology
few
combine
pretty good tips and tricks
the
on-
navigation and endoscope for spinal fusion, right?
Ed, I'd like to now hand it
But
off to
sometimes I imagine I wish I use convertible
Deshmukh
scope
from,
or robot can decompression because in
Ajit has
the
been a
Korea and
mentor.
most Asian country, the expandable case is not available yet
on this book
because
and also
of
Ashok
cost
for putting us
itself, especially in the
on
endoscopic
this
fusion
platform.
cases. So in summary, there is a benefit shown of MIS. This is very awesome contest by Roger Hartle in Cornell University. And I revised
after
this
distal
benefit shown of MIS to the endoscopic spine surgery.
The chapter actually
Interestingly, there is a
starts
unmet
with
gap between the open traditional surgery with the
Where
endoscopic
we,
spine surgery. I think that's gonna be the special benefit
that
shown
these
of the
injuries
endoscope. So current status endoscope based on the academic
the
level,
younger population
it is approaching the standard treatment, very
these
close
injuries,
status.
distal femur fractures.
So I used to have a debate
occur, with
where we headed with endoscopic spine surgery. The next meeting, they asked the expert, Michael Wang and I debate the future of endoscope. Anyway, because of COVID-19,
nailing,
personally, I think we have the paradigm shift toward outpatient spine surgery, focusing the endoscopic spine surgery. When you think about the history and the future, it is not big issue already. So endoscope can treat the radialysis, endoscope can treat the spinal decompression, myelopathy. I think that's going to be a problem of time consuming. Eventually it'll be done, right? So we have those kind of history from the pre-branding status, setup status and hypomaturation status. That is the expansion of the category. And now we are stand on the late stage of hyposegmentation. There are a lot of the spine surgeons in Asia and recently the States and the Latin America. They have learned, tried tons of endoscopic spine surgery. So next time we're gonna face the golden age of endoscopic spine surgery.
Meticulous clinical examination.
So, do you wanna walk in the golden age of endoscopic together? Hopefully you do. Thank you very much.
X-rays, which include weight-bearing.
Yeah. Thank you, Dr. Kim,
lateral, oblique,
for a wonderful lecture. And so I would like Dr. Pramod, I invite Dr. Pramod to continue this session, to have a discussion and summarize also this session. Over to you, Dr. Pramod.
Thank you very much. Thank you, Luke. It was an excellent talk. I think,
conservative
management properly highlights everything on the advantages and the limitations of endoscopy. But just to make it clear for the audience, I would like to ask you a very direct question. Yeah. So, what are the different types of disc herniations you're dealing with endoscope? Are you able to cover the entire spectrum?
Really, but
and secondly, as you said, some of your limitations of full endoscopy are severe stenosis. So by severe stenosis, do you mean the extent of the stenosis or actually the degree of severity at that particular level?
Yes, so excellent question, Pramod. So regarding the treatment of disc herniation, lumbar disc herniation, mostly lumbar disc, and also we can treat the cervical disc herniation by endoscope. So we have this single name of lumbar disc herniation, right?
Operations are done.
Considering the shape and the pattern and the symptom, we have tons of cases of the lumbar disc herniation, you guys know, right? So endoscopic started with the transfemoral endoscopic surgery first. So the trailblazer pioneer of the endoscopic guys, we have developed sort of various kind of the trajectory to directly access to the target. There is a target-oriented surgery. So we developed the tool of the foraminoplasty and the different name of the foraminoplasty. Some guys love to use the suprapedicular approach, and some guys use to the outside in. Also with the various weapon, trephine, manual trephine, and the drill. Yeah. Anyway,
a select group of patients.
If you ask me, how many percentage of lumbar disc herniation could be treated by endoscope? I can say, yeah, probably more than 95% of the disc herniation could be treated by endoscope. Why not 100%? The 5%, I think that is the not only depends on the shape, also
placement, and
also
this has been
related on the inflammation and adhesion, right? Because we have the narrow
controversy
working area,
there is
sometimes it is hard to release adhesion scar enoughly, right? So
acute setting, this is
time is not
really
important.
One of the options for.
I think the characteristic of the disc herniation is more than important than
with the younger patient
considered endoscope spine surgery. Regarding the spinal stenosis, so
without bone-on-bone osteoarthritis, with
I have the similar, actually same page with very cool. When he have answered how many
pain, then an extra
could be treated by the tube or endoscope, yeah, it is. We have the same answer. Probably 1 level and 2 level. More than 3 levels, it is time consuming. The surgeons could be exhausted, right? So we just focus on the current symptomatic level and the John. So my personal opinion for treating the spinal stenosis by endoscope is more important is the severity right, than the level itself. In the case of the severe stage of the spinal stenosis, it is not the only mechanical compression, but also the chemical adhesion, right? So a lot of the high risk of the dural tear in their cases. So I always
surgeons has to look out for.
Ask the patient, how long have you been suffer from the recent this kind of claudication radiculopathy? That's my answer.
Or even a
Thank you so much. Any other questions from the panelists?
Tubercle osteotomy. If you want to,
Arvind, you have to unmute.
To preserve the extent.
Dr. Kim, I have one question.
The mechanism.
So if you ask 10 residents who come out of their training as to which specialty super specialty in spine they want to take up among deformity, trauma, and open spine surgery, whatever, the only answer you hear from them is minimal access surgery. So, from a world leader like you, what is the shortest way of, reaching your, completing your learning curve? One sharp answer. Is it the best way of picking it up?
Yeah, it's excellent. Yeah, excellent.
Whatever training
taking
with
the patient to the operating,
etc.
So we have
some of these
methods,
screws and plates or
the stage of the
devices can be preserved
the
by
learning curve. So prior to being educated with the endoscope,
but you also have to be mindful.
I always recommend the learn
of
the tubular surgery first.
I don't constrained and a stemmed implant.
Speaking, I don't recommend the open surgery.
Yeah? If you need a stemmed implant,
in some situation without any other tubular armamentarium, we have to open up the patient bag. But if we if we have the MIS solution for tube and endoscope,
preoperative planning,
so I recommend the tubular surgery first. Yeah, and then the trainee can figure out
deformity can be corrected.
They can move from the microscope to the endoscope. They can narrow down their surgical field from the 2 centimeter to less than 0.5 centimeter.
To do anything extra articular.
So, of course,
but
we need
if you feel that
mentors. So fortunately, in most Asian countries, especially in Korea, there are tons of the master's level of the spine surgeon in even the small private clinic. So we have the circulating opinion
with the use of
from the elder group and junior group. So circulating the opinion and send the consultation once the trainee doctors with the difficult cases,
for about 5 years,
so they can get the answer from the masters and
the
renowned surgeons endoscope. Not only it's not the problem of the endoscope. We have the same
intraarticular bone cuts,
educational problem with the
just chose to do a constraint
surgery. Yeah.
Okay, thank you very much. So we are ending this particular lively session. It was great to have both two champions of using two different techniques with a common goal. Both of you showed, how your technique evolved over a period of time and how it has stretched its boundaries and how both the techniques have had not only clinical but even economic implications, and I'm sure this is going to attract a lot of new delegates to embrace minimal access spine surgery in their practice. You patiently answered all our questions. Thank you so very much, and we look forward to meet you in person in near future. Thank you, Dr. Pramod and Dr.
So on and so forth. So we've really
being a part of this great 1 hour
taken a lot of attention to detail when it comes to these individual joints.
Thank you. Ram Chadda for Dr. Ram Chadda. He's our senior spine surgeon.
With me,
one of the pioneers of minimal access spine surgery in India.
It has
so he'll be giving a vote of thanks. Over to you, Dr. Ram.
Thank you very much. It's been a pleasure to have the who's who of minimal access.
With that being said, I'm going to show
from Larry Koo to Dr. Kim, and we are indeed most privileged and grateful that you've spared your time from different parts of the world to come and educate us and discuss with us, so that on a common platform we can share the way forward. Thank you very much. It's been a pleasure having both of you. and we look forward to interacting
Bowler, who's
more
been my
aggressively
co-author on this chapter.
in more comfortable environment.
We also
in the
kind of
near
address
future.
the
Thank you so much.
spine-pelvic
God bless you.
relationship.
Stay safe, guys.
We discuss the acetabulum in terms of a
So without
revision
wasting any
acetabular
further
setting
time,
with
thank you all the
acetabular
moderators.
bone stock
We
being
move on to the
defined by
next
the
session,
Poprowski
which is the spinal
classification.
deformity session.
We
And
show
may I
you
please invite
pictures of
Dr.
what
Samil
these
Darvi
different
and
types
Dr.
of
Abhay
defects
Nene
are.
to take
And
this
then we
session
go on to
forward.
say, there are really two ways.
Hey, good evening,
of
guys,
correcting
and
these
good morning
deformities
to
is
the
either
Americans
a defect
and the
matching
Japanese as
or a
well.
defect
So
bridging
it's a
type
great
platform.
pleasure for
And then
us
we
to host you
present
guys.
cases
And
such
all I
as
can
this
say is
case of
now
a
that
patient
the
with
little guys have
bilateral
had their turn,
protrusio.
right? The minimal invasive little guys, and it's
just
now
an
finally turned
idiopathic,
for the big boys
protrusio
to play.
case.
And since it's night in
We
India,
show you some
we all know that the big boys play at night.
and the final correction.
Talk about
that
big
occurred in
boys.
this
We've
patient.
got like the
And then
biggest
we also
guys
show you
in
patients who have
scoliosis here.
traumatic
And your
protrusion.
two moderators,
bilateral
myself and
acetabular
Abhay, have
fractures
been purposely
caused by a
chosen
traumatic
because I think we have the
situation in
most
which
to
we
learn.
waited for
So at least for the next 2 hours, we are going to be
consolidation
sitting in rapt
As you
attention,
can
and
see
you
by
guys don't
these
know what a treat
images,
you
I
have.
know that some of
I
them
hand
are a
over
little bit blurry and a little bit smaller on the
session to
presentation,
Abhay
but
to
the book
introduce
gives you a
our first
beautiful
speaker.
overview of how this
Nene, Abhay?
consolidation occurred. Then we give you an intro.
Samir, I'm so excited to be here because if I had to think of 5 or 6 top dogs in the field of spinal deformity, and I would just wish Aladdin to give me those wishes, these would be the 5 or 6 names that would come to fore. I mean, it's a no-brainer that we have a galaxy of stars who write the books, who make the rules. They're the lawmakers, they're the pathfinders for us. And indeed, it's a great pleasure. Thank you, Bombay Spine Society, for helping us achieve this status.
Fractures. So this is an example of
rubbing stars with these, rubbing shoulders with a galaxy of stars.
For fracture correction with three-dimensional reconstruction. Again, this is the part which I enjoy the most
pilgrimage of
because,
sorts
as Eric
for spinal
mentioned, Eric
deformity
is an
surgeons.
orthopedic trauma
Our
surgeon.
first
I'm a hip
speaker
and knee
is the
reconstructive
god
surgeon.
of
So
small
he
things.
bridges
Peter Newton is very, very valuable across the world for treating pediatric deformity, and we all follow his, his words like the Bible. It's needless to say that he's the big guy from San Diego, and
then
the
when you
professor
have patients
at
such as this
the
with
University
massive
of
acetabular
California,
defects,
San Diego School of
and
Medicine,
these are cases that,
and
that
also
I really learned
the champion
Ajit on how to
surgeon at the
manage
Raleigh
these
Children's Hospital. But
things
that's
like
all
performing
apart
figure of
for us.
7
He's our
allografts
dear
or
Peter Newton.
autographs in these
Sir, I hand
patients,
over to you
and then
for
correcting
your
that
first talk
deformity,
on handling
bringing
early onset
that
deformity
hip joint
with your
center
various
back to its
techniques. Over to you,
native center of rotation.
Great,
and
thanks,
then giving
Abhay.
them adequate offset
I'm
and
going to go ahead
correction.
and try to share my screen.
Finally,
If
we also
if you can
discuss
stop
challenging
sharing,
cases
I'll,
such as this, such as pelvic
ahead.
dysmorphism,
Great
in
to
which
be
you not only have a
joining you all this
dysplastic
evening
acetabulum, but you
for this
also
evening
have
for you
a
guys.
side joint fusion on that left
Still early in the morning for me.
hemipelvis, as you can see by this three-dimensional CT.
Can
And
you go off
massive
screen,
deformity and how we try and approach this with three-dimensional bone modeling in identifying the structures first off, and then finally correlating that with our intraoperative pictures and intraoperative anatomy that's observed in the patient. We go ahead and we show the various degrees of version that are associated with the acetabulum.
Well, my topic was is early onset scoliosis, and this is
at 2 years.
really
So if you have the online
quite a
version of the
broad
book, you have
area
access to some of these
to
pictures
cover.
and some of these
My
videos
disclosures
and
were
how
listed
patients
here.
perform after these massive
I think we're all
corrective
understanding
surgeries
of why
as seen
we
here.
think of this as being
So
such
with that
an
being said,
important
the final case that I think I wanted to
these
highlight
children
was
who have
we
early
also
onset
discussed pelvic
scoliosis,
discontinuity.
we've got several
So we
goals in
discussed
mind:
how
prevent deformity, promote
initially we're
pulmonary
bridging the gap.
development.
We
really
have
one of the big
concepts
ones.
such as distraction,
And
osteogenesis that we
and most of the
discussed
time, in all the
we've
things
also
we do, we
discussed the
assume that our
use of,
intervention is better than the
custom
natural
devices
history.
such as
So
a triflange.
I'm not
as
sure
shown
that's
in this
always
case.
the case when we
And I'll show you
intervene.
the images
So
associated with
keeping
the
that in
failure
mind,
of
I
a
think
cage
it's,
in a
really
traumatic
critical for
situation,
this
and then the
particular
application
population.
of a custom triflange and restoration of the center of rotation. Once again,
Well,
these are the
I like
offers that are
to,
currently available to us. The link
categorize
will give
idiopathic
you a $40
scoliosis
discount,
as,
and then the holiday
either
sale, which is
that
up
in
to
which the
December
patient comes
31st,
with a
will
really
give you an
bad
additional
deformity,
$30 off. So it's a great,
or severe
great
early
offer.
onset
Please
scoliosis can
make,
also be
use of
caused by
this.
the surgeon.
This is our contact
who
information.
has big
Please
ideas
feel
about
free
how
to
they can
email
use
us with any
so-called
questions or
growth-friendly
concerns that you
surgery.
have.
And
once
those
again,
are
thank you
are
very
on
much
us.
to Ashok
So
for
we've got to make
hosting
sure
this first
that
book
we
club for
limit
us.
that kind of
I'd like to
severe
stop
causes of
my
early
screen screen share. Ashok, if you'd like to say any words, or my co-editors, my author, if you'd like to say
once we begin any of these surgical interventions,
if I can, thanks,
unfortunately, there's no going back. We don't get to undo anything that we do. And many of these procedures create wear debris, autofusion, and really substantial junctional issues, particularly proximally, that can be a challenge. So I guess the first
book, as I
point
mentioned
that I would
before, is
like to
kind of a
make is that
missing
in
link,
many of these children, the
for,
first things to do is to
things
really
that
try
you may
not to operate on these children before age 8. I really work
Each of
hard
the
to
authors
use some form of non-operative treatment
in the
for
book
many,
have,
many years for these children.
spend time to
I know we've spoken about this, that in your country,
picking the
the heat
right
and the humidity
example
can be a
and the
challenge
great
for many of these casting and bracing scenarios. But I promise you, that's nothing compared to some of the challenges you'll face after having implants that break.
and preparation and
So observation, casting, bracing, and even halo traction.
methodological
can be really
processing.
valuable. So I have
the
had this case
procedure.
presented to me as a failure of brace correction, therefore is an indication for surgical
but it
intervention.
is
I would strongly disagree with that.
an international
That's
book.
not
I
a
consider
very good
we
brace, and there's better things we can do. The first way to impart growth modulation is to use a cast.
from Europe to give in
and
their
this is clearly an effective method. It doesn't work for
perspective,
everybody,
in
but
their expertise. So
it can be a powerful tool early in life and can be used over and over again to try to manage severe deformity in these young kids. It has very little downside.
Thank you very much. And I'm seeing these.
There are a lot of different casting strategies. Meta casting is probably the most common worldwide now, and I can understand.
I think it was an excellent beginning.
Like Min Meta's methodology
very,
in India, I would completely understand that. I have adopted largely a bending cast. Occasionally, I kind of go back between the two, but I find this bending cast strategy to be very effective, very simple. So we suspend the child from a loop of muslin and put the cast on in that kind of bending position. You can still also work on derotation through that.
I think the readers
in
will
very
be
small children, we might even
really
include an
thankful
arm or a
to all of
thigh
you.
to make sure that we've got enough of the body to hold on to. That's rarely
Doctors who are
required for
combined.
older children, but in the very young children, this can be a good strategy as well. And I can just tell you that
because
severe curves with large ribvertebral angle differences can be managed this way. And in fact, children with early onset scoliosis can be cured by casting. You might even consider this. Here's an 8-year-old patient who I said you've now reached the age when surgery could be performed, 47-degree curve, very immature, normal MRI. What levels do you want to put your implants in? I'm still going to say maybe you should just stop and consider a cast even at this age. And you can see that the outcome of this patient 3 years after casting has been really a cure of their scoliosis without any implants placed. So young children, juveniles can be managed this way as well. And we can really cure scoliosis non-operatively if we're aggressive with good cast management. So please consider this as your first choice. And when we work well with a cast, we can often convert to a brace. And clearly the bracing for adolescent idiopathic scoliosis trial that Stu Weinstein pioneered has proven that bracing works. To work, there has to be good in-brace correction, just as with the cast. And clearly time in the brace matters. And the brace maker who designs it matters. I don't know if the name of the brace matters so much as the correction that you get in that brace. But experienced orthotists do a marvelous job of correcting scoliosis non-operatively. And obviously the best way to get 100% compliance is to make it out of fiberglass or plaster and call it a cast. That will be very effective as well. The complications with this approach really are the failure to control the scoliosis. It doesn't always work. We can also create chest wall deformity, which again, we remember one of our early principles was to preserve pulmonary function and promote pulmonary development. If you have excessive deformity of the chest wall due to casting, that can be a problem. But I got to say, the ribs bounce back pretty darn well. Skin pressure and breakdown can certainly be a challenge if you push too hard. But all of these complications, I got to say, are just negligible compared to what we see with any of our surgical interventions. It might be that we have some patients that just seem like they've got too proximal of a curve to use a cast. Well, I mean, with some Minerva type extensions or cervical thoracic extensions, either with an additional appliance or with the cast itself, we can treat upper thoracic scoliosis. Now, this isn't quite so standard anymore, and obviously the Milwaukee brace is not something common, at least in the United States. But this concept in early onset scoliosis can still be a great delaying strategy. And this gal with that approach certainly had curve progression over time, but to begin to manage this at age 7 compared to age 3 or 4 is a much, much different prognosis for her in the long term. So at some point, we may fail, and if it doesn't work, the next stage will be some form of surgical treatment. So we've got to be ready for that at some point. But before we get to surgery, I would strongly encourage thoughts around halogravity traction, particularly for some of the more severe curves. This is a extremely valuable approach. It often takes us from what is a very difficult surgical procedure to something that appears to be, again, much more manageable. And upper thoracic kyphosis is really the bane of many of the non-fusion growth, so-called growth-friendly, growth-sparing instrumentation systems that we use in young children. And that upper thoracic kyphosis is really tough, but it's pretty well managed with a period of halogravity traction. So consider that as a first stage. Here's an example, just in general, of what halogravity traction can do. And I know you think that those images were pre-traction were all just some distortion of my imaging, but that's in fact the spine, and it makes it a dramatic improvement. So use halogravity traction. It rarely disappoints me. And if you wish, you can even convert halogravity traction to halter traction, just under the chin or delivered through a brace. I've got several children now who manage their scoliosis with a combination of bracing and a couple hours a day of traction in a walker like this or in a wheelchair. This is also a very, very nice delaying strategy. Not quite as powerful as a halo, of course, but obviously doesn't have the downsides of having pins in the skull, and you can do it for years. I think we all would agree that non-operative treatment is eventually may fail, but also remember that surgery is in some ways the beginning of the end when it comes to flexibility and a relatively complication-free existence. So do what you can to keep delaying, unless delaying is causing problems for the lungs. So I understand that there's a very difficult balance and decision-making to be made between when are we going to intervene to preserve pulmonary function and when are we going to intervene or whether we're going to stay away to avoid the complications that come from beginning this treatment. We'll go back to this patient that we've been looking at previously. So here is her time after halogravity traction. And now, is she ready for some form of growth guidance or growing rods? And what levels will we try to treat? I did this with more traditional growing rods, largely because I wanted to limit the area of instrumentation for the non-fusion growth construct to the abnormal section of the spine. If we'd put in magic rods or something more traditional, we would have been way down into the lumbar spine and doesn't need to be bothered by our instrumentation. So here's another case, very large curve. This had one attempt at casting, really didn't tolerate it well, had skin issues. We went to traction for a period of time, and now we're also have a much more manageable curve, and we can question where this patient needs to be instrumented. For a big, long curve like this, unfortunately, it's a relatively long construct. In this case, that long construct does allow us to use magnetically controlled growing rods, which I think is helpful for the patients. This kiddo has been lengthened now for about 2 years, doing very nicely. So the first principle of early onset scoliosis treatment: delay surgical intervention, cast, brace, traction, and resist the temptation of easy surgery. And growing rod surgery is pretty easy. And putting in something like that, casting can be hard, but that's how we go. But the second principle is know when to violate the first principle. And I would say in that scenario, there are often times that we can use a short fusion early to help in these scenarios as well. So a short fusion is not a long fusion. We can argue how short is, and I would say that it really depends on the age of the patient as to how long of a fusion you can perform and still be not restricting substantial growth potential or pulmonary development. I don't think any of us have trouble with doing a fusion early in life for a single level on a congenital deformity. And if that's the case, then we ought to be able to have some level of fusion that we can do even a little bit older than that. This is an example of a boy with neuroblastoma paraplegia who had a relatively long fusion, you might argue, but whatever that is, 7 screws put in very early in life. And you can see that although that stunted the growth of his lumbar spine, his thoracic spine, we didn't bother much. It grew beautifully in both width, height, and depth. And he's got great pulmonary function, had a single operation done when he was just 3 years of age and is fully grown without having to have any other intervention. Here's another example of a relatively short fusion in a young boy with neurofibromatosis. That's also been his single intervention, and it's not had to have multiple procedures associated with growth constructs. I would like to emphasize that too much fusion early can be problematic, and too little too late can be problematic. So again, we're often trying to thread that needle. The growth or the height of the chest that we're trying to reach is about 22 centimeters. That's been suggested as a goal for us to reach appropriate pulmonary function. Let's just take a quick trip down 2 patients who've been managed with slightly different strategies, both with very severe upper thoracic congenital malformations. No question about these are going to be problematic in life. One was managed with a fusion, fairly substantial upper thoracic fusion. The other was managed with growth-sparing constructs, which was revised again and again, and subsequently had resection. And so on the 5th surgery, they ended up with an operation that's not so dissimilar from the first patient who had just a single operation. So I think, knowing when we should just bite the bullet, do a relatively short fusion is still a really important concept to consider. Final fusion for these patients who've had some growth-sparing construct tend to be difficult. The dissection's difficult. Everything's been beat up before. The implants have spared the midline, but now you try to dissect better. They're stiff. They've got a lot of junctional problems, and the correction can be quite limited. Here's we showed earlier an example of proximal junctional kyphosis. This is a classic complication after a long period of lengthening, and often requires some sort of a 3-column osteotomy to revise. So final fusion for deformity is often required, and removing the growth rod, correcting the deformity, frequently with some form of 3-column osteotomy, of course, is difficult and dangerous surgery. It's a revision situation that can really be a challenge. Some have advocated that we just skip the final fusion, and there probably are some patients in which this is the right thing to do. The frail population, low demand, high risk for complications, spinal muscular atrophy, OI being a couple of examples. We just leave the implants and hope that nothing breaks. Now, some of those do break, and if that's the case, you may have an unplanned operation rather than a planned operation to go back and manage. But there's literature from the Pediatric Spine Study Group that suggests that patients who underwent spinal fusion as their definitive treatment were more likely to undergo revision surgery after that so-called definitive final fusion than those that just had their growing rods or growth-friendly implants maintained. There probably is some selection bias in this, but even still, this concept of waiting and watching, I think, is becoming a little bit more popular, at least for some of those patients that are particularly frail. So my kind of thoughts on who gets a final fusion are those, we just observe those frail with low demand. The robust, normal, otherwise healthy child, I will observe some of those, but I will still offer them a final fusion so that they know that they're leaving with a good, solid instrumented fusion. Many of these patients that have so-called autofusion don't have a robust fusion and will break their implants. If they've got residual deformity, of course we need to do a revision to manage that deformity. And if they've got magnetic rods in, at least the current FDA recommendation is for those to be ultimately removed and have a definitive fusion. Whether or not that is just an industry recommendation or a real requirement, I think we have to see down the road. The decisions in this population, I think, matter more than any other group that we operate on, maybe than compared to other than maybe the very elderly. But these folks are frail, the operations are challenging, the problems are difficult, and we have some very easy surgical solutions. Putting in a growing rod is simple to do on the outset, but can create all sorts of downstream difficulties. So I would say resist the urge to instrument early and resist the urge to instrument more than just the diseased part of the spine and chest. And the younger these patients are, the greater the importance of getting it right, because there's so much effect on those growing years. And growth sparing instrumentation, no matter how growth sparing you want it to believe it is, it's just not that friendly to the spine. And once you put it in, it's pretty much done. There's no going back. So again, when possible delay, I would much rather take a large curve in a virgin spine that's never been treated. Those we know how to fix. It's much, much simpler than managing these folks that have had lots of operations and big deformity. So these decisions are tough ones, and we often don't have a perfect solution, but when you can buy some time, even if it's hard to do it, and it's tough to convince the family that being treated non-operatively in a cast or traction is not always the easiest thing to do, but we've really got to choose wisely with a long-term vision for these kids to imagine what their final solution is ultimately going to look like. Thanks very much. It's a great joy to be able to be back with you all and join the Bombay Spine Society. Thanks again for the opportunity, gang.
Thank you so much, Dr. Newton. That was a fantastic, concise, we'd say, on a very, very difficult topic. Since you're pushing time, I'm going to use my prerogative as the chair for this session and ask you just one question. With this lukewarm, response to magic rods in the medium term, do you think it is still the way forward? And should we all, give away the double growing rod or the Sheila technique in view and use magic rods? And in case we do, how do you control the apex? Because very often the apex could spin out of control.
Yeah.
What are your thoughts on this, sir?
Well, I think each of these children have a very specific, unique deformity, and a single solution is not going to be the right solution for all of them. For the relatively long curve, I do think either a traditional or a magic style growing rod is appropriate. But as you saw, I still use some wedding band constructs, side-to-side lengthening, or a short fusion to throw in the mix. And I do have some Shillas that I think where the apex is lower and very kyphotic, a resection with a fusion at the apex and Shilla at the ends is a really valuable technique. So I favor tailoring the approach to the deformity. And whether you use magic or traditional growing rods for those in which a growing rod construct seems appropriate, I think it's really a dealer's choice. It does save the child some surgical procedures, but the ultimate complication challenges of PJK, infection, wear debris are all still there. It doesn't erase any of that. It just saves a few anesthetics along the way. But unfortunately, we're often still doing some sort of revision surgery for a broken implant or a challenge down the road, even with that. So not the total solution by any means.
Yes, thank you so much. And thanks for spending your Saturday morning.
There is a question. Abhay, is there another question allowed?
And you're going to take over.
Yeah. There is another question for Dr. Newton from Kshitij Chaudhary. Sir, my friend asks you, for curves that cannot be controlled with non-operative techniques, have you tried to control the apex with uninstrumented fusion and then control the rest of the spine with the non-operative techniques?
Great question. I guess I would say if I'm going to fuse the apex, I'm likely to instrument the apex. So I would say I'm more likely to do an instrumented fusion of the apex. And yes, I do have some cases like that where we'll go for a very short apical fusion. And really that's a Shilla-based kind of concept. Fix the apex and guide the growth at the ends. that growth guidance can either be with a cast or with rods. And I think that depends a little bit on the patient and what the likelihood of needing to control the ends of the construct are based on the deformity. But a short apical fusion to control what's really driving the deformity, I think is a great strategy.
Thank you very much. Thank you, Dr. Newton. And now it's my pleasure to invite our next speaker. To introduce Dr. Lenke is the easiest thing, and yet it is the most difficult thing to do. It's the easiest because I would say if you don't know Lenke's classification, you shouldn't do scoliosis. But if you don't know Lenke, you shouldn't be doing spine surgery. It's the most difficult thing to do because his CV is 236 pages. I would be here a week reading out his CV, but just very concisely, he has 435 peer-reviewed publications and 44 submissions waiting in the wings. He has 134 book chapters, 883 international podium presentations, 568 posters, and 16 patents. I mean, if those numbers don't woo you, then, what does? I met Dr. Lenke for the first time in 1999 when he was the traveling SRS fellow to the UK, where I was a fellow, and everybody whispered that he's going to be the next big thing. And believe me, he is. He's the definitive sort of a spine surgeon for our generation. And what better to us in Mumbai than to hear about Lenke's classification, literally from the horse's mouth. Dr. Lenke, I welcome you. And we look forward to hearing from you.
Thanks, Samir, for that very nice introduction. I appreciate it. I'm not sure I can live up to those expectations. So I actually did some of my talk, but I wonder, can I actually give my talk live like Dr. Newton, if you don't mind, instead of my pre-recorded talk? Because I changed, I edited my talk a touch this morning. Do you mind that?
Yes, sure. Can the tech team please take off the pre-recorded video and let him share his screen? So please unshare your screen. Vama Events, please unshare your screen. Yeah. Let Dr. Lenke, Dr. Lenke, please share your screen and go ahead.
Okay, let's get up here. Sorry, but this is gonna be a second here. But like I typically do, I've edited my talk the morning before my talk, which I typically do. So I appreciate the opportunity. Can you all see my screen now?
Totally.
Good to go?
Yes, we can see and we can hear.
Super, perfect. So again, great question. I'm going to try and answer today. Although we have this classification system, does it recommend valid levels of instrumentation? And that's a challenge. And I'll go through this and say how we're trying to do better with this. But at first glance, it really doesn't. But I think with time, we can hone in on the best instrumentation levels for choosing the UIB and LIV. My disclosures. Hopefully, we're all aware of this triad component of AIS classification, the curve type, the lumbar and sagittal thoracic modifiers. It's really amazing that this has stood a test of time. Published in 2001, it really still is the gold standard for 2D AIS classification system. Things haven't changed. We still have 3 regions of the spine in AIS that we have to evaluate: the deformity, the proximal thoracic, main thoracic, and thoracolumbar and lumbar, both in the coronal and sagittal planes. Obviously, the major curve in this operative system is easy. We're going to fuse that. The real question becomes, do we have to fuse the minor curves? We came up with these minor curve structural criteria that are not perfect, but do give guidance as to, when the proximal thoracic, main thoracic, or lumbar minor curves are structural based on coronal inflexibility on side bending or sagittal hyperkyphosis. I think we're all familiar with these criteria by now. And then we can come up with this depiction of 6 curve types. These descriptions we're all familiar with. We just put some objectivity and coordination between when is something a main thoracic, a double thoracic, or double major curve, etc. The first 4 are the thoracic spine is a major curve, and type 5 and 6, the lumbar region is the major curve. And so this has worked quite well, again, for selecting out curve types. These 2 modifiers help us to pick the lumbar spine modifier, the apical translation of the lumbar curve that becomes important, especially for decisions regarding selective thoracic fusion. And I'll highlight that in a brief part of this talk. And obviously, the sagittal thoracic modifier is a bit outdated. This only looks at T5 to T12, but it does highlight the fact that we have to look at the sagittal plane, including the thoracolumbar junction, for any operative fusion level and instrumentation level selection. And I'll touch on that as well in this talk. So again, the classification systems does not tell you specifically what your UIV or LIV should be, but it does give direction as whether which regions of the spine you should fuse. Type 1, we should only fuse the main thoracic region. Type 2, we need to include both the proximal thoracic and main thoracic, etc. And obviously, when we created this system in 2001, we were doing a lot of main thoracic and many type 5 isolated thoracolumbar and lumbar curves to anterior approaches, and you can still do that because there's an isolated curve. But realistically, all double, triple curves need to be treated posteriorly to control these progressive deformities. And also, in fact, the posterior approach is a universal approach. I've used that for every single AIS case I've done since 2001 as well. So really is dealer's choice. Obviously, things are changing a bit with the use of tethers, but I'm not going to go into that today. That's a separate topic for discussion, but will be an important consideration in the future. Now, I want to acknowledge that we have added a third modifier the last 6-7 years to our system that we use at our center and has recently been published in JBJS, as I'll show you. And this is the touched vertebra modifier. So for those who are not aware of this, the touched vertebra is the most cephalad thoracolumbar and lumbar vertebra between T12 and L5 that is touched by the center sacral vertical line of the lowest structural curve. For this main thoracic curve, so the main thoracic curve is the only and really lowest structural curve. So you see the CSVL touches L2. That's the most cephalad vertebra touches. And this is important because you see on the right here, that ends up being our LIV. In the 5 years post-op, we have a near perfect LIV and distal alignment of the spine. So the touch vertebra does become very important in our selection of the LIV, as I will discuss in this talk to a great degree. So getting back to the premise and title of the talk for selecting the UIV and LIV, we're going to talk about the LIV first. Again, we certainly use the touch vertebra, but also pay attention to the end vertebra, the nuchal as well as skeletal maturity when we're making decisions on LIV selection. And for UIV selection, it's really based on clinical and radiographic shoulder balance preoperatively, as well as structurality of the proximal thoracic curve. In addition, a dynamic component, the amount of main thoracic curve correction planned and achieved. Because one downside about doing such great work with screws and osteotomies in the main thoracic curves that we have to pay more attention to the proximal thoracic curve, because the more correction we get of the main thoracic curve, the more likely we are to elevate the contralateral shoulder, typically the left shoulder, as we all know. So there's some dynamic consideration with UIV selection that are not present with LIV selection as much. So we're going to go through the 6 curve types and kind of highlight now initially more focusing on the LIV selection. So this 1AN L1's curve, again, this is the most common curve we see, a 1AN curve. 20% of all curves that we treat operatively are 1ANs. Here, the 1AN/L1 refers to the L1 touch vertebra. So now all my curve classifications are going to have the 3 components, the 3 modifiers. Obviously, A, lumbar modifier, N, normal sagittal profile. L1 is the highest touched vertebra, L1 here. So again, touched vertebra is L1, and we treat this with a T3 to L1, stopping in L1. And so you see the 0 after that. That means that the touch vertebra equals the lower instrument vertebra. So we stopped at the 0 position, at the touch vertebra position here. You see 3 years post-op, we have perfect alignment of the LIV and below in the lumbar spine. So this is obviously a good selection of the LIV in this case. And clinical photos pre and post-operatively. So here's a double thoracic curve pattern, 58-degree proximal thoracic, 90-degree main thoracic, 36-degree lumbar. It's a 2A plus because the proximal thoracic curve is a structural, lumbar curve is not. It has a hyperkyphotic sagittal modifier, and L2 is the lowest touch vertebra. So the question is, are we going to stop at L2? The answer is yes. So we stop at L2 again. So the touch vertebra equals the LIV. So that's a 0 fusion level again stop. And you see it here is post-op. Again, we have excellent realignment of the lumbar curve below in both the coronal and sagittal planes, and excellent clinical correction pre and post-operatively as well. So again, highlighting the touch vertebra rule. This was now finally published in JBJS with the title of the paper, Radiographic Results of Selecting the Touch Vertebra as the Lowest Instrumented Vertebra in Lanky Type 1 and 2 curves at a minimum 5-year follow-up. So we used the Harm Study database and looked at all the Type 1 and Type 2 curves, hundreds of cases. I think it was 316 cases in total that have 5-year follow-up. And we concluded that selecting the touch vertebra for the LIV in these curve types is a very safe LIV for the vast majority of skeletally mature AS patients. For immature patients, sometimes we have to go one level caudad to get more of a stable vertebra, as you know, especially in 1AR cases where there's more of an overhang thoracic curve. And very occasionally, if it's a tweener in between where the touch vertebra almost touches the corner of the next cephalad vertebra, and that next cephalad vertebra is neutral and end, sometimes we can stop at -1 in these curves. But overall, 90% of the time we stopped at the touch vertebra, and at 5-year follow-up, they had excellent realignment with no adding on or minimal adding on and no revisions. So that the bottom line, it's a very, very nice place to start as a possible endpoint for type 1 and 2 curves. Now, how about double major curves, where obviously the lumbar curve now is going to be structural. Here's a very large double major curve, 3C plus L4. You see L4 is just touched by the center circle line there on the standing film. So we stop at L4 on this curve. There's no way to stop at L3, which is rotated at the apex of the lumbar curve. So this is, again, is a 0 stop. So the touch vertebra pre-op of the lowest structural curve of the lumbar curve is the LIV post-op. Obviously, you had to do a long fusion here with nice radiographic realignment with posterior osteotomies. Triple major curves, again, are rare curves. Only 7% of curves have structurality to all 3 regions. Here's an example: 41-degree proximal thoracic, 88-degree main thoracic, 60-degree lumbar. All 3 regions are structural. So we're going to do a long fusion here, again, down to L4, the lowest touch vertebra. So again, it's 0 stop here in this long fusion for this patient with good alignment postoperatively of the L4 sacrum region below. Now we're going to switch gears and look at our type 5 and 6 curves, where the major curve is in the thoracolumbar spine. Type 5 curves are fairly common. About 20% of all curves are type 5 isolated thoracolumbar curves, and it's 5CNL4. So again, a 62-degree thoracolumbar curve with a 38-degree thoracic curve above that's non-structural on side bending. You see the low touch vertebra for the lumbar curve is L4, but L3 is the end vertebra. And that's so important because for type 5 and 6 curves, we look at the end vertebra touch vertebra
Let me hand over to Rajiv.
And again, often in these curves, we actually will select the end vertebra for our LIV. So here we do a T11 to L3 fusion. So this is a -1 fixation because we stop one level short of the touch vertebra at L3, which is the end vertebra.
I would like to welcome you all for this journal club. Generally, we are doing this as a routine weekly activity, and we meet every Tuesday morning from 7 a.m. to 8 a.m.
6 curves, again, now the lumbar curve is going to be the major
we thought
structural, but as
because
well
we are doing a very interesting
65-degree thoracic,
journal club on
74-degree lumbar
Springers,
curve,
because we have
6CN L4
in recent years 5 publications
L4
from
is the
India
touch vertebra on the pre-op standing film. L3 is the end vertebra.
Deformity.
But
So
again,
we thought,
the question is, can we stop at end vertebra?
all the
Here, the
authors
apex
together,
of the lumbar curve is L1, so it's 2 seconds
and we
above
do
the
this
planned
journal
L3 LIV. So here we can't
So,
stop at L3.
I would like to introduce
-1
the
stop. You
first
see, we don't have
author,
perfect
Dr. P.N.
neutrality of
Gupta,
L3.
and he will
There's
be
still some
speaking about
rotational
what
alignment between L3 and
Woodward
L4, but
procedure.
L3 is nicely centered over
It will
the
be
sacrum
followed up by
with a good
Dr.
sagittal
Sandeep
profile, and we
Patwardhan,
save
who will
one
be speaking
lumbar
about
level. So controversial
modified
whether
Woodward
L3 or
procedure.
L4 is preferred here, but again,
After that, Dr. Premal Naik will be sharing his experience of 40 cases
as long as the
about Green's procedure.
The L3 is not
Dr. Atul Bhaskar
exceedingly
from
rotated
Mumbai
and at least
will
2
be
levels
speaking
below
about
the
Mears
apex of the lumbar
procedure.
curve. So we
And
studied this,
last
and
but
we
not the
presented
least,
this. We haven't
Dr.
published
Anil
this yet. We're still
Agrawal
working on
will
getting
be
this published.
highlighting about
But again, looking at
scapular
the
osteotomy.
touch vertebra versus end vertebra,
And we
and
have
selecting
one
the LIV for
expert,
type 5 and 6 curves. Again, on average,
Dr.
it's
William
fairly
McKenzie,
easy. Like
who
in
is
this
a
case,
chairman
when the
of
end vertebra and touch vertebra L3 is the same,
chairman
then we
at
almost
Department of
invariably stop
Orthopaedic Surgery at
touch
DuPont
vertebra, and we have excellent realignment post-op.
Children's
It's
Hospital.
more controversial, obviously,
So
if touch vertebra
today's
is one level distal to
program
end
will
vertebra.
be
Can we still stop
there will be
at
an
the
overview and treatment algorithm
end
by
vertebra?
Dr. McKenzie,
And here's an
followed
example
by
of that.
role of
Here on the
clavicle
far left, the
mossilization
touch
by
vertebra
Dr.
is
McKenzie.
L4,
Dr.
end vertebra is
Gupta will
L3,
be
but we stop at
presenting
L3. So we
about
do a TD minus 1
Woodward's
LIV here.
procedure.
And again, we
Dr.
have very
Sandeep
nice
Patwardhan will
realignment
be
here
presenting
of
about
the lumbar
modified
region,
Woodward
and
procedure.
arguably a better result because we saved one
Dr.
more
Premal
distal
Naik
fusion level. So
about Green's
key
procedure.
also obviously
Dr.
is
Atul
excellent
Bhaskar
sagittal
will be
alignment in these
presenting
patients
about
as well.
Mears
So
procedure.
again, bottom line
Dr.
is for most type 5 and 6 curves, we stop at the end vertebra of the curve, not the touch vertebra, sometimes are the same, and that always precludes a very, very nice
then there will
result.
be some
Not
closing
the same. Sometimes we'll have a little bit of disc wedging there, but typically it's acceptable as long as the LIV pre-op was fairly neutral and is at least 1.5 to 2 levels below the apex of the lumbar curve. Those are the criteria we use for stopping at the end vertebra in type 5 and 6 curves. Now, switching gears for a second to talk about selective thoracic fusions, obviously a very important component to AIS surgery. Selective fusion, I don't like using this term for A and B modifiers. It's really reserved for C modifier curves in both the thoracic and especially the lumbar curve across the middle line, and we're trying to only fix the thoracic curve and leave the lumbar curve alone, as we did here in the selective thoracic fusion for the C modifier curve that has now a B modifier curve post-op with very nice alignment. So the question is, when the lumbar curve remain unfused, when can we truly do a selective thoracic fusion? Well, again, the classification system recommends that for a 1C and 2C curve. I can tell you that's not necessarily done by the majority of surgeons who do AIS surgery, at least in North America. But we really try and all costs do selective thoracic fusion for 1C and 2Cs. But I can tell you that there are certain types of 3C and 4C curves that can also do a selective thoracic fusion, which goes against the classification rules, but again, is done when we can both clinically and radiographically get away with it and leave the patient with a mobile lumbar spine.
One case was first
so I'm just going to show one case to highlight the radiographic and clinical factors that we use to do a selective thoracic fusion. And here are 3C curves. So this is a 3CN L4 curve. You see the
scapula's normal anatomical location is
lumbar curve. Lumbar curve is structural on side, bending only bends out to 32 degrees. So this is a 3CN curve. You see L4 then is the lowest touch vertebra. Since the lumbar curve is structural,
medially
the
rotated.
TV isn't T12.
The ratio of horizontal to vertical diameter is increased.
Suggesting that we fuse the lumbar curve. Now the question is, can we do a selective thoracic fusion?
The glenoid articular surface is in Barre's inclination.
Classification system and look at the radiographic ratio. So here back, published in 1992, we still use this nearly 30 years later. We look at the COB, the apical vertebral translation, and the apical vertebral rotation ratios.
Scapular embryology
68 over 51 is 1.33 ratio. 6 centimeters over 3 centimeters translation is 2, which is very favorable for a selective thoracic fusion, and ABR ratio is 2.0.
We know it's associated with spine, renal, and
ratios are greater than 1.2, especially the ABT ratio. It's definitely an opportunity to consider a selective thoracic fusion from the limb, even in a 3C or 4C curve.
The limb won't develop,
but we have to look at the patient in this situation. So here's a pre-op clinical photos of this patient. And standing upright film, we see a prominent scapular region. We do see a slight indentation of the waistline asymmetry that is due to the lumbar translation, but it's not terrible. And importantly, for bend, these foraminal measurements are 17 to 12, which again is much greater.
Here we have a most scapula showing the many different signaling
evaluation of the patient.
and the genes
from both
involved
radiographic and clinical parameters, this patient can be considered for selective thoracic fusion.
This is an example of a wild type mouse, and you can see the
classification perspective, the
here,
3CN recommends a
developing in this.
fusion down to L4. But again,
with
with the ratio and clinical evaluation, we do a selective thoracic fusion here, T4 to T12. So we do a -4 fusion because, again, the lowest touch vertebra is L4, but we stop at T12. So we're saving 4 lumbar levels. Here we have excellent realignment. You see we undercorrect a bit the thoracic curve to harmoniously align with the lumbar curve below. So you have nice sagittal 3D correction for creating more thoracic kyphosis in the spine. An excellent realignment here in both coronal and sagittal planes. Very nice cosmesis of the patient here pre and post-operatively. And this was especially important in this patient who had seen 5 previous scoliosis surgeons who all recommended fusion of both curves.
And the
she's a competitive swimmer. She needed her lumbar curve for her activities. So we kept her lumbar curve unfused. She was able to continue on her swimming.
Because of the interference
had a full scholarship to Harvard University, where she swam on the swimming team for 4 years and did very well with that. So again, we have to take everything in consideration, including the patient's consideration of what their athletic activities are, considering selective thoracic fusion. I will spend the remainder of the last few minutes of the talk on UIV selection. This is actually, for me, is simpler because to me, the key is the clinical, and especially where she swam in the swimming team for 4 years. The result is did very well with that. So again, we have to take everything into consideration, including the patient's problems, consideration, ideals. So here, I will spend the remainder of the last few minutes of the talk on UIV having balanced shoulders or right hip. To me, the key is from a clinical perspective, and especially where she swam in the swimming team for 4 years. Did very well. So again, we have to take everything into consideration, including the patient's problems, consideration, ideals. So here, I will spend the remainder of the last few minutes of the talk on UIV having balanced shoulders or right hip. To me, the key is from a clinical perspective, and especially where she swam in the swimming team for 4 years. Did very well. So again, we have to take everything into consideration, including the patient's problems, consideration, ideals. So here, I will spend the remainder of the last few minutes of the talk having balanced shoulders or right hip. To me, the key is from a clinical perspective, and especially where she swam in the swimming team for 4 years. Did very well. So again, we have to take everything into consideration, including the patient's problems, consideration, ideals. So here, I will spend the remainder of the talk having balanced shoulders or right hip. To me, the key is it's more easy to understand going to T2. To me, it is. So again, we have to take everything into consideration, clinical and ideals. So here, I will spend the remainder of the talk here often we start out with patients with level shoulders, and the question, can we start at T3 or T4 for this right thoracic curve? Now, you see, this is a non-structural proximal thoracic curve, but again, there's a lot of coronal translation. I want to try and perfectly correct this curve in the midline, which we should be able to. Obviously, the 54 degree is a flexible curve. So I'm going to go for marked coronal complete correction. And again, that dynamic criteria, aggressively correcting the main thoracic curve while keeping the shoulders level, is going to allow provide me the opportunity to start at T3. So here I'm going to do a T3 instead of T4 start as UIB. I find very little downside to starting at T3 instead of T4. I'm able to more easily keep the shoulders level with this main thoracic curve correction and have a balanced shoulders post-op. So this is an indication for starting at T3 with or without a structural proximal thoracic curve when the shoulders start out level clinically. And really the only time I start out at T4 as my UIV is when the right shoulder is high and there's a non-structural proximal thoracic curve. So here's an example of that. You see a main thoracic curve of 74 degrees, a 40-degree proximal thoracic curve that's very flexible, and clinically a high right shoulder, obviously, pre-op on the clinical photos. So here, we're going to start at T4. Even though we completely correct out the curve, we still have a level shoulders post-op following this T4 to L4, T4 to L2 correction. So in conclusion, although the Lanky EIS classification system has remained relevant over 20 years due to its comprehensive yet modular method of radiographic curve depiction with treatment guidelines, we have had to add a third modifier, the touch vertebra modifier, to help aid in LIV selection, as I've recommended. Obviously, it's not a perfect method, but I suggest you do draw the CSVL on every single case. See what the touch vertebra is, and then decide: can you use that as your LIV, or can you cheat one level in a mature patient and go TB -1? Or in an immature patient, do you need to go TB +1 to be absolutely safe, so you won't have adding on as the patient finishes their maturation. Again, for UIV selection, both clinical and radiographic shoulder balance helps select the UIV, especially the clinical aspects of that. That's for me a little bit more straightforward, but again, very problematic because it's very easy to elevate that contralateral shoulder, as you know, with main thoracic curve correction, especially now in the pedicle screw era. So in addition to proper UIV and LIV selection, obviously, we do need appropriate correction maneuvers to perform to optimize 3D spinal position and alignment, which obviously is important not only for shoulder balance and adding on, but also pulmonary function and reciprocal changes in the unfused spine long-term in these young AIS patients. So I thank you for your attention. I'd be happy to answer any questions you have regarding this very important topic.
Thank you very much, Dr. Lenke. And, that was like a lifetime's information in just 20 minutes. And that was probably the most valuable 20 minutes any of us have spent. There are huge debates ranging in the chat box. And we'll get to that in a minute. We're just going to take a little more of you. But I've got a question first. For the thoracolumbar lumbar type 5s, some of us, are sort of anterior enthusiasts. And you people seem to have completely moved away from it, which I fully appreciate looking at your results. Are the rules the same for the levels? Or would you still save a level with an anterior?
That's a great question. I was an anterior thoracolumbar lumbar surgeon until 2000. So for 10 years, because I did every type 5 curve anteriorly. And then I started playing around with the posterior approach with those. And honestly, with my goal being I want to do the same levels posteriorly as I would do anteriorly. Initially, I was worried about that I wouldn't be able to do that, but I must thank people like Harry Schuffelbarger and others who were doing this as well. And together we realized that I think if you choose the same levels and do aggressive 3D correction, and sometimes even releases, pontostotomies, even on flexible curves, again, to allow optimal correction, I feel I can do the same levels. Again, some surgeons will maybe cheat even a level at what I would do and go end vertebra -1 and have a little more disc angulation to save another level. Again, personally, I don't agree with that. I'd rather stop at end vertebra, which is my typical stopping point for these curves, and have a near perfect alignment at L2 or L3, typically to the sacrum. But again, that's debatable. But the point being, for my fusion level selection, I'm doing the same ASF or PSF. And that's why I switched all my corrections to a PSF only, because to me, it's just the morbidity is so much less. And that's been proven. There's several manuscripts out comparing ASF to PSF for type 5 curves. And definitely the morbidity and complication rate and the hospital stay, operative time, everything you look at is better with the PSF approach if you're doing the same levels.
The other thing is, although we are all talking about AIS, would age and maturity have a bearing on your selection of levels? I mean, if you are debating about one level less or one level more, would you in a younger patient give the benefit of going slightly longer rather than use the same rule for if you have a 16-year-old and if you have a 14-year-old or
Right, absolutely. Obviously, we'd have to look at skeletal maturity. I think I mentioned that a couple times. I didn't have time in this 20-minute talk to focus my discussion on that, but absolutely, as I mentioned, in skeletally immature patients, however you want to define that, standards 2, 3, 4, Richter 012, patients who have substantial growth left, especially for overhang curves. Peter Newton did a nice service by separating the 1As into Rs or Ls, right? 1AR was a total overhang curve. Often you can have a touch vertebra of L2, but L3 is more stable. In that immature patient, I'm going to L3. I'm doing TV +1 to be absolutely certain that with growth, we won't have adding on. So you do have to pay attention, especially in type 1 and 2 curves, actually less so in type 3, 4, 5, and 6 curves. It's actually interesting, less problematic for adding on when you include the lumbar curve in your fusion. It's much more problematic when you do a shorter thoracic fusion for adding on and problems with maturation and growth with after fusion. So you absolutely have to pay attention to that. I would often extend my LIV selection to TV +1 in that case to stop at a more stable, true stable vertebra selection.
There's a raging debate again in the chat box about screw density, and I'm sure you get that a lot because I've seen your X-rays, and you've really barely missed any pedicles there. And in the chat box, Peter Newton as well confessed. He came to the confessional. He also does a lot of screw density there. And so where are we? Is the jury still out on that, or are you okay? I mean, or is that the rule now?
Again, obviously, my X-rays don't lie. You can see that I'm a high dense surgeon. Again, I agree. If your resources are limited, if someone put a gun to my head and said, I had to do this AIS case with 12 screws instead of 20, could I do that case? Absolutely. Would I get the same exact 3D results post-op? I'm not quite, not only post-op, but 5 years later, I'm not quite sure, honestly. I mean, maybe I would, but to me, I think the issue with AIS is that, our goal should be absolute perfection with no complications long-term. This is a patient population completely different than what Peter Newton discussed in the very beginning, right? I treat AOS patients too, and he was spot on with his talk. I mean, every EOS patient is incredibly unique, right? AIS, it's much more homogeneous, right? And these are healthy patients. So my goal is to have zero complications and get them as perfect as I possibly can. If I'm treating those patients as they were my daughter, right, or my best friend. So again, for me, if I can safely do that, and I think I need maximum screw density, that's what I'm going to do. Obviously, the only way to know what would be best is to do a randomized trial in my own hands, doing maximum screw density and less screw density. To me, ethically, it's hard for me to do that because I'm concerned that I may have, less suboptimal results, sub-perfect results in the less screw density. I may not, but unfortunately, I'm unwilling from an ethical perspective to do that because I know what I can safely do with a maximum screw density, if that makes sense. So I apologize. It's not a scientific answer. I'm a very scientific, data-driven person. The trial that's been finished, the name escapes me. I should know that. The low versus high screw density trial has been finished. And again, from coronal correction alone, they didn't show any difference. But I know that was going to be the case. The question is, and Peter's nodding his head, what about three-dimensional correction? Do we get the same 3D correction that Peter Newton showed us we need to get with less screw density? I'm not sure about that. And that wasn't part of the trial, and that's what I would be worried about, to tell you the truth. So that's my answer. Obviously, that's a great discussion. Resource challenge and screw density to impart the best three-dimensional correction. And we can work on that.
The audience for that from Vishal actually, that was does that impact your rib hump correction as well? Using the high screw density and rotation in 3D. Have you seen that your rib humps are much better corrected now?
Well, again, versus what I did hybrid case photos, yes. I tried to show the radiographic and clinical correction. So my answer is yes, but again, to say that in my hands in 2020, I would have the same rib hump correction if I use less screws, I don't know that answer, honestly. So I'm being perfectly honest. But the bottom line is, I don't want to find out that I was wrong by doing less screws would give less correction, because to me that, I'm striving for absolute 3D perfection on these cases. Do I obtain it? Of course not. But I want it. That's my goal. And I know, and I've been, and then Peter Newton, he's taught us that we have to strive for that. So I've drank the Kool-Aid. And so once you drink the Kool-Aid, it's hard to go back, right? Maybe Peter can comment on that, but that's the way I feel about it.
Is the concern?
I made a very
Peter, sorry.
Just an extension to this. So after your correction, if your rib hump is still you feel intraoperatively that your rib hump is still protruding out, do you make extra attempts to correct it even further, or you would go and take out the ribs, or what is the plan from there?
Very occasionally, what I will do is I'll redo my concave rod. So if I do my 3D correction, and my concave rod is my correcting rod, I think some of the chat things that Peter answered, I use a very stiff, hypercaphatically contoured rod, way above my reduction screws, and I twist the convex side as I lift up the concave side with dynamic translation. If I find that both rods are in, and I still have a large rib hump, what I'll do is keep my convex rod in and redo my concave rod with a different rod that again is hyperkyphotically contoured, and I'll do another correction. Saying that, how often do I do that? 1%, 2%, 3% of the time. I don't do that very often because I've learned now how to really, really overstress that concave correcting rod and really twist the convexity and get the spine where I want to the first time. But I won't hesitate to redo it if I need to, especially in the extreme lordotic. Honestly, I do that more in adults. I do adult deformity surgery. If you think AIS 3D correction is difficult, try taking a 45-year-old adult who has lordoscoliosis that's now 75, 80 degrees with 20 degrees of lordosis. Try and correct that thing. It's nearly impossible. But again, sometimes it's 2 and 3 times correction, honestly. So that's when I more commonly redo corrections is actually in the adult, not in the child.
So I think actually we can have you with us almost forever, and the questions are never ever going to end, since you are the sort of final word in a whole lot of things, and we've got Peter there as well. So we can have this forever, but I have a feeling that we are a bit short of time. There's one question which had come, which actually leads into the next speaker. There's a question about shoulder balance. But I'll hand it to Abhay now.
Two things that we need, one from Dr. Linky and one from both of you. Dr. Lenke, after filtering out so many LIV, ratios, do you still get it wrong?
Oh, you're putting me on the spot. Do I get it wrong? When obviously I'm very, very critical of my results, as we all are, right? We all need to be, because again, as I said, I said I'm looking for perfection. I'd say maybe 10% of the time I look at my LIV results and I say I'm not exceedingly happy that it's not perfect. Interestingly, often we give it time. As you know, the early X-rays, sometimes things do improve over time gradually. The key is if the sagittal plane is perfect, often the LIV will and lower unfused lumbar spine will accommodate over time. As saying that, when is the last time I had to redo a AIS patient for improper LIV selection? I can tell you that. I know for a fact it was 2001. So in my hands, since 2001, I've never had to redo a patient for an improper LIV selection. Again, does that mean I've not had some radiographic adding on and other issues that I'm not proud of? Absolutely. I'm not saying that. But I can tell you that I've not had to redo anyone since 2001.
Lovely. Thank you so much. And Peter and Larry, we want your thoughts on the teether, because we chatted about it on the box, but the audience at large has no access to that chat box. So both of you, what are your thoughts of the teether? Do you think it's going to take us to the next solution to AIS?
Go ahead, Peter. You can answer that more than me, because I'm not a tether surgeon. Peter?
Very good. Well, I've certainly spent a lot of time investigating tethers, both experimentally and clinically. And in the chat box, for those that you didn't see, it's been suggested that it's being heavily oversold and pushed very aggressively in India as well as in the United States. I don't support that concept. I think that this has the potential to be a solution for a very select subset of idiopathic scoliosis patients, those with relatively small surgical curves, 45 to 65 degree. Certainly the thoracic curves more than the thoracolumbar curves have got much more experience right now. And even in that setting, and in particular, those who have 2 to 3 years of growth remaining, in which true growth modulation of the spine to bring it into a set of patients can be and will eventually be able to be reliably treated this way. Today, that's not the case. It's not a reliable solution. It is a solution for people who've, as Larry said earlier, drank the Kool-Aid from the internet. But it is heavily promoted inappropriately, in my view. And we should go slow, continue to collect the data, and develop the algorithms for which patients should be treated with this technique. And it's I hope your country is doing better than ours at managing that onslaught.
Lovely. Thank you so much. We needed to hear that from you, because it is an onslaught. Thank you both for sparing time on Saturday mornings, and you're more than welcome to stay with us. Vishal and Ram want you to stay with us, but we fully understand that your mind is in the hospital. Vishal, do you want to
So yes, please, Prof, if you can stay with us, we will be really honored to have you around. It's only an hour, and then we'll trouble you for today.
No problem.
Lovely. Thank you so much. So while we've spent so much time discussing the LIV and trying to get out of, sparing the lumbar spine, there's one guy from the southeast of Asia who stuck his neck out, literally. Because he put the entire, focus on how the neck tilt matters and how do you leave the neck. And in the end, that's really the part that shows. And I've had innumerable number of people, coming back saying that, I'm all happy, but I'm not happy with this guy coming up and my neck. So that's my dear friend, Dr. Kwon from Malaysia. And he's done such stellar research, and he probably is the Sergei Bubka of neck tilt, because nobody is even, position 2, 3, 4. So Dr. Kwon, thank you for being with us, and I'll hand over reins to you to talk about neck tilt in adolescents with scoliosis. Over to you, sir.
Yeah, thanks, Abe. Thank you very much for the BSS for the invitation. I think it's a great honor for me to be able to share a little of my experience with regard of shoulder and neck imbalance. Can I have the video, please?
Tech team, please play the video.
So there were some questions about medial shoulder height, and they're going to be directed to you, Dr. Kwon.
Yeah, sure. You can add it to Peter and Larry as well.
While the talk comes up, Dr. Lenki and Dr. Newton, there are plenty of questions on the chat box for you. Please, if you can do us the honors and reply and keep chatting with the delegates there.
Dr. Kwon.
Yeah, thank you for your kind invitation. Introduction. The goal of scoliosis surgery is to correct the deformity, to fill shortest, to preserve maximum mobility, and ultimately to create a well-balanced spine. This means a well-balanced trunk, shoulder, and neck, while ignoring the X-ray findings. Most importantly is not to create a new form of coronal deformities. In Lenki 1 and 2, overcorrection of main thoracic curve will elevate the left shoulder upwards, resulting in a disfigured, imbalanced shoulder. Zhang and colleagues published a meta-analysis study that shows the incidence of post-operative shoulder imbalance was 25%. Our group has reported that the PSI patients are aware and unhappy with their disfigurement. To date, these are the recommendations for the UIV selection in Lenki 1 and 2 curve. However, studies done so far have shown that UIV selection have no impact on BSI. Beard and colleagues have reported that they could not identify a set of UIV criteria that accurately predicted BSI. This means that besides UIV selection, there are other factors that determine shoulder and neck balance. Type of shoulder and neck imbalance. Ono and colleagues have reported two distinct types of shoulder imbalance. Lateral shoulder imbalance defined by clavicle angle. Medial shoulder imbalance defined mainly by T1 tilt. However, this observation is based on shoulder alone. If you extend upward, one will notice that the neck is imbalanced too. Our group has reported a prospective study to evaluate the correlation between the shoulder imbalance and the neck imbalance. Our study showed that there is a poor correlation between the medial shoulder imbalance with neck tilt versus lateral shoulder imbalance. These are different entities by themselves. Later, Chu Yung group has also reported the deterioration of post-op cervical tilt can occur in Lenki 2 AIS patients. Currently, we have adequate data to show that shoulder imbalance can be divided into lateral shoulder imbalance assessed by mainly RSH and clavicle angle, whereas medial shoulder imbalance is assessed by T1 tilt, neck tilt is assessed by cervical axis. How to prevent medial shoulder imbalance and neck imbalance? Recent data show we have the solution to overcome this issue. Amil and colleagues have reported a medial shoulder imbalance can be improved by leveling the T1 tilt and first rib angle. We believe the post-op UIV tilt angle plays an important role in leveling the T1 tilt. Instead, our group has reported that the post-op UIV tilt angle is an independent factor which have a significant correlation with the post-op T1 tilt and cervical axis. How does a medial shoulder imbalance with neck tilt happens? This diagram illustrates a scoliosis curve with segmental pedicle screw placement prior to correction. The yellow color vertebra represents the pre-op UIV tilt. Correction on the main thoracic curve will invariably result in UIV tilt to the right as shown in the diagram. This will cause the unfused proximal segment to tilt to the right. If the segment is flexible, then it will be able to compensate and balance toward the center. However, if the proximal segment is stiff, it will not be able to compensate, thus leading to an imbalanced medial shoulder and neck. Silaski and colleagues have reported that a significant correction of main thoracic curve of more than 54%, with simultaneous under-correction of proximal thoracic curve less than 52%, will result in shoulder imbalance in 59%, regardless of UIV. They have recommended that proximal thoracic curve should be carefully scrutinized, especially when the larger correction of main thoracic curve is performed. The question now is, how can we decide on the amount of correction of main thoracic curve? This slide summarizes what has happened. The correction of main thoracic curve and portion of proximal thoracic curve will lead to an UIB tilt. It depends on the flexibility of the unfused proximal thoracic curve to balance back. Based on the above summary, in order to solve this problem, we need to know the compensatory ability of the proximal thoracic curve, and we also need to know what is the optimal UIB tilt angle to allow the unfused proximal thoracic curve to balance back. How to assess the flexibility of the proximal thoracic curve? Our group has published a novel method of flexibility assessment of the proximal thoracic curve called cervical supine side bending. This technique has been shown to be better than the cervical supine flexion radiograph. Following this, our group has further published the flexibility assessment of the proximal thoracic curve above the potential UIB by this technique. In this study, hypothetically, we presume a perfect correction of main thoracic curve resulting in the horizontalized UIB tilt. We use the left cervical supine side bending firm to assess the compensatory ability of the proximal thoracic curve above the UIB. We subclassify Lanky 1 into flexible and stiff groups depending on the side bending as shown. Results. This table illustrates the compensatory ability of all three groups. In Lanky 1 flexible, the compensatory ability is possible from T6 up to T1. This explains why UEV-1 can be chosen as UIV as proposed by Professor Matsumoto. Similarly, it explains why T4 and T5 can be chosen as UIV in certain Lanky 1 curve. In Lanky 1 stiff, the compensatory ability is possible from T3 up to T1. This explains why T3 is commonly chosen as UIV of choice. Lastly, in Lanky 2, the compensatory ability is only possible in T2 and T1. This again explains why T2 is chosen as UIV of choice, and at times, T1 can be chosen as well. In conclusion, the compensatory ability of Lanky 1 flexible is not the same as Lanky 1 stiff. Lanky 1 stiff behaves like Lanky 2 by using the cervical supine side bending assessment. This study serves as a scientific basis that the current recommendation of UIV selection can achieve a good proximal balance in 40 to 85% if the UIV is horizontalized. As shown in the next diagram, I'm going to illustrate what will happen if the UIV is tilted more to the left or right, especially in Lanky 1 stiff and Lanky 2 curves. If the UIV tilt is more to the left, it will increase the compensatory ability of the proximal curve. Whereas, a more UIV tilt to the right will reduce the compensatory ability of the proximal unfused curve. These are some of the figures extracted from literature that illustrates a significant shoulder imbalance occur because of the abnormal UIV tilt to the right. Our group has reported that patients with UIV tilt to the right will have 15 times odds of developing medial shoulder imbalance and 3 times odds of developing neck tilt. How do we measure the optimal UIV tilt angle preoperatively and apply this concept intraoperatively? We have reported that an optimal post-op UIV tilt will prevent medial shoulder imbalance with neck tilt. More importantly, the pre-op cervical supine side bending firm can be used to calculate the optimal UIV tilt angle. This is cervical supine side bending supervised by physician. From this firm, we can measure the optimal UIV tilt angle using this formula. In order to understand this concept, I would like to illustrate using a simple diagram. Assuming blue vertebra is UIV. This is C7. Example 1. This is left side bending. This is right side bending. The red line illustrates the central range of motion. The green zone illustrates the reserved motion of C7 above UIV. This is CSVL. This is C7 located at the center range of motion. In order for C7 to balance back,
the UIB have to be tilted a degree to the left. A degree to the left. This angle is called optimal UIB tilt angle. Because C7 is located at center, therefore, the patient will have a balanced neck and medial shoulder. Example 2. Assuming UIB is tilted wrongly to the right, this is C7. The reserve motion is located outside the central line. This will result in a medial shoulder imbalance with neck tilt as shown. Clinical application. Assuming T3 was selected as a UIB of choice based on the current recommendation. Right side bending. The C7 centroid is located 10 degrees to the right above the UIB. Left side bending. The C7 centroid is located 0 degree. From the calculation, the optimal UIB tilt angle is -5. This means the UIB must be tilted 5 degrees to the left. The UIB tilt before correction in this case is +5 degrees to the right. So the aim of surgery is to create an optimal UIB tilt of -5 degrees to the left. These are our surgical strategies to achieve the more negative UIB tilt. Application of the right rod with distraction of the concave side of the proximal thoracic curve to correct the proximal thoracic curve maximally. Following that, one can let go the correction of the convex main thoracic curve by bending the rod if necessary. Application of the left rod with compression of the convex proximal thoracic curve to correct the proximal thoracic curve maximally. Lastly, one can let go the correction of the concave main thoracic curve by bending the rod if necessary. By using these strategies, one can easily achieve a 10-degree UIB tilt correction to the left. During the surgery, the surgeon can assess the UIB tilt angle clinically at each stage and decide the type of strategy required to achieve the optimal UIB tilt angle. Intraoperative assessment can also be done by using a crossbar. These are the II images of the crossbar. From this image, an UIB tilt can be measured and confirmed so that we can achieve a good medial shoulder and neck balance and avoid this disaster. How to prevent lateral shoulder imbalance? For lateral shoulder imbalance, so far, in my opinion, there is no solution to overcome this issue. There is no way a surgeon can control the lateral shoulder by manipulating the spinal column through T1 vertebra. Lohmann and colleagues have reported that the relationship between T1 tilt and RSH pre-op to post-op did not demonstrate consistency. Brooks and colleagues have reported that selection of the T2 UIB does not guarantee a balanced lateral shoulder. Therefore, there are other factors that may affect the lateral shoulder imbalance. What we know so far is that a short segment fusion can undergo spontaneous development of cosmetic shoulder balance. Tang and colleagues have reported that 93% will regain lateral shoulder balance at 3 years follow-up. Professor Matsumoto has reported that distal adding on may be a compensatory mechanism for this deformity. Conclusion. There are two types of PSI, lateral shoulder imbalance and medial shoulder imbalance with neck tilt. To date, there is no solution for lateral shoulder imbalance. What we know so far from the literature are spontaneous correction can occur during follow-up, and distal adding on might be a form of compensatory mechanism to improve this imbalance. For medial shoulder imbalance with neck tilt, UIB selection is not the most important determining factor, and optimal UIB tilt angle is required to allow the proximal unfused segment to balance back and indirectly leveling the T1 tilt. Preoperative cervical supine side bending firm can be used to calculate the optimal UIV tilt angle preoperatively so that it can be applied intraoperatively. Surgical strategies must be tailored to achieve the planned optimal UIV tilt angle intraoperatively to avoid this complication. Thank you for your attention.
That was absolutely path-breaking research, Dr. Kwon, and it's something that most people are not even, alive to. So while the questions roll in, I'm going to still take the first bite even before Vishal. You talked about the T1 tilt or the UIV tilt rather. Is there any role of UIV derotation that also comes into play when you talk of medial shoulder balance?
The answer is straightforward. No. No, derotation does not play in the UIV tilt per se. So what we know at this point is mainly the coronal plane tilt angle rather than the rotational aspect. I suppose that in the future, people can look at the rotational aspect as well as the sagittal aspect of the UIV tilt.
Also, is there a cutoff for the main thoracic curve apex when you start really worrying about the neck? Like if it's a low apex curve, would you still want to worry about the neck tilt? Or there's an optimum apex of the main thoracic curve where you start looking at the neck?
Not really. I think that the whole idea is a main thoracic curve is nowadays there are more and more data coming out. Silaski and group, I think, have published a very interesting article. One of the co-author of the papers have stated that if you correct main thoracic, let's say 52%, that will result in 60% of shoulder imbalance. So rather than the apex of the main thoracic curve, I think the issue is that how much you correct the main thoracic curve. What happens is that all of us are trained to correct the main thoracic curve maximally without looking into the flexibility of the proximal thoracic curve, like what Reddy had mentioned just now.
Great. Fantastic. Vishal, your question?
Thank you, Prof, for one and force when you are going, your upper instrumented vertebra is going about T3. But there are many curves where your upper instrumented curves or upper UIV ends at T5. And there is still some amount of residual proximal thoracic curve left, like a 15-degree non-structural curve with a tilt at T1. So does all these principles, do they apply there also? Though there is no shoulder imbalance to begin with, but with correction, we saw some amazing corrections by Peter and Lenky there. With all these correction maneuvers, do you fear that the shoulder tilt will appear, which was not there to begin with?
I think, Vishal, great question. I think instead that in these are cases that you need to very worry. The reason being that if the surgeon do not know, the flexibility of the proximal thoracic curve, and you assume that the proximal thoracic flexibility is what you think of, and you correct the curve without knowing the enemy, which is the proximal thoracic curve, that invariably will lead to the medial shoulder imbalance.
Right. Thank you.
So the lower you go at T4, T5, and the more understanding that you need to know about the proximal thoracic curve. So at this point, in our institution, based on the data that we have, we think that the only way to standardize it is by performing a cervical supine side bending firm. The reason being that different centers have different standard of performing a side bending firm. They are standing side bending firm, they are supine side bending firm, and both of them may not able to assess the proximal thoracic curve. But without knowing that the proximal thoracic curve is our main issue when we deal with the AIS surgery. And all time, I think that, as I said, Selassie Group, the conclusion of the paper say that one had to pay a lot of attention on the proximal thoracic curve instead of the main thoracic curve. If the proximal thoracic curve is stiff, and based on your assessment, you have to let go the mean thoracic curve and not to correct the main thoracic curve so much in order to balance the body.
Right. So
thank you so much.
And for the want of time, I'll just, Dr. Peter has another session to join. He just messaged me a while ago. He'll be probably leaving because he's immediately joining there. But before he leaves, Dr. Peter, let me take this opportunity to thank you and also to let you know that the patron of Bombay Spine Society, Dr. V.T. Ingalhalikar, has composed, lyricist and made a music BSS anthem song dedicated to all the foreign faculty members, which we are going to play at the end of this session. We wish that you could have stayed back. But for now, Dr. Ramchadda, to do the honors for vote of thanks, the past president of Bombay Spine Society, Dr. Ramchadda.
Thank you very much, Peter, for an excellent presentation. In fact, these 3 lectures with Peter speaking and then Larry and then Kwan has actually raised the level of this entire deformity session to a level where probably each one of us is glued to the screen. Thank you so much, Peter, for sparing your time. Saturday morning, I do understand that you have other commitments. So stay safe, stay healthy, and thank you very much for being with us. Seeing you soon sometime. Thank you. Namaste. God bless.
Thank you so much. It's great to have been with you, and I'm sorry I've got to sign off I've got another conference call to run, but you guys enjoy the rest of your
dedicated
evening.
To you, Prof.
Thank you.
Over to you, Dr.
Yeah. Thank you, Dr. Peter and Dr. Lenki. We are not letting you go that easily. So that talk was very interesting. I'm sure you heard it as well. And we just like your comments on Dr. Kwan's
again, outstanding talk. The detail involved in the assessment is really critical to me, because you're right. We just can't look at the patient from the posterior view and look at the X-rays on AP and lateral side bending and choose our UIB and say it's going to be perfect, because number one, again, the clinical evaluation, again, is very controversial. How the patient looks from a posterior view versus anterior view as far as shoulder balance can be completely different. We have a publication pending on that. Again, and even the view, whether it's the medial view or the lateral view, can be different as far as which shoulder, quote, is high or whether the shoulders are level now. So it's much more complex than we initially thought. But the more detailed radiographic and clinical analysis that we perform, as he really highlighted in his talk, will only help us give more information to optimize the shoulder balance. To me, the other key is that, again, we have to correct the upper curve. We spend so much time and attention on the main thoracic curve, and just because you select a UIB doesn't mean you're going to have good shoulder balance. You have to also correct the UIB to where you want it positioned. Sometimes that means horizontalizing the UIB. Sometimes it means keeping some tilt to the UIB to optimize shoulder balance. And you have to get intraoperative X-rays to confirm that what we can control, which is the UIB and the medial ribs, top ribs, first rib, that looks optimal. I agree. We can't T1 the first rib angle, and we have to assess that intraoperatively. You can't just guess it and then find the patient post-op. Again, especially if you're doing maximal correction of the main thoracic curve. So this is. Again, if you look critically at all 50% of them have altered shoulder balance. They look great. Everyone's focused on, everyone wants to show the X-rays of complete main thoracic correction, but then the first rib on the left clavicle is high on every X-ray, or 50% of the X-rays. And this is at the SRS, our premier deformity meeting of the world. And so, again, none of us have a perfect solution for this yet. So that's why I really appreciate the depth and detail of the analysis, because that is what we're going to need to give better shoulder balance post-op in our patients. Because I don't want to sacrifice main thoracic correction, because optimal 3D main thoracic correction will give better pulmonary function long-term to the patient if we do it right, correct? We're giving better chest volume. So we shouldn't back off on main thoracic correction to get better shoulder balance. We should figure out how to get better shoulder balance with optimal main thoracic correction. And that's the key, and that's why his lecture was excellent.
Great. So now this is the new thing which we have, shoulder balance, and I will, because we're running short of time, I'm now going to go to introducing the next speaker. Again, it's an extreme pleasure for me to introduce Dr. Neil Anand, because he is not just faculty, he's my dear friend. And most of you many of you may or may not know, but he's a Mumbai boy. And he was at the Nair Hospital where he did his MS, and he was a friend of Dr. Lyris. And then he went to the UK, and then he finally flew to the US, where right now he is the professor of orthopedic surgery at the world-famous Cedars Sinai Spine Center. Now, my friend Neil Anand is a man who is ahead of his time. I used to sit next to him in some kind of meeting over there, and he'll always tell me what the next year's talk. So he's a guy who's 2 years ahead of the others, and he picked on to MIS and these kind of surgeries way before the others, and now he's one of the leading guys with that. He's also the sort of a rock star among spine surgery. So he's a surgeon to the stars. So if you want to see the American Hollywood stars, you just need to sit in Neil's clinic. So he's going to speak about the topic, which is sort of almost the Waterloo of most of us spine surgeons, because I get terrified when I see an adult deformity patient come into my clinic. And hopefully Neil is going to shed some light on adult deformity. So I hand over to the tech team and to Neil. Neil, you're welcome.
Thank you, Samir. It's a really, really wonderful introduction, and I appreciate it. I'm going to share my screen, if I may. And I think...
You can share your screen, sir.
Can you guys... Can you see me now?
Yeah, Neil, we can see you and we can hear you, so you can start your presentation straight away.
Okay, so first of all, thank you, and really appreciate it being here, and a great honor for me to be here. In terms of my disclosures, my topic, interestingly, was, is it worth it, right? Adult spinal surgery, deformity correction. And I'm going to go through a part of the history where we know that pain and disability is what determines adult scoliosis correction, not the actual deformity. And I think that's important to recognize. But on the flip side, though, it is that failure to maintain the cone of economy that drives the pain and disability at the same time. So we are in that quandary where we know that positive sagittal balance, as it gets worse, our health quality measures start dropping down. Now, I will understand that this is definitely cultural, and some cultures are far more stoic than others, but that doesn't deny the fact that your quality of life does come down. It's just that maybe patients are more stoic in putting up with it, and there'll be a certain limit at which they cannot put up with it anymore. So the fact still remains that it does matter what your alignment is, and that drives pain. And it drives it to such an extent, there's a really good paper looking at health impact of adult deformity. It's almost equivalent or worse than many significant disabling conditions. As you see here, if it was primary lumbar scoliosis, it was equivalent to the disability of osteoarthritis and chronic heart disease. If you had primary sagittal deformity, it was equal to less than 25th percentile of rheumatoid patients. If you had severe sagittal deformity, you were equivalent to patients who had less than the 25th percentile in chronic lung disease. And if you had combined lumbar scoliosis and severe deformity, you were worse off than patients with limited vision or limited function of arms and legs. So I think you'll all agree it's a significant deformity that's what is imposed by adult spinal deformity. And yes, I'll admit again, it's cultural. And again, some cultures are far more stoic than others. But I think it's something we need to look at carefully. And it's something that we do need to address. And again, we know that the MCID is different. You may need a higher MCID in an Asian population, as we know how stoic they are, as opposed to the Western countries. But still, it doesn't matter. Our job is to get patients back to their functional quality of life, irrespective of where they are, but do recognize where they are. That's fine. Now, does non-operative treatment work? I mean, there's paper after paper showing no. For adult spinal deformity, every measure and every paper has shown that surgery does better than non-operative treatment for the symptomatic, functionally disabled deformity patient. I think that's important. It's a symptomatic, functionally disabled patient. And so non-operative treatment does not change that at long-term follow-up. And at 2 years, we know that leg pain gets better. There's looking at leg pain in these patients. Surgery helps that leg pain, not non-operative treatment. Similarly, back pain. Surgically treated patients have far less back pain and disability, even though they started off with more actually before the surgery, and still they do better after surgery. So we do make them better. We do not make them worse long-term. It lasts. If we can go 2 years, it lasts 3 to 5 years, unless they develop a complication in that period, and 10% will. So that's important to recognize, though. We need to reduce the complications. So if you have complications, you're going to make them worse as they go on, but a majority do very well. And again, if you look at the quality, we talk of cost effectiveness, right? This is one measure of looking at the quality adjusted life. Again, you get higher mean qualities and larger qualities gained at 1, 2, and 3 year point with surgical treatment. And that again translates to cost effectiveness. there's an incremental cost effectiveness of $27,000 per quality gain, and there's a gain of 0.75 in terms of operative treatment compared to non-operative. And it's cost effective around 3 years, but improves over time, becoming highly cost effective at 4 to 5 years. So we are being cost effective. If you look at it long term in a healthcare system, and this is as treated analysis, 5-year follow-up, again showing the incremental cost effectiveness of $44,000 per quality gain. And we look at the risk benefit though. This is where the problem comes up. With everything we do, there is a risk benefit ratio. And unfortunately, these patients are elderly with significant comorbidities, and this is where our complication rates start going up. It is 71% complication rate in the 65 to 85 years of age. And I think this is what's been driving people away from, if I may. Here's another paper looking at patients over 60, and here's Larry, one of the co-authors. Again, if you look at the complication rates, 37% overall, 20% major, reoperation rate of 33%. 9 pseudoarthroses. But if you look carefully, it's the elderly and it's more osteotomies. As we keep adding osteotomies, the complication rate gets higher, again, based on the severity of the osteotomy or maybe the degree of osteotomy. In similar fashion, here's another paper looking at overall complication rates of almost 50%. We see are clearly increasing that even more as we go in, and it's across the board. Here's a British paper looking at complications. So clearly we're seeing complications with what we are doing, even though we're improving the quality of life and we do it right. But then today we've learned so much more. We know spinal pelvic parameters. We understand what they are. We understand the thresholds we may need to get that correction. And so we know that we want to write PT and a PILL mismatch and SVA, and we learn a lot about it. We know these objectives. But we also know that this changes with age. Here's Larry, 95, told us way back that this does happen. We need to watch it. And we know that we've been chasing this alignment for years. And we got PJK after PJK after PJK in these patients that really is creating what I think, honestly, is an issue, because paper after paper after paper, and we have to accept this is iatrogenic. We create this, and we chase this mantra, if you will, to get this optimal correction, and something we need to look at very carefully. But now we know we need age-appropriate thresholds. We've really gotten down to it, honed down. Elderly patients do not need this massive correction. So I think that's an important aspect that will key into what we need to do as we go on ahead. And we know that we have been overcorrecting. If you look at most PJKs, they generally have been overcorrected for that particular age. And again, we've shown that. So the end of the day, where are we? This is what we tell our patients. And I think this is important. 67.8% will have a major or minor complication, with 47.8% having a major complication. 25% will be reoperated in 2 years. 73.7% will require blood transfusion, and 76% will go to the ICU. And I guess this is what begets the question, is it really worth it? And that's a fair question to ask, right? Is it really worth it? And we know it's disabling for sure. We know it's far more disabling than people without an eye or limb or eye loss. We know we improve the outcomes. We know it sustains for the most part, and it's cost effective, but long term. But it comes at a high complication rate. So should we really be throwing out the baby with the bathwater because we have a high complication rate, when actually we know we're actually doing good work in getting these people a better quality of life? So I would say we need to change our goals. It doesn't have to be this major surgery. It can be a simpler surgery that causes rebalancing. Recognize an older patient doesn't need the perfect SVA. It's not an adolescent. And do not overcorrect that lumbar lordosis, and avoid an osteotomy in elderly patients. I think that's really critical. We don't need to do them unless you're fused. And look at inherent flexibility that you can work with. But when you do an osteotomy, you literally are dissociating the spine, and you pretty much can put them where you want to put them if you're not careful. And what happens with all these angles is we create this hyperangular corrections, which clearly create more problems. I think anyone can see these x-rays and say, this is not physiological. This is not a normal sagittal alignment. And I think we need to recognize that. So why don't we change that and look at ligamentotaxis to achieve harmonious physiological restoration of the spine? You're going to hear this from me a lot. And it should be, I think we can get that minimally invasively, harness the fusion interbody, maximize 4551 where it should be, and then study anatomical corridors with minimal disruption. But it may not be easy. It's hard to get into that small place and create what we need to create, and not many can do it. But if we can harness the technology, we can get there. And why do I say not many? We put this questionnaire out, all the SRS members and the SRS committee, and basically found out that less than 7% would do this patient we presented minimally invasively. But a large majority jump to hybrid, saying they're doing MIS. And then staging, you can see as it goes. The problem with hybrid is, and we've shown it again through the ISSG, it's probably the worst of even open and MIS, where you're creating the worst combination of the two. You had a much higher blood loss. Hybrid was basically doing lateral MIS fusions and then doing open posterior osteotomy and correction, as you would do with an only posterior surgery. So now you added a lateral to an open posterior surgery and compounded the risks, making it bigger blood loss, more OR time, and more complications. So we got to realize where we are, but I guess we fall back to what we are comfortable with. And just because it's easier, it doesn't mean it's better for the patient. I think that's important. By the end of the day, whatever we do will be absolutely minimally effective if we do not know what we are effecting. We have to know what we are doing with these techniques. There are so many techniques available, and we also need to know how to effect the change with these techniques. And these are kind of important things we can discuss later. And so these two really matter, how you go about it. So I can really take you through our universal protocol we've used for all deformities, irrespective of its size, without a single osteotomy. We use it in all non-fused spine patients. And if they're fused, it really matters how many and how many levels are fused. Are there any open discs to access? All these patients have been treated completely MIS without a single osteotomy in our hands. The key is getting an X-ray, of course, looking at the alignment we all know, get the parameters we need. But more important is looking at many other components. What deformity is it? Is it degenerative or idiopathic? Look at the coronal shift, look at the fractional curve, find the tilt of L4-5, because it matters what techniques we're using. You got to be able to see the pedicles to do this, whether it's spondy, rotation. So assess all that and look at thoracic kyphosis. Whereas if it's degenerative, it corrects just by doing a lateral interbody fusion. You can literally throw the screws in and you'll get a great correction. But if it's idiopathic, it does not. It does not derotate. You'll still need derotation translation techniques percutaneously now to correct this deformity. If you throw screws in, it just doesn't work. You still need to access that. And you still can do that without an osteotomy, but you need to understand that that's the issue. Then MRI, we clearly study all the things we talk about. But most importantly, I think, is two things. A sequestrated disc fragment, at least I can't get it through a lateral approach through a tube. So you need to reassess what you're going to do and maybe take that out before you address the deformity MIS. Or a very large central disc, watch it. You push material into the canal. If you go laterally and go posteriorly a little bit. So watch that. But most important is access for me. We decide our access in the lateral position as to whether I'm going lateral to the aorta pre-psoas or going between the bifurcation. But we've been going pre-psoas ever since 2001. 11 never made sense to me. Why did we go through a muscle to do a surgery? It just goes against every principle that we've ever learned in orthopedics. And so we do ACDFs going medial to the carotid. This is no different. We just go to the side of the aorta in front of the psoas, completely minimally invasively in a natural plane. To me, it's an ACDF of the lumbar spine through a 1-inch incision, and it's no different once you know the plane. And these are the incisions we use, single position lateral, 5-1 all the way up for deformities. Bottom one is 5-1, middle is 3-4-4-5, and the top is 1-2-2-3. So basically, we converted an open thoracoabdominal approach, which we all know, into 3 small incisions, but spare the muscle. At 5-1, it's a A-lift in the lateral position. It's the same A-lift between the bifurcation, and we get access there and do our A-lift like we normally would. If you've done your 5-1 there, you then go up and do your 4-5 and keep moving up through these approaches, all minimally invasively. So here's a patient 3-4, 4-5, and 5-1. I can access pre-service, lateral to the aorta, or the bifurcation of that clean plane. But here's another patient at 4-5, 3-4 I can, but at 4-5 it's already bifurcating. You go a millimeter below 4-5, the IVC is sneaking to the left. That is not an approach I'd go lateral to the big vessels, but rather go in between the vessels. And this particular patient is similarly 5-1. So this patient gets a 2-level ALIF in the lateral position. So that's all we look at, whether we're going in between or going lateral to the vessel in the lateral position. CT scan we always do for any suspicion of fused levels. We've stopped doing bending films. These patients don't bend, they hurt. And what happens is you don't know if you got a fusion somewhere. And then you're doing a lateral approach and you're completely going to blow it up. But if you have gas, you know it'll move. It's a very good indicator of hypermobility, and you know this will get height and distance. You want to see osteophytic bridging, so you can plan around it. So you can break that down if needed. You want to know if it's completely fused. You cannot do a lateral at this particular level. So CT gets really important. Bone density, really study it beforehand. If it's highly osteoporotic, we don't do it. We put them on teriparatide or parathyroid hormone analogs. And the reason I do that, I don't wait too long, but I make sure they get it before we do it. If it's 3.5 or lower, I won't do it, and then I deny them at least for a year. So here's a stage protocol we published extensively on it. And it's staged as first stage is all the laterals are done, as many levels as you need, usually 5 levels, 5-1 to 1-2. And then 2 days later, they're up, walking, moving, get an X-ray, check indirect decompression, and then go on to doing stage 2 with percutaneous screw, rods, derotation, translation. And you'll see how this pans out. We do not do an ALR release or an ACR. You don't need it. The only 2 indications I ever have for this are a fused segment 4-1 and do it at 3-4, or a 3-1 fusion, do it at 2-3, if you can get that correction based on the alignment parameters. These are my only 2 indications for an ACR today, and not for the normal patient. So let's go quickly to patients. 64-year-old state attorney, significantly coronally and sagittally decompensated, PILL mismatch. You can see, look at what happens after the stage 1. She's completely unwound herself. It unwinds and reorients the spine just by doing laterals in the sagittal plane. I don't need to go T2 to the pelvis now. This became a T10 to pelvis or sacrum operation right away. And we haven't done a T2 to pelvis in 4 years today for an adult deformity. The only time I do it is there's persistent thoracic kyphosis. The thoracic spine does not hurt as much in adults. And you can unwind this, and you're going to see it repeatedly. Here's the coronal, did not derotate after stage 1, but after stage 2, you can see it completely turned around with correction and derotation. Another 164-year-old retail nurse, female nurse. Again, you see the MRI. And the reason I put this up is osteophytes are bridged there. There's an osteophytic fusion. But this you can break down. You plan around it, osteotomize through it. Here's the interstage X-ray. Same thing. Look at that sagittal balance unwind itself as you create and put the laterals, and you got your sagittal alignment. Again, a T2 to pelvis in my hands 15 years ago became a T2 to pelvis in terms of its alignment and correction, with no need to go up in the thoracic spine. To me, this is the biggest contribution of MIS deformity surgery to this date, and we have a paper coming out very soon. It's a 5-year follow-up on that. Here's another paper, significant coronal sagittal deformity again. Again, here's our MRI. It looks pretty normal, but look at that CT scan. 3-4 is completely fused. 3-4 is totally fused, and the facets fused. I could not do a lateral here, but I can go above and below that and create global correction. Here's a bone density. She was on Forteo. And the key is to get height. Height gives you indirect decompression. You got to work on it to preserve the end plate, get the height, place your prosthesis anteriorly as best as you can to create the lordosis, do your A-lift in the lateral position, concentrating on lordosis at 4-5 and 5-1. And here's our first stage X-ray. Again, significant correction, but not all of it. But look at a lateral, completely unwound itself. We're getting 80% of a correction sagittally on the lateral. 50% of a correction coronal happens at the posterior, by the way, when you derotate and translate. It's the opposite of what people thought in the idiopathic scoli. Then you go back, put your rods in, realign it, bend it, contour it, derotate it, translate it. There is a lot that goes on here rather than just sliding a screw in a rod. And I think that's something that needs to be talked of. and learn. But here's our alignment parameters. Again, this became a T10 to pelvis case and no more T2. And she's now 5 years out with correction both coronally and sagittally. So that again has changed how we go. Here's a male from Louisiana. So this works for every single deformity, irrespective of its size. It's more about how you plan around it to create ligamentotaxis. Here's a 72-year-old with massive deformity. Again, the same thing. You see it time and time again with case after case. And I leave you with this 10 years out, came back to me for a cervical problem, grabbed her for an x-ray, holding up really well. And this was even before we knew what we were doing. And that's 10 years out. But there are numerous technological improvements that have come up, imaging systems that we can now look at directly on a screen to teach, to do, and actually make magnification so much better to look down the tube. Robot navigation systems become immense now. Look at this T10 paraplegic, Charcot joint below, fixed in the past, actually started getting pain, could not even sit in her chair. Here's a CT scan, Charcot joint there. We were able to plan robotically assisted right around the implant without taking anything out. Not one hardware was removed or even exposed. So it's percutaneously cannulated. We did not even use an O-arm spin through a pre-op CT. We're able to segment, correct, and realign these screws in spite of doing a lateral. And here's our x-rays lined up. And this to me is where MIS deformity correction has gone. We actually reduced her lordosis because she does not need it. She sits every day. If you left her where she is, she would have had immense lordosis. And then we now have screw anchors that we're able to get an osteoporotic patients to really get good fixations. The DBM screw anchor that we're able to put in and get the fixation we need. It's 5 times insertion with torque strength. So these technologies have helped immensely. We published immensely on the data over the years in a longitudinal fashion, going on now 17 years, shown that blood loss and the operative time is far less and very commensurate to anything else. The reason we stage is a physiological load is so much less in an elderly patient than 8 hours of surgery. They are much better with 2-3 hour surgeries and what they do. The outcome measures are really good, problems across the board significant, as well as the complications. If you look at the complication rate, you reduce that down to 20% and down compared to what it was before. But we're not seeing catastrophic complications. That's the key. This is all comers. There are no deaths, no major neurological deficits, no major blood losses. We've shown reoperation rates of 3.36% with a readmission rate of 3.3%. We've talked about inadequacies. We've talked about our failures. We've talked about our work as we've come along and where we reached today to why we are today. But I think the key is this I'd like to really talk about, PJK. As we went along, we were not seeing PJKs. And we published this consistently throughout in a longitudinal fashion. And these are all from papers I did 2 and 3 scattering here and there of PJKs. So we went back to look at it, and I think it's important. Age does matter, and we have been overcorrecting. And inadvertently with MIS, we somehow fell into probably the right alignment through sheer ligamentotaxis. Our PJK rate is 7.2 with a PJF of just 2.9%. We went back and looked at every single patient that went back. And what's interesting is this PJK is not what we're seeing with open. These were delayed over time, 18 months, 3 years, 5 years, more due to lack of sagittal balance compensation. Like this patient, with really a flat rod, and they keep falling and decompensate as time goes on and then need a PSO. And that's what we're seeing more from our early patients where we did not get the true correction we wanted, which is not the case today anymore. Here's another patient similarly. This is the sort of PJK we are seeing, not catastrophic PJKs. We want to look at hardware failure or what's happening then. Again, it was interesting. This again is all comers. What I point to is symptom screw loosening and rod fractures. Only 10 patients, of which 9 are asymptomatic. Only 1 patient needed a revision. Every one of them went on to get an L5S1 fusion. These are 5.5 millimeter titanium rods with a rod fracture rate of 2.1%. I think anyone will agree this is ridiculously low, and we got to answer why. And these are the rod fractures, the below L5 or S1. They all have a fusion at 5.1. The incidental findings on CT scan. So if we get a rod fracture of this technique, don't rush to revise it. They go on to heal. And then use a CT scan with fusion. Even despite a rod being broken on both sides. They go on to fuse. And then we're seeing this novel set screw loosening, where the iliac set screw nut comes loose, completely asymptomatic. Again, an incidental finding, so don't rush to heal it. So why is it so low? I don't have any answer, other than it has to be the harmonious physiological reconstruction with ligamentotaxis. There are no osteotomy. There's a rubber anterior column support. These are 5.5 titanium rods. There's no in situ bending. And I think this is something we need to look at. We change the paradigm. And the other big criticism, they're all mild. No, they're not. 53% of our patients have severe ASD by all criteria, show up plus plus or plus 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 if you want. So that's not true. So at the end of the day, though, I think we need to rethink what we're doing. Harness technology, improve our techniques, judiciously select them, pre-address known factors. But the key is let's achieve physiological, harmonious, age-appropriate ligamentotaxic correction, maximizing 4551. And we don't need big rods. Do not do in-situ bending if you can, and preserve the soft tissue. Because then I say, is surgery for ASD really worth it? My mind, a resounding yes. And I must say that and for me is the final word. Thank you so much for having me here. Thank you.
Hey, Neil, that was, could you please unshare your screen? Neil, that was a fantastic talk and you really covered it very well. And it was amazing. And I think I kind of know the difference between American women and Indian women now. I think Indian women like to wear their metal outside, around their necks and in their ears and on their wrists. But the Americans like to wear it on their spine, looks like. So anyway, we are really short of time. Vishal wants to ask a burning question. So Vishal's going to ask you a question and then we're going to go to the next topic. But you please stay around and answer.
So one question for you, one quick one. So age and the amount of correction are both independent risk factors for complications and proximal junctional kyphosis and adjacent segment disease in adult scoliosis surgery. So how do we find the optimal balance of how much to correct and how much to leave behind and yet have a safe correction with less complication rates? Dr. Neil.
No, thank you for that question. That's where ligamentotaxis comes in, right? We actually cannot overcorrect. There is no osteotomy. The only release osteotomy is at the ALIF at 5.1. Everywhere else, there's not a single osteotomy. No facets resected, no ligaments resected. We're doing laterals and increasing the disc space, which will only give you what it will give you, which is about the 12 millimeter height. You don't go jamming bigger cases. I really think that's what's doing it. If you do an osteotomy, you bought yourself you have to get that correct alignment. When you don't do an osteotomy, the spine only gives you what it can give. It literally is having a bunch of blocks in a sock. You straighten the sock out, the blocks will straighten out. I think that's what we're doing. I don't have a better explanation for this. If anyone has a better explanation, I'm all ears and eyes. But this is what we're seeing, and I think it's important to recognize that. We're getting an optimal correction for that patient. And everyone is different without doing the osteotomy.
Thank you.
Right. So now I hand over to my co-moderator Abhay to take this talk forward.
So big meeting where there is. And so may I ask upon Dr. Ramchada to please extend a vote of thanks for Professor Linky, please. Dr. Ramchada.
Thank you very much, Larry, for having come in and spared your time with us. It's been a pleasure listening to you each time. And I even recollect the time when you were unable to come in person because of medical reasons to India. And you shared a lovely talk on listhesis, high grade, and how you do it. And it's always been a pleasure connecting with you. Thank you so much. Do remain healthy, safe, and take care of yourself. God bless you.
My pleasure. Thank you so much for the invitation. Congratulations on a phenomenal conference. And hopefully in the next year or two, we all can see each other live again. So thank you so much. It's an honor and privilege to be part of this session meeting. Good luck with the rest of the meeting. Take care.
Thank you.
Thanks, Larry. Thank you.
Bye-bye.
Thank you so much. So it's clearly been a burning hot session on prime time, and Neil's talk really took it to the pinnacle. Neil, thank you for a wonderful talk, and you've lived your reputation as the heroic surgeon from LA. we move over now to Japan's best export, even before Mount Fuji or Yamazaki comes Professor Abumi. His word, his name, rings out, so many good memories to all of us. He's hosted all of us turn by turn to his place. He's intensely academic. And, even at the tender age of 18, as you can, he is, staying up past midnight in the land of the rising sun just to talk to us about something that he's spoken about years on end, but he still wants to share with us. Abumi-san, Kuniyoshi-san, very, very happy to have you, sir. And it's over to you to talk about the big game hunting of cervical spine.
Tech team, please share the video, the slides. Dr. Abumi, you can share the screen, please. Dr. Abumi, unmute, please.
Do we have this video? Or we can start playing it if it's recorded.
So he's going directly live.
Yeah.
Yeah.
So I have to put my slide here. I cannot move my slide to the
share screen, sir. Share screen. There's a green share screen button at the bottom.
Yes, I clicked. And
press on the share screen at the bottom.
Yes, I pressed. And how to move my slide on the share screen?
So open your presentation first.
Okay. I open.
Yeah, and then go to share screen.
Go to share screen. How to?
Yeah. Just press that green button, share screen, that arrow up. On the bottom of the panel, you can see Q&A, chat, share screen.
That is on the Zoom platform, sir.
Mm-hmm.
It's on the Zoom platform, sir.
Yes.
Where you so there is a green button which is called share screen.
Green button here.
Yeah. Click that. And then there will be a window where you can see your screen.
Yes.
That presentation. Click that window.
Oh. I opened my.
Yeah, and open.
Yes. I open.
And then there's an option called share.
Or share.
Alternatively, we can run the next talk and I'll call up Dr. Abumi and try and sort this out with him. Vishal, does that work for you?
Yes, that works wonderful. So I think we can have Professor Harry's talk first, which is on high-grade spondylolisthesis. And maybe meanwhile, we can set up Professor Abumi's talk while Dr. Abhay liaises with him.
All right. Tech team.
Dr. Schaffelberger here? Is he here?
Not yet. He's not yet joined. We have tried connecting with him. He's still not joined so far.
Right. Anyway,
talk is here.
Yes, yeah. So we'll run his talk. But guys, Dr. Schaffelberger also is another legend. He's like a granddaddy of spine surgery. And I have a feeling he would be retired now. When I say granddaddy, it means that he's the guy who started it all. So the system, which was the granddaddy of all our systems, which is the Moss Miami system. If you know, the Miami of Moss Miami is Schaffelberger. So Schaffelberger collaborated with Professor Harms, who had the Moss, and that started the Moss Miami, and that set the ball rolling for almost anything and everything that we do now. So again, he's a huge legend, and he is, would be the author of hundreds of papers. And let's get the recorded talk running on spondylolisthesis.
Tech team, please play Dr. Harry's video. Please play the video.
Start. Okay, good day, everyone in India.
I'm Harry Schuffelbarger, and the title of my talk today is High-Grade Spondylolisthesis, What's In, What's Out, and What's in Waiting. This is a virtual talk. I wish it were in person. These are my disclosures. Let's start with the definition of high-grade spondylolisthesis, and that's going to be grade 3 by the Myerding classification or greater. Spondylolisthesis is nothing new. This is a before Christ wall painting of the boxing boys, demonstrating a spondylolysis on the left and the typical spondylolisthetic posture on the right. Spondylolisthesis is a combination of the local deformity that we're familiar with, the regional deformity it makes in the lumbar spine, and it makes a global deformity affecting sagittal balance in particular. This is Jean-Marc Macfion's classification of high-grade spondylolisthesis, and it goes from type 1 less severe to type 6 very severe. This article is excellent. And these are the radiographic pictures of high-grade spondylolisthesis from type 1 all the way up to type 6. And we'll touch on treatment recommendations a little bit later. I'm going to make the case for reduction of spondylolisthesis. The reasons to do that are several listed on the left. The reasons not to are primarily higher incidence of neurologic injury, plus it's a very difficult operation. I'd like to observe that any instrumented surgery involves some degree of reduction. Over my career, I've been engaged in a quest for a reduction technique, and I started with halofemoral traction and then cast, going to posterior Harrington distraction instrumentation, anterior posterior resection reductions as advocated by Bob Gaines, and in the pedicle screw era, either Wakame, Steffi, or Edwards, the lever reduction entered. Approximately 20 years ago, Professor Harms taught me his technique, which is what I've employed ever since, and I'll describe in more detail. We should credit Paul Harrington back in the 60s with establishing the pedicle screw, and that was done through his U.S. patent application for use of that in spondylolisthesis. The surgical treatment of this condition should address pathomechanics. And Ron DeWald stated 30 years ago this should involve monosegmental fusion if possible and an interbody arthrodesis and restore sagittal vertical axis, which implies reduction. The reduction of lumbosacral kyphosis is very important to improve sagittal alignment, improve standing, improve fusion rates, and improve HRQOL. And this is documented several places. The uninstrumented fusion is an in situ fusion. And in this instance, high shear forces persist. There's high risk of pseudoarthrosis and progression and poor prognosis. This is an example of a high-grade spondylolisthesis treated with an in situ fusion with further progression to spondyloptosis and a very unsatisfactory result. In 2005, the Scoliosis Research Society made a summary statement regarding spondylolisthesis, and they quoted a compelling rationale to reduce and realign the deformity. Evidence-based medicine, there's a paucity of high-level evidence for spondylolisthesis. Dr. Transfeld quoted 5 comparative studies with decreased pseudo rates with instrumentation, no difference in outcome, and it was unable to formulate clear guidelines for treatment. Longo did another meta-analysis of 8 studies comparing reduction in situ, and reductions had greater decrease in slippage, greater decrease in slip angle, less pseudos with equal neurologic deficits at 8% and good clinical outcomes in both groups. This is back to McFeon's classification, going from less severe to severe, and the higher categories require some type of reduction. And this is a radiographic example. The type 4 and 5A can be treated with a postural reduction, which is simply positioning on the operating table. Type 5 and type 6 require formal reductions and some effort to do that. Those against reduction cite many problems. Perry Schenecker, some 30 years ago, said this is extremely demanding and potentially dangerous operation, and multiple authors report catastrophic injury, nerve root deficits, etc. This is an interesting article backed by Mike Newworth, which is an anatomic study, and he felt partial reduction was safer with correction of lumbosacral kyphosis. And he demonstrated convincingly that correcting the kyphosis is protective of the L5 root. Cal Ming, Dave Pauly, and others from the SRS M&M reports reviewed 605 pediatric patients with isthmic or dysplastic spondylometry. Of those, there was only 62 dysplastic, of which 38% were reduced, which is only 23 patients. They found the complication rate 10% overall and 5% neurologic. Of the 229 reductions in all groups, including dysplastic, neurologic complication rate was 10%. Those not instrumented, the complication rate was not 0, but 2%. And this is my report from 2005, 25 patients with high-grade isthmic spondy, all adolescents, virtually all followed up. About half had some neurologic deficit before surgery, and all had greater than 50% displacement. The surgical procedure I've employed for over 20 years involves a gill procedure with exposure particularly of L5 root, screw placement using reduction screws in L5, adding temporary distraction. The discectomy is done, sacral dome excision. I would then do a gradual reduction using the screws and distraction, place an anterior autogenous graft in the anterior part of the disc space, place the cage, do compression, and do a posterior lateral graft. And this is about a 4-hour procedure. At some point in my career, I changed the instrumentation philosophy using iliac and sacral screws. Distraction should be an integral part of the procedure that serves several purposes. It facilitates L5 placement and makes the disc work easier and the dome excision easier. Distraction is not always easy to do, and it's frequently in the middle of the field. This is an example of a 14-year-old, 100-kilogram girl with high-grade spondy and back pain. And distraction is very desirable because you see the L5 trajectory is very difficult, and it's an even more difficult angle to the L5S1 disc. About 3 years ago, we started employing temporary internal distraction using an iliac screw and a temporary screw in L3. This can be done bilaterally, improves lumbosacral kyphosis, and makes the interdiscal work much easier. And more important, this is well lateral to the midline areas where we're working. It's easy to do, and it's lateral. Neurophysiologic monitoring is an important component. I use stimulus evoked EMG for L5 root, and I will do this multiple times during the procedure. It allows positive identification of L5, which may be difficult, and assures the surgeon of the integrity of L5. Normal root threshold may decrease during the procedure, which is expected. We have never lost a response. This is an abstract of 72 patients with high-grade spondy with intraoperative neuromonitoring by direct nerve root stimulation. There were 2 mild L5 neuropraxias post-op. These had an increase in stimulation threshold by 2.5 times. So I can say unequivocally that the stable L5 root stimulation threshold is predictive of normal L5 function after surgery and highly recommended. Sacral dome resection is an integral part, and this is equivalent to a PSO done more proximally. And this facilitates reduction of the lumbosacral kyphosis. It also is posterior shortening, decreases L5 stretch, and facilitates reduction. Role of instrumentation in high-grade spondy and anterior column support. We can see on this artist conception that reducing the spondy creates a very significant anterior column deficit, which must be filled. And this can be done either from the direct anterior approach, or it can be done by the TLIF approach. So again, the steps in distraction are shown. I generally will remove the L4 screws at the completion of the procedure. This is another high-grade spondy done the same technique. These are the results of our 2005 series of 25 adolescents, and we see significant decrease in the percent listhesis and the slip angle. All existing preoperative neurologic deficits cleared. There were no new neurologic deficits, and the one complication I'll show you. This was an adolescent with high-grade spondy, and very happy with the result. Follow-up shows bending through the S1, S2 segment, which was fully segmented. So this led to my using iliac fixation in addition. Harms in the textbook of spinal surgery reports 112 patients with 3 transient neurologic deficits. My personal series is approximately 100 patients over 20 years, and the data is as reported for the initial 25. There were no neurologic deficits and no reoperations. And one last example, high-grade spondy by the technique which has been described. So in summary, you can do a successful uncomplicated surgery by doing a partial reduction with kyphosis correction, posterior tension band, and anterior column support, and restoration of spinal pelvic balance. We need to identify and protect neural structures. Now, what's in, what's out, and what's in waiting. I use this one patient to demonstrate most of these ideas. This is an adolescent with high-grade spondy, operated elsewhere with a instrumented reduction, which is a reasonable initial reduction. We would predict this would fail, and it did. 6 months later, we see it's worse than we are. The same, and this teaches us that reduction creates an anterior column deficiency, and we need to supply rigid anterior column support. The same surgeon did a revision with anterior column support, and we see that also failed. We need to have adequate distal fixation and correct the lumbosacral kyphosis. And this involves iliac fixation and tricortical screws in S1. And the lumbosacral kyphosis is corrected by rod bending and posterior compression. So when I undertook the care of this patient, this was her radiographic and clinical alignment. She was a very unhappy young lady. Our revision plan was posterior resection of the sacral dome after removal of all the implants, instrumentation L3 of the sacrum, a TLIF L5S1, and we deal with the thoracic curve later. This is the intraoperative pictures and the relatively soon post-op. This is 1 year after the third surgery, pretty good sagittal alignment, the residual scoliosis. And I went to Venezuela and did the scoliosis correction, leaving her with this instrumentation. And this was 3 years after the last surgery, 1 year post-op, and she's now 20 and a very happy young lady. And this is 3 years after that at her wedding in Barcelona, Spain. So always anterior column support at L5-S1 is always in. I urge you to be wary of S1 distal fixation and use iliac fixation. Correct the lumbosacral kyphosis. Always identify the L5 roots by root stimulation and get it right the first time. Revisions are always more difficult. What's in waiting? Navigation-assisted spinal surgery is here, and it's not going away, and it's very helpful in spondylolisthesis. It facilitates screw placement and is very helpful in planning the sacral dome osteotomy. We've now done 6 patients with high-grade spondy in this year using navigation, and it's our feeling it makes the procedure much easier to do. Robotics in spondylolisthesis surgery may be in the future. I really have no experience with this. So I thank you very much for the opportunity to present my thoughts on spondylolisthesis to the Bombay Spine Society.
Okay, I think we've got Dr. Abumi, so we'll just carry on straight with this talk.
Thank you very much for the opportunity to present my thoughts on the Bombay Spine Society.
Yeah,
Professor Abumi, welcome to the final session of the day. Your slides are visible, and now we need to hear you as well. Professor Abumi, over to you.
Okay. Can you hear me?
Yes, Professor, we can hear you.
Okay. I'll talk about the cervical deformity surgery. Anyway, thank you very much for invitation. I appreciate for invitation, and I'm very glad to see many Indian doctors face. Thank you. So this is my first slide, and I talk about the cervical deformity. And okay, shall we now? The scoliosis surgery has developed for the last 50 years, segmental stabilization, and from two-dimensional correction to three-dimensional correction, like this. But how about the cervical spine? Cervical spine also had the deformity, but correction surgery of cervical deformity had been delayed, and one of the challenging themes in the field of spine surgery. Here, this is a textbook by Scoliosis Research Society, and published in 1978, 50 years ago, and there's no description about the cervical deformity. But in major spine meetings, deformity had been limited only for thoracic and lumbar spine. First cervical deformity session or theme in major spine meeting was such as SRS 2009 by Butcher J. He made a session of deformity, but the paper was only 2. And 2010, Ulrich organized the cervical deformity session, but the paper was only 4. In Japan, I used to be a Japanese president of Japanese Scoliosis Society. I made the main theme with cervical deformity in the meeting. We have a two tools for deformity correction in the cervical spine. One is destabilization by spinal osteotomy. Another is cervical instrumentation. We have a 3-grade cervical osteotomy, offering progressive degree of destabilization. Most simple one is partial hysterectomy or discectomy with grade 1. And SPO is grade 2, pedicle subtraction osteotomy. And PSO, sometimes we do at C7 and or T1. This is a less invasive osteotomy, but we can do only for C7 or T1. More invasive osteotomy is PCR, lateral column reduction. we need to approach anterior and posteriorly. Yeah. And Smith-Peterson osteotomy, SPO is simple osteotomy. We can cut bilateral facet joint completely bilaterally to the extraforaminal. And this is simple, but this procedure had a risk of nerve root lesion by iatrogenic foraminal stenosis, especially for C5 palsy. More invasive osteotomy is opening osteotomy, posterior closing and anterior opening. But this is the report, first report was 1958, many years ago. But they did local anesthesia. And Dr. Simmons developed open wedge osteotomy and the surgical correction of flexion deformity of the cervical spine in ankylosing spondylitis for this. This procedure had consisted with wedge resection of the posterior portion, manual correction by anterior opening, and one open wedge osteotomy. But this procedure had a high risk and the posterior hollow cast was required. And shoulder arthrosis rate was very high. And the mortality was 4%, very terrible. And more safe osteotomy was developed in 2000, this century. This is a pelvic subtraction osteotomy in the cervical spine. Dr. Tokara firstly describes the C7 cancellation closing wedge osteotomy for correction of fixed cervical kyphosis. He did not put the name of PSO, but Dr. Zebra put the name of PSO for osteotomy technique for fixed surgical sagittal balance. And he used lateral mass screw and thoracic pelvic screw. And this PSO was only, we can do only at C7 or T1. Less risky for the nerve root. Yeah, another strong tool is spinal instrumentation. In the until 1980s, we have only spinal process wiring or triple wiring by Henry Boland. With simple osteotomy, but not so strong. In the late 1980s and 1990s, the cervical instrumentation had developed. Mangal screw for C1, C2, lateral mass screw, pedicle screw, a constant type of anterior plate, and followed by facet screw and laminar screw in these centuries. Pedicle is the strongest structural element of the cervical vertebra. If we can put the screw to the pedicle, we can expect greater pull-out strength and stability for repetitive loading. We can also expect high correction capability of deformities. Yeah, if patient is flexible kyphosis, we can correct the kyphosis by single posterior approach and corrected by pedicle screw without osteotomy. This is the case of a small girl, 9 years old. This is a post-laminectomy kyphosis intradural extraepidural tumors. This is a flexible kyphosis we manage only by posterior approach. This is a more rigid kyphosis. This case has a spondylotic myelopathy with rigid kyphosis. So we need anterior and posterior approach. Anterior resection of the C3, C4, C5, and the posterior correction. And again, come back to the anteriorly and put the cage or a bone graft, sort of bone graft. We also correct the cervical scoliosis. The cervical scoliosis is a three-dimensional deformity, so more complicated than simple kyphosis. This is a case of post-laminectomy scoliosis. But L5 and 6 nerve root region developed. Very severe radiculopathy. So introduced to us. So we can see very the severe deformity of the facet joint, but we can orient the pedicle screw insertion point after resection of the degenerative portion here. So you can see good correction of the scoliosis. these are different from the thoracic and lumbar scoliosis. In the lumbar scoliosis, the thoracic and lumbar scoliosis, concave side was compressed and the convex side was open. But in the thoracic cervical spine, applying compression force is risky for the nerve root. So only for destruction force must be applied for the concave side. For this case, only for left side. You can see good screw insertion point by CT. We have there is a contributing factor for development of neurological disturbance. If patient spinal canal stenosis, the procedure is managing procedure is decompression. If patient has segmental motion for the development of the myelopathy, we have to do fixation. And the deformity, kyphosis or scoliosis sometimes contribute the development of neurological disturbance. We need correction of the deformity. So deformity correction provides decompressive effect for in some cases. Yeah, this is the OPLL case. Many years ago, 1993, I did laminoplasty for posterior approach. But after surgery, and kyphosis developed, and JOS score myelopathy developed. So kyphosis also developed from lordosis to the 12 degree of the kyphosis. Yeah, you can see spinal cord compressed like from anteriorly. In the posterior, there's space. So posterior decompression again is decompression is non-effective for this case. So I did correction of the deformity, kyphosis. So you can see good correction of the deformity and the JOS score myelopathy improved very well. You can see the good correction and the improvement of disappearing of the spinal cord compression. Yeah, this is a more severe case of kyphoscoliosis. This is the congenital and degenerative kyphoscoliosis. You can see very severe deformity at the lower cervical spine. Yeah, so spinal cord is compressed anteriorly by bony spur at C5-6, and also compressed from posterolaterally by from facet joint C4-5. So I intended, this is my surgical planning. So firstly, I intended posterior correction, and second, I did anterior decompression. Yeah, you can see backward and forward bending with small motion at this kyphosic portion. So I guessed correction of deformity must be possible. But the problem is the pedicle size. Pedicle is very small, very small. So it was impossible to insert a screw. So I put the screw only C1, and I did additional anchor of tape, like polyethylene tape for this, for C2, C1 and C2. And the pedicle screw was inserted T1 in T2. So I did correction of the deformity kyphosis only from posteriorly. And also I did laminectomy for this patient. And deformity was corrected very well. And myelopathy improved very well. So after the surgery, I took the MRI. You can see. And spinal cord compression was disappeared by correction of the deformity, kyphosis. So I think we don't need anterior approach for this patient. So Orthopaedic syndrome is a more complicated deformity of the cervical spine. There's we have many causative disorders. But usually the surgical intervention is difficult for many patients. But if patient had post-traumatic or post-laminectomy, post-infectious drop head syndrome can be surgically managed. Yeah, there's the schema for the osteotomy level for correction of kyphosis and the repositioning of the loading axis for drop head syndrome. This is a model of kyphosis of the drop head syndrome. Yeah, apex of kyphosis is C4-5, and the caudal end of the kyphosis is C7-T1, which level is good for deformity correction of drop head syndrome. If we did osteotomy at C4-5, correction of the kyphosis is good. We can expect sufficient kyphosis correction, but the transposition of the loading axis is not so good. If we did correction of we did osteotomy at C7T1 junction of the cervical thoracic area, and repositioning of the loading axis is well, much better than C4-5 osteotomy. So this is a surgical strategy for Orthopaedic syndrome. Here, I divide the three types. In type A, C7 plumb line is located posterior of the sacrum. So global spinal balance is not so bad. Skull plumb is still anterior of the sacrum, but the global spinal balance was not so bad. So we need, we can correct the deformity, relatively shorter the fixation. So I did C3-6 laminectomy and SPO at 4 level, and C2 down to T6 fixation. You can see good correction of the deformity. In this patient, C5 nerve palsy occur, so I did foraminotomy for this patient, and the nerve root lesion wasn't healed. Type B, in type B, C7 plumb line located anterior of the sacrum. Of course, the skull from the skull, plumb line from the skull is very far from the sacrum. In this case, we need longer fixation than type B. So in this patient, I did long fixation from C2 down to C8, T8. The second type is type C. Type C had C7 plumb line is anterior of the sacrum and very rigid thoracolumbar spine. So if we correct the only thoracic kyphosis, spinal balance is not so good. So we need stages lumbar and thoracic fixation. Firstly, I did lumbar osteotomy at PSO at L2, and the second stage I did C7 PSO at C7, and the spinal balance is much better than before. This is the PSO at C7. You can see PSO of C7 like this. For correction of Orthopaedic syndrome, selection of instrumentation level must be different from ordinary cervical kyphosis. Restoring of cervical or global spinal balance is much important than correction of kyphosis. About the fusion level, instrumentation level, gradually we required from the fusion level up to C2, C3 or more granularly. Regarding the causality, we have to down the instrumentation to upper thoracic spine mandatory. For some case, we need to down the fusion level to the middle or lower thoracic spine. We can consider about the two tools for correction of the cervical deformity. We have a two tools, cervical instrumentation, osteotomy for destabilization, but deformity can be corrected by less extensive osteotomy and strong instrumentation, or more extensive osteotomy and less rigid instrumentation. We can select according to doctor's skill, doctor's experiment, and the patient condition. Here, this is the case from the cervical spine textbook. In this case, the doctor did two-stage surgery of anterior to posterior. So anterior plate and posterior, in the posteriorly, the lateral muscle is not so strong, but we can expect good correction of the kyphosis by two-stage surgery. So in the future, and now the computer navigation system or OARM is developed. So we can expect good and high correction rate, high insertion rate of screw. Also, this tool is expensive and difficult to popularize for very expensive, but I think less instructive for the young doctors. So also aiming device is developed, caliper type or 3D-dimensional printers. We can some company has developed for 3D printer procedure. Thank you for your attention. This is our final slide to my presentation.
Dr. Abumi, thank you so much for taking the time, making the effort. Your enthusiasm to teach us and to be with us is we are truly grateful for that, because you're a one and only in this whole scheme of things. Thank you again from the bottom of our hearts. We've way gone over time and you stayed up the night to be with us.
Yeah.
And so also Dr.
Midnight.
This was indeed a complete top shelf session, thanks to these speakers. And may I hand over proceedings back to Dr. Uday Pawar and Dr. Vishal Kundani to thank our foreign guests and maybe go ahead with the anthem of composed by Dr. VTI. Vishal?
Thank you, Dr. Abhay. It has been a wonderful session, jaw-dropping session. I would say that rather than a head drop, my jaw is dropping, and I'm really amazed by the passion and the enthusiasm with which every speaker has stood by and has given us what we could have learned the most. And how could it have been better that the most senior-most guy is staying awake till the latest hour in the day. It is past midnight for Dr. Abumi. He's the senior-most among all, and his enthusiasm, his passion is just unmatchable. Thank you so much, Dr. Abumi. And with this, I also would like to thank all our academic partners. The day is over, but the session is not. We are yet to enter into another academic day tomorrow morning sharp at 9 o'clock. And I would recommend all of us to please wake up half an hour early and enter the e-poster hall, where again the young Turks are at displaying some awesome research work and awesome papers are at display there. So I would recommend all of you to please join in the auditorium tomorrow and go and see the e-posters there. All our academic partners, I would really thank you all for making this possible. And it doesn't have been possible unless and until we had our patrons like Dr. Ram Chadda, Dr. Arvind Goregaonkar, none other than Dr. Sudhir Srivastava sir, to back this up, to make this day possible, and then for another day to come up tomorrow morning. But the highlight of the day is yet to come, which is by Dr. Vinod Ingalhalikar sir. Thank you so much, sir, for doing this for us. And we are coming up with the BSS anthem. And this anthem will be dedicated to all the foreign faculty by none other than you yourself, Dr. Ingalhalikar sir.
It's been pleasure, and we have been playing with this.
Neetu, we'll have the anthem slide, please.
Yeah. Please go ahead. I'm very happy that this whole faculty deserved something special, and here it is.
So the faculty for the presidential session, this is for you from Bombay Spine Society, sir. Dedicated to you all.
It is automatically, you don't do anything.
Scientists, that's why the surgeon specialists, folks with heart full of empathy, who practice patient care with integrity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society. Researchers we are, academic ambassadors of India we are, talented innovative researchers we are, academic ambassadors of India we are, technology model, everything we are, technology model, everything we are, lauded by academic community, will be futuristic till eternity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society.
teachers, motivated members have vibrant leaders, visionary pioneers and world-class teachers. Motivated members have vibrant leaders. Pathfinder, we find the world. Pathfinder, we find the world. We love them all, we have no enmity. We are a strong bond fraternity. We are the Bombay Fine Society. We are the Bombay Fine Society. We are the Bombay Fine Society. We are the final scientists and final surgeon specialists. Those with heart full of empathy, who practice patient care with integrity. We are the Bombay Fine Society. We are the Bombay Fine Society. We are the Bombay Fine Society. We are the Bombay Fine
So that was fantastic. Thank you, Dr. Ingalalikar, for the fantastic anthem. We all are in debt to you. Thank you, sir. And I guess with that, we end this today's session. Just to remind you that we have a session tomorrow, and we'll have a jam-packed session tomorrow whole day. So please join in at 9 o'clock. May I now request our President, Professor Srivastav, to have a vote of thanks for all the delegates and the international faculty, please. Sir.
Dear friends, I am very happy to accept that today's sessions were extremely good. I thank all the faculties who have participated, all the moderators and conveners of different sessions, all the BSS members and all the delegates. It was a good session, a good first day of BSS conference. I invite all of you for tomorrow's program. We will wait for you. Please join us. Thank you very much. A very good night to all of you.
Dr. Ramchandra, final words for the day, please,
Dr.
sir.
Kwan, Dr. Abumi, Dr. Peter, Dr. Lenki, Dr. Shuffleberger, who couldn't join us because of technical issues. Thank you so much from all of us. Bombay Spine Society stands indebted to you. Thank you.
And great show, Vishal and Uday.
Yes.
Oh, it's all done? Okay, guys, good show.
Yeah.
Sorry we ran grossly over time, but it couldn't be helped.
Hey, it's worth it.
It was a very good, teaching session. In fact, we heard so many new things.
Yeah, absolutely. We learned a lot.
Yeah, extremely well managed.
Yeah. So we are hanging up now. And the same link for tomorrow morning.
Yes,
Vishal, same link. Yeah, same. All right. Good night,
guys. Good night.
Good night.